Yes.
They're happy.
Judge, Dr. Ely's going to rest real quick.
I haven't heard.
Does he know where it is?
All right.
You can pull it around there. I'm sorry. Cleaning crew. You can be seated. Ladies and gentlemen, I hope you had a great weekend. We're going to continue on with the testimony. Ms. Sawyer, call your next witness.
Thank you, Your Honor. State call back Leslie Ely to the stand.
Doc, I need you to raise your right hand. You solemnly tell the truth, the whole truth, and nothing but the truth, so help you God?
I do.
You're going to make yourself comfortable. You've got an aerial mic there in front of you. Okay, I need you to state your name and spell it for my court reporter so she can get used to your diction.
Sure. My name is Dr. Wes Ely, W-E-S-E-L-Y.
Can you hear that, Sam? Okay.
And Your Honor, if we can have the screen down, we're going to need that with them at some point.
Okay. I would have normally put it down earlier, but
I know. Thank you, Your Honor.
what are you going to run it off of? The projector?
Yeah, overhead, I'll be running it off of. Thank you. Dr. Ely, where are you employed?
Vanderbilt University and the Veterans Affairs Administration Hospital, which are both in Nashville, Tennessee.
And what is your position with that?
I'm a professor of medicine at Vanderbilt University, and I direct a research center there called the Critical Illness, Brain Dysfunction, and Survivorship Center, CIBS, SIBS Center. And I, at those two hospitals, teach medical residents, interns, and students, and take care of patients in the medical and surgical intensive care units.
And are you a licensed physician in Tennessee?
Yes, I've been licensed to practice in Tennessee since 1998.
And what education do you have to be licensed as a physician in Tennessee?
I went to medical school at Tulane University in New Orleans, and after that trained in internal medicine at Wake Forest University in North Carolina, and then did a pulmonary medicine fellowship and then a critical care medicine fellowship. And then I trained in lung transplantation at Barnes-Jewish. The fellowships were also in North Carolina. And then after training in lung transplantation, I became the medical director of lung transplant at Vanderbilt University, and then continued on in intensive care for the past 25 years there at Vanderbilt University.
And I'm sorry, sir, did you indicate when you received your licensure as a physician?
Yes, I became board certified in internal medicine in 1993 or 4, and then in pulmonary and critical care medicine in 1996 and 97. And I've kept my, I'm continue to be board certified in critical care medicine. After doing transplant for many years, I just decided I wanted to stay in critical care. So I only maintained the critical care certification at this point. So all I do is ICU medicine. So I just maintain the board certification in critical care, and I'm current in that at this time.
And that licensure and certification has remained consistent since you obtained them?
That's right.
Now, you indicated you're a teacher. Do you specialize in any areas as far as teaching at Vanderbilt University Medical Center?
I mainly teach about how you take care of the most vulnerable people in medicine, the world's sickest patients, those people who are on life support, on mechanical ventilation, on dialysis, people who have a low likelihood of surviving without critical care. And the specific areas that I research the most and care for the most are people who have, well, for example, now in COVID, I'm in the COVID ICU, been in there for a couple of years now, day in and day out with the COVID patients on life support, but also people with severe sepsis, all forms of malignancy, all forms of intracerebral bleeding, all kinds of large vessel bleeding, heart attacks, strokes. And I'm considered, I guess my area, I was trained by one of the fathers of geriatrics. So he always taught me, Wes, how do we take care of the people who are the most vulnerable, that is the elderly, and help them have a dignified dying process. So I really, in the past 15 years, have realized that my job in the ICU is not just providing procedures to help people live, but a third of my patients die by the time they leave the hospital. So I really focus on a good quality dying process, something that allows them to be shown dignity and love during their dying process, and allows them to make as much of a connection with the people that are most important in their life as possible. So for example, during the COVID pandemic, I was one of the main people who argued with the hospital to reopen the hospital for visitation. And my patients were the first ones that got their family back to the bedside.
Now, you indicated that's been a large focus of your research over the last 15 years, is dying with dignity and helping them. Have you published papers regarding that issue?
Yes, and I never intended to make this an area of my field. I was really just kind of interested in how do we get people off of life support faster to help them survive. But what I realized was that I was carrying around a lot of shame because I wasn't focusing enough on
I believe it's non-responsive. The question was, have you ever published any articles?
Yes, and I'm going to tell you how I got to that publication.
Okay, hold on. I get to make the call.
Sorry, you're right.
I'll give him a little leeway overruled.
Okay. So you indicated yes. What got you to that point, Dr. Healy?
So I decided I needed to start publishing papers on what is the appropriate way within the bounds of our legal system to provide good end-of-life care so that people could die with dignity. And what that led me to were papers on the discrepancy between euthanasia and a good, comfortable dying process. And specifically with regard to the doctrine of double effect, for example, and publishing pro-con debates on what is allowable in medicine at the time of death versus not. And so those publications have been a big part of my career over the past few years, as the culture and society has tried to argue one way or the other for legalizing euthanasia.
Now, have some of those research writing included evidence-based practices that are recommended throughout the nation?
Yes. In 2013, there had not been a redo of the clinical practice guidelines for the safe use of sedation and analgesia pain medications in 10 years. So I was one of the main authors on the clinical practice guidelines for the Society of Critical Care Medicine, which is to say that the society that determines the appropriate use of drugs like fentanyl and morphine published their guidelines, which were then adopted throughout the world as the authoritative guidelines on the use of these medications. And I was one of the leaders of the committee to generate those guidelines.
Now, as part of the research in regards to those areas, did it also include research and writing regarding the withdrawal of mechanical ventilators or extubation?
Yes, actually, that's how I got my entire academic career started. The idea of how to safely withdraw a mechanical ventilator has been one that's been debated for many years. And in 1996, I published a paper in the New England Journal of Medicine, which helped to outline the modern day protocols for how to withdraw life support. And so I've been on basically most of the committees, guideline committees, and panels of experts to help teach doctors all over the world how is it that we could most safely remove these machines, both to increase survival and also if someone isn't going to survive, how do we do it in a way that provides a comfortable dying process?
Now, the end of life, obviously, does it touch upon palliative care and hospice care?
Yes, palliative care is an area of my expertise as well. I'm currently mentoring some palliative care physicians, and we're doing NIH, that's National Institute of Health, funded research in the area of palliative care. We are determining the appropriate ways to increase the use of palliative care. I think it's an incredibly important area in medicine that we provide good, safe, and appropriate palliative care to all of our patients who are dying. And this is an area that I'm actively researching, teaching, and publishing in.
In addition to, I think I counted over 300 articles and letters, chapters and books that you've done, including chapters and textbooks, have you taught nationally and worldwide?
Yeah, actually, I have over 500 peer-reviewed publications. And I teach internationally on all continents and travel extensively throughout Asia, Africa, Latin America, the North American region. I'll be going to Brussels in a couple of weeks. And I'm on these, I do that. I don't like being away from family, but I do that because it's important for us to communicate medical advances. And there's really no way to do that without going to the places that are doing the work on the ground and helping one another learn how to do better for other people.
Now, among the topics that you teach on when you travel, does that include the best practices in ventilation withdrawal extubation?
Yes, I'm usually asked to teach on mechanical ventilation itself, withdrawal of mechanical ventilation, palliative use of drugs to keep people comfortable during that process, and to help establish the protocols by which people can approach this safely for people while staying within the bounds of law, but also using science to generate the best foot forward. We can't just wing this. We have to use the evidence. And so I always take an evidence-based approach when I'm asked to give these lectures internationally.
Now, Dr. Ely, in addition to teaching, you indicated you are actually a practicing ICU physician.
Yes, I'm very busy in the ICU. Next week, I'll be back in the ICU at the bedside with my patients, kneeling down, holding their hands, and taking care of them.
Tell us a little bit about your practice in the ICU at Vanderbilt.
Vanderbilt's a very busy intensive care unit. During the COVID pandemic, there were months where it was all COVID patients, but now we've mixed it up. And so next week when I'm in there, I will have probably 20, 25 patients at a time. I'll have medical students, residents, and interns with me, pharmacists, social workers. I make a point to make sure we have the hospital chaplains with us. And so it's a team usually of around 15 people that are going around from bed to bed. And we go in with each patient and their family and round with them for a better part of half a day, and then spend the rest of that day going back to see them again, having family conferences, being with them and doing procedures. But really, it's more about communication and talking than it is procedures for me these days, because I just find that is the most critical part that's missed at the bedside. So many people get a bad example of communication, and then we start missing one another. So that's what happens. It's kind of a very busy 1 to 2 week block, depending on if I'm on 1 week or 2 weeks at a time.
Now, when in the ICU, are there certain tools that are used to determine the pain a ventilated patient might be suffering?
Yes, generally and those guidelines I was talking about earlier are called the PAD guidelines, which stands for pain, analgesia, and pain anxiety, and delirium. And we have tools that are validated for use for pain monitoring, and also for anxiety monitoring, and also for delirium monitoring. And that's been a big part of my career, is developing and validating the tools. When I started this in 1998, we didn't have the tools, but now for example, the main tool used all around the world for delirium to see if somebody's awake and alert is one that I developed called the CAM-ICU, C-A-M-ICU, and it stands for Confusion Assessment Method for the intensive care unit. And that's a tool, all these tools that I've helped develop are translated into over 40 languages and used on all continents to care for patients around the world to keep them safe.
And Dr. Ely, are you also familiar with the Glasgow Coma Score?
Yes.
What is that exactly? I'm sorry, coma.
The Glasgow Coma Score, or the GCS, is a tool that was developed for people with brain injury, like a stroke or a bleed in their head or head trauma. It's not a good tool to be used outside of those areas. So for example, in a COVID patient, we wouldn't even check the Glasgow Coma Scale. We would check instead the tools that I helped to validate, one of which is called the RASS, Richmond Agitation Sedation Scale, RASS. The RASS and the CAM, which I mentioned a moment ago, are the sister instruments by which we measure if somebody is awake, alert, and thoughtful, and uncomfortable. So what we do in the ICU is we couple a pain tool with an anxiety and a delirium tool, and that is our language. When we try to describe to one another how somebody is doing and if they are suffering, we can use these valid tools to try and help understand if they indeed are suffering or if they are not suffering.
Now, you indicated you helped develop the RASS. Can you tell us a little bit about that?
Yeah, I was, at the time in 1998, everybody was using the GCS. And it didn't make any sense to me because the GCS has never been validated outside of a neuro ICU. And the majority of ICU patients aren't neuro ICU, they're pneumonia patients or heart attack patients. So a friend of mine named Kurt Sessler in Richmond had developed this tool, and I called him, and we developed it and published it in the Journal of the American Medical Association, or JAMA. JAMA is one of the top 3-tier journals in the world. Those top 3-tier journals are JAMA, Lancet, and New England Journal. And when we published this RASS tool in JAMA, it quickly became the #1 way to tell if somebody is comfortable and or sedated enough all over the world. And so the basic schema is this.
Your Honor, I think at this point we're unresponsive to the question. I'm going to have to object.
Well, I disagree. I'll overrule.
Okay.
But I'll keep it short. This is relevant, in my opinion, because what we want to do is ask ourselves, is somebody suffering? And do I need to give more medication to cover their suffering? This is the way I practice medicine every day. And the RASS helps you understand that with the CAM and the pain tool, because otherwise I'm guessing. If the person can't communicate to me, I have to have some objective way to measure whether or not I need to give more medication. And the RASS and the CAM allow me to do that along with the pain tool.
All right.
Bottom line, I can work with my nurse.
Okay, hold on.
That's okay. Bottom line is what, Dr. Ely?
Bottom line.
You ask a new question.
Okay. How is it that you or your ICU utilize that tool?
Yes. Bottom line is that I and the nurse at the bedside assess the patient objectively to see if they are still suffering. You might use my arm as an example. My wrist here is untreated suffering. And I use this example a lot with medical students. If I can see my wrist, then there is still a need for more medication. Okay? If I was able to cover my whole wrist, now, and I'm assessing with the RASS and the CAM, these tools, oh, the tool tells me I'm good. This person is now comfortable. They do not need more medication because more would pose a risk for damage to them. It would make them stop breathing. It might make them die. So if I'm untreated suffering, I'm going to increase my morphine or my fentanyl to try and cover their suffering. But if the suffering is all taken care of, sorry for my weird way of showing you, but if the suffering is covered and we judge by these tools, by the RASS, the CAM, and the pain tool, that this patient is not currently suffering, then there is absolutely no reason to give them a higher dose of a medicine and then only cause harm. Because I want to uphold my duty of first do no harm.
Diane, it's okay. Publish first and just put it up. Okay. Your Honor, if I may publish for the
Trying to
jury.
get it up.
All right.
It's showing on the screen here, but it's not going to the big screen. There we
There we
go.
go. All right, Dr. Ely, I'm showing you what's been marked for identification first as States Exhibit 21, and then I'll move it down so you can actually see what it is. Can you identify this for us?
Yeah, that's the GCS.
And explain how this works based upon what we have here.
So the GCS looks at whether or not somebody's eyes are able to open when I tell them to open them, whether or not they have a verbal response if I say something to them without touching them, and if they have a motor response. And again, this tool for you, if I was to measure your GCS right now, if I don't talk too much and put you to sleep, it would you'd have a 15. So the highest is a 15. The lowest is a 3. The lowest you can get is 1 for each. But that tool was not validated for use in patients outside the neuro ICU.
Okay. And then I'm going to go to page 3 of that document, Diane. Can you tell us what this is again, States Exhibit 21? Can you tell us what this is?
Yeah, this is important because this is what the world uses now. The world uses the RASS. And if you look at the positive numbers on the top, this is the tool that I validated and published in the Journal of the American Medical Association. So basically, we look at somebody and we say, are they restless or more combative? Which, if somebody was really uncomfortable and in need of more pain medicine or anxiety medicine, they would have positive numbers there. You see them combative, agitated, restless. You right now are a RASS 0. You're awake and alert and you're calm. That's a RASS 0. And then we have 5 negatives, -1 through 5. Now look on the far right where it says verbal stimulation and physical stimulation. This is really, I hope will be intuitive to you, but if I talk to you and ask you to look at me, I'm not touching you, I'm only giving you a verbal stimulus, and I can tell that you do look at me and make eye contact, then I can rate you as either -1, 2, or 3. If when I ask you to look at me and respond, you do not respond at all, then I know that you're at least -4 or -5 at the very bottom there. Physical stimulation required, and you're either deeply sedated or unarousable. Okay. Now, if you are deeply sedated or unarousable, then there's very little likelihood that you need more medicine, because you're already deeply sedated and unarousable. You're not responding to verbal stimulation. You can't look at me when I ask. And if I even give you a sternal rub or grab your fingernail and punch down as hard as I can, which is very painful, and you have no response, then that's how deep you are in your sedation, illness, whatever. You're basically, we call that a coma. So -4 and -5 is essentially coma. And then -1, 2, 3 is various stages of deep sedation. It would be really rare, almost unheard of for me, to give higher doses of medications when somebody is already in a coma.
All right, Dr. Ely, what type of medications are you talking about there?
Generally, I'm talking about drugs like narcotics or sedatives like benzodiazepines, Valium, midazolam, lorazepam. These are benzos, or you might know them as sleeping drugs, like Valium, like an anxiety drug. But there are other types of benzos that are more strong than that we use through a vein, and one of them is called midazolam. But the narcotics we generally give in the ICU are either morphine or fentanyl. And we would give morphine or fentanyl through the vein if their RASs were in the positive range, or if they were 0 or -1 or something. We would not want to increase the dose of those drugs if somebody was -4 or -5, because A, their pain is already covered. They don't have untreated pain and suffering. And we don't want to get the negative, the bad effect of the drug, of those drugs, fentanyl and morphine, which is to stop you from breathing.
Dr. Ely, there's another document we've heard reference to called the CPOT. Are you familiar with that?
Yes. Remember I was saying earlier that the guidelines were called the PAD guidelines, which stands for pain, anxiety, and delirium. So I've covered for you the anxiety and the delirium portion with the RASS and the CAM. We didn't cover the CAM yet, but that's a way to tell if your thinking is clear or not. But the P part, I haven't covered that yet. So the P part is, are you in pain? Now the RASS kind of does get at it a little bit, because if you're in pain, you're probably going to be up there in the pluses. But it's possible to experience pain and not be in the pluses. So therefore we have a CPOT, which stands for Clinical Pain Observation Tool.
And how is that used, sir?
The CPOT is a 0 to 8 tool, and when people have CPOTs in the 4, 5, 6, 7, 8 range, we judge that they are in pain. And so if somebody had a CPOT in those high ranges, we would want to give more pain medicine. But if they were down in the 0, 1, 2, or 3 range, we would judge that they didn't need more pain medication. So for example, if a nurse told me Mrs. Smith's CPOT is 3 and her RASS is -1, I would think she's not in pain and she's lightly sedated, a little drowsy. So she says those numbers, I can hear it as, how is my patient doing?
All right, I want to direct your attention up here. This is the back part of State Exhibit 21. Can you identify those for us?
Yes, these are the ways of the CPOT. So what we're doing is we're looking at the human being, because the whole idea is I'm there to serve them. So I want to know, am I serving you well enough? Are you tense? Are you grimacing? Are you protecting yourself? Are you restless and agitated? And if you're on a ventilator, one big sign of pain and discomfort on a ventilator is when you're, what it says at the bottom down there, where is it? Yeah, ventilator tolerance. Are you coughing? Are you fighting the ventilator? And we can tell if somebody's fighting a ventilator, because if I give you 10 breaths and you just take the breath, inhale, exhale, inhale, exhale, inhale, exhale. If you flow along with the ventilator the way that I told the machine to breathe for you, then you're not fighting the ventilator. But if every time I tell the ventilator to give you the breath, you exhale and fight and jump around, then I can tell, well, something's not right with Ms. Smith. She's very uncomfortable. Maybe she's in pain. And that's part of the CPOT.
And this goes up to a score of 8, you indicate.
That's right.
And it's structured according to how this is laid out?
Exactly. And what we do on rounds is that the nurse assesses each patient.
Your Honor, the question was, and this is structured as this, just responsive, please.
Okay. Sustain. Start line of question.
How would this be used in your ICU?
So what we would do on rounds is that I came up to the patient's bedside, and the nurses will usually have assessed the patient already, and they'll say, Dr. Ely or Dr. West, the CPOT today is a 2, the RASS is a -1 or 0, and the CAM is positive. And that gives me those 3 pieces of information. Are they in pain? Are they anxious? Where are their levels of sedation? And are they delirious? And with that, I can get a clinical picture of what's the degree of suffering that this person's enduring right now. And then we as a team will change our medication plan to try and meet their needs.
Now, just something that you just said, are these tools used alone or are they used in cohesion with each other?
They have to be used together. They're siblings. I'm not going to take care of your pain and not pay attention to your anxiety or delirium. I'm not going to take care of your delirium and ignore the pain. So I'm trying to get a whole picture of, is my patient suffering? And if they are, I'm going to increase this medicine because I first and foremost want to make sure somebody's not suffering. And if they aren't suffering by these valid tools, which we've studied in thousands of patients, then I'm going to make sure that we maintain that and reassess them every 4 hours. And time is on our side because I can always go back and reassess them again and get more information from the nurses.
And Dr. Ely, these 3 tools that I showed you, the Glasgow Coma Score, the RASS, and the CPOT, those are commonly used tools within your business.
Yes.
And what I just showed you are true and accurate copies of those tools?
Yes, they are.
Dr. Ely, you mentioned that typical drugs that you would use in the course of the ICU are morphine and fentanyl. Tell me a little bit about that use.
Yeah, these are really, thank goodness we have these drugs because they allow us to alleviate the pain that somebody's having, and they allow us to do it safely if we use the right amount. The important thing about that is that each individual person has to be cared for under their own circumstances. And the downside of the medicines is such that I want to make sure that I do good and not harm. The downsides would be, minor things like constipation, but major things like stopping you from breathing and causing you to go into shock and stopping your heart. And we know that narcotics, when given in too high doses, can cause cardiovascular collapse or a drop in your blood pressure and shock, but and very, very predictably can stop you from breathing. So if somebody's not on a ventilator, for example, I need to make sure that I start low and then work my way up.
Why is that important, sir?
Well, it's important because my oath is first do no harm. And if I want to do good for somebody, but I know that a medicine can also do bad, then I'm going to err on the good side and then work my way up so that I'm doing good, good, good. If bad's up here, I don't want to start up here with bad, because my goal is to help somebody and never to hurt them. And so I can start low and go high. And what we do in the ICU is I'm up there all day. So we give a medicine at 9 o'clock, a little bit. And we come back at 10 o'clock and give some more. So we commonly give them medicines each hour.
There's an objection.
10 thing is to responsiveness. The question some time ago was explain how morphine fentanyl use.
Let me take a spin here. Doctor, I know you've got a lot to tell us, but we do it by question and answer.
Okay.
Like your procedures in the hospital, these are ours. So let's let her ask you some questions and we'll work it that way. Fair enough?
Thank you, Judge.
And you just said something about that. Now, we've heard on fentanyl several times, there's no maximum dose medically. What are your opinion on that?
There is a maximum dose of fentanyl.
Your Honor, I would just, sorry to interrupt, but I'm not sure the expert has ever been officially tendered.
Okay, well, you better go sidebar before you go there. Ladies and gentlemen, let's make yourselves busy for a second. We'll be right back with you.
You already CDC guidelines.
Yeah, they just came out. I know.
Later for, later snack. Oh, yeah. Well, they must get really dirty. You guys doing okay?
We're waiting on her, guys. We'll worry about that. It's okay, no pressure, Sam. You're fantastic. You're wonderful. And you're bound up there.
Make sure I write that part down.
No. Unless you want to, I don't care. You ready?
Yes.
Do you want to give the question again?
Certainly, Your Honor. Dr. Ely, we've heard from other individuals that there is no maximum dose of fentanyl. Can you give us your opinion on that?
Yes, the maximum dose of fentanyl or effective dose of fentanyl is when the harm outweighs the good. And that gets back to the notion that there is a way that I can hurt you with any medication. And since I don't know your individual maximum, and because the maximum is so dangerous, i.e. that it would stop you from breathing, I have to stay way away from that ceiling. which is why we start lower and work our way up rather than risking hitting or exceeding that ceiling. That's how we do the maximum dose.
Now, you indicated that the ceiling could cause you to stop breathing. Are there common side effects that could be suffered from a larger dose of fentanyl?
Yes, the common side effects would be a drop in your respiratory rate or the size of your breathing, or completely stopping breathing at all, meaning no matter what, your brain is going to not tell your body to breathe. Because the medication impairs the respiratory center in your brain, the most basic part of the brain which tells you to breathe. So if the medicine hits that respiratory center and tells you to stop breathing, then the way that it will stop you from experiencing pain is through dying and no breathing. And that is the circumstance where we say that the bad outweighed the good.
Do you have an opinion as to whether or not fentanyl used with elderly patients is good or bad?
Fentanyl can be safely used with elderly patients, and I do it. I do it making sure that I stay way away from that ceiling. Usually, for example, I would give doses of 12.5 micrograms, 25 micrograms, maybe 50 micrograms of fentanyl in a single dose, and then repeat that dose if the tools that I have tell me that there's still ongoing pain and suffering. So I would go 50, if I was at 50, then maybe an hour later give another 50. And over a period of a day, I might give 24 doses, all one at a time, making sure that I stay down here in the area of good and never cross that bright line of I'm causing harm now. And that way I can give the medicine safely, keep the person comfortable, cover their pain, and make sure that I never cross over the line of causing them to stop breathing and endanger the natural life that they have been given.
All right, so you just said you might in a 24-hour time period give up to 1,200 micrograms of fentanyl. Would you ever give that all at once?
I would never give that all at once.
Why not?
Well, it's a breach of standard of care for one thing. The medical literature is very clear on the types of doses that we give for patients who are underneath the care of palliative care. I am, by the way, a primary palliative care doctor. I can also get people who are secondary specialists in palliative care, and the literature shows us that the amount of medicines that people at the end of life get is on the order in 24 hours. And these are the types of patients that I treat with severe sepsis, COVID, cancers, whatever, on the order of around 25 milligrams of around on the order of within 24 hours of 200 milligrams of morphine over a 24-hour period, which would be in the neighborhood of maybe 1,000 to 2,000 micrograms of fentanyl in a 24-hour period. Divide that up by 24, and you're talking 2,000 divided by 24, you're less than 100 micrograms an hour. So that's why I was saying before that we might give 50 to 75 micrograms of fentanyl an hour on average for dying patients. I have given max ever over that 100, 150 micrograms of fentanyl in a single dose. The highest dose of fentanyl I ever gave in a single dose was 200. And it was to a person who had been receiving fentanyl for 10 days hourly. So, and they had evidence of ongoing pain and suffering from cancer in their bones, broken bones. But I would never give over even 300 micrograms in a single dose for fear of killing them.
All right, now you just indicated the largest dose you gave was because that patient had been on fentanyl for several times. Is that what we call opioid tolerance?
Yes, when someone is given opiates over a period of days, their body builds up a tolerance to the medication, which then allows them to receive a higher dose without stopping breathing. And that does not accrue, that tolerance does not accrue in hours, it accrues in days. So I don't escalate the dose largely in a matter of hours. I always go very slowly increasing. For example, I might go 2 milligrams of morphine, 4 milligrams of morphine, 6 milligrams of morphine, but I'd always give 2, 2, 2, 4, 4, 4, 6, 6, 6, and spread this out over a period of days before I would ever get up to 20 milligrams of morphine. And the way that morphine and fentanyl are converted is by a factor of 10. So 10 of morphine is 100 micrograms of fentanyl. It's different units. 10 milligrams of morphine is 100 micrograms of fentanyl.
And so I'm going to direct your attention to the screen. And I'm showing what's been marked for identification as State's Exhibit 19. Is that essentially what you just said?
Yes, look at the second row, which says fentanyl 10 micrograms is 0.1 of morphine. I think it's easier just to think of it as 110.
Okay, hold on. Can you guys see that?
Conversion.
Or do you want
A little bit,
Enlarge
zoom in.
And one.
to zoom it in?
I'm working on it. How's that?
That actually, is that morphine equivalence? Let me see.
Hold on. Can you guys see that better, or do you need it bigger?
So State's Exhibit 19, this would be a conversion chart, and is that to a reasonable degree of your medical certainty?
I'm looking for the morphine.
I believe it's under hydromorphone is what they're talking about, and then.
Oh, equivalence of morphine. I see. Yeah. Oh, I see. Okay, yeah, that's right. Yeah, so that factors what I just said. Yeah, 10 and 100. Yeah,
Okay, and that's to a reasonable degree of medical certainty?
it is.
When we're talking about opioid tolerance, how does a drug addiction, street drug addiction, factor into that in your practice?
Well, if somebody was a chronic, if somebody suffered from addiction, then they would accrue tolerance over time. Unfortunately, I don't know if I'm allowed to keep going with that, but street drug people who are suffering from addiction still die readily when they overdose on a given medication. And right now in our country, fentanyl is the main thing causing most of the deaths that I care for in the ICU. When patients come in overdosed and have had a stroke or brain dead, it's usually now because of fentanyl.
So how would that affect the ability to administer medical fentanyl to a drug overdose who overdosed from fentanyl?
Would you mind rewording that?
Sure. How would that affect your practice if they're on a ventilator, they're in your ICU, you know that they've overdosed on fentanyl? How would that affect what you give them as far as medication while they're on the ventilator?
Well, I wouldn't, if they'd overdosed on fentanyl, I wouldn't give them more fentanyl right then, obviously. I would try and achieve the covering of their suffering by some other medicine, because I don't want to continue to pile on to the problem they already have. Is that an adequate answer for you?
Sure. What if they've overdosed on other drugs, like cocaine?
Yeah, anytime somebody has overdosed on a drug, I try and avoid that same class of drugs as I'm caring for them until I know that that drug is cleared out of their body.
And how would it get cleared out of their body, sir?
The kidneys and the liver generally clear the drugs. Fentanyl has a half-life of a couple of hours. So when I give it, it's going to last not for days, but it's going to last for a couple of hours. And that's why we dose it hourly or every 2 hourly.
All right, now you just indicated it is assimilated through the kidney and the liver. What if there's damage to those organs?
If there's damage to the organs, depending on the drug, because some drugs are more kidney cleared and some drugs are more liver cleared, but we try and pay attention to whether or not somebody has those organs damaged, and we would have to use much lower doses. If they had like kidney damage, we'd have to use much lower doses
Why is that, sir?
because the drug will build up much faster and the toxic effect of the medication would be more profound if we don't factor that in because they have no way of clearing the drug.
Now, Dr. Ely, we've also heard the term chest rigidity used with fentanyl. Are you familiar with that?
Yes, if we give a high dose of fentanyl, think 500 micrograms or more, then the person can get chest rigidity, meaning that they can't breathe. So now you have a second cause of suffocation, is that one is the brain is not telling them to breathe, but the other one is that physically there is this extreme chest rigidity. And so that's another reason why I don't want to get anywhere near those sorts of doses.
What about the use of fentanyl in the extubation, palliative extubation? Have you ever done that?
Yes, I have. When I am extubating patients and have made an agreement with the families on the patient's behalf to keep them comfortable, I want to make sure that I give them drugs that will make sure they're not short of breath. So narcotics have a beauty about them in that they relieve us from feeling short of breath if used in low doses. And when somebody is taken off of a ventilator, I will commonly give them a narcotic so that they don't experience suffocation as they're dying. And the doses that I would give that in would be something like 50 micrograms of fentanyl, maybe 100 micrograms of fentanyl. And that way I'm only treating the suffering of the suffocation, but not crossing over into the badness of stopping them from breathing. So it's that tightrope, that delicate balance that I want to walk with them to do them good and never to harm them.
Now, doctor, obviously you've done palliative withdrawals, extubations in your practice,
Thousands of times.
and you've actually developed evidence-based protocols for such.
Yes, we have a very standard way of withdrawing the life support. We never say withdraw care because we're never going to stop caring for this loved one, but we do withdraw support. And we withdraw support by pulling the tube out and providing them, assessing them objectively with the RASS and the CPOT and the CAM if they're suffering or not. And as we're pulling the tube out and we watch them carefully, we see, are they suffering? And usually over the ensuing 12 to 24 hours, we will give them doses of medications if we see any suffering. If we don't see suffering, then we don't give them those medications because if there's no suffering, the medicine can only harm them. Another way of saying that is if the medicine can't help them, it's only going to hurt them.
So can you give us an example of how you would do a palliative extubation as far as what medication you would use, how you would approach it, that type of information?
Sure. I would work with the nurse and the team, these many people I've got, and we would address a human being as mind, body, and spirit. So we would address their cognitive issues and suffering, their body and their spirit. So we would make sure that the body and mind were addressed with morphine and fentanyl, morphine and maybe a small dose of a benzodiazepine. And so I would say to the nurse, let's give them 2 milligrams of morphine and 25 or 50, and maybe 2 milligrams of a benzodiazepine, Valium or midazolam. If they were on fentanyl, I might say, let's give them a dose of 50 micrograms of fentanyl and 2 milligrams of a benzodiazepine. And we can repeat that dose every hour as you're watching them very carefully, depending on if they are exhibiting a rise in their CPOT. Their CPOT goes from 2 to 7. Oh my goodness, no, they're in pain. Let's increase that fentanyl. Let's go to 100 now. At 9 o'clock, we gave them 50. The CPOT now has gone up to 7. We need to go up to 100 of fentanyl now. So let's double that dose. And it's all through the medical literature shown that the way that we do that commonly in the last 24 hours is we will often double and sometimes even triple the dose. So I might go from 50 of fentanyl to 150 of fentanyl. And that's well established as the right way to do palliative care.
Does it make a difference if that patient is conscious or not as you withdraw them from the vent?
Either way, I would take the same approach, but usually it's just that the conscious person will be more likely to be able to express to me or show to me that they were suffering. The unconscious person, since they can't, that's why we want to use the tools. So when the unconscious person, super important then to use the CPOT and the RASS, because they can't tell me, but I can watch their respiratory rate. I can see if they respond to verbal or if they're grimacing and such.
Do you give pain medication in the anticipation of pain that's going to occur with extubation?
Well, we do try and stay ahead of this. So we don't wait until they show pain, but we don't try and jump too far ahead either. So there's this balance. It's all about judicious use of the medicines. And what we talk about, what I teach the medical students is, don't let someone develop a huge amount of suffering, but the easiest way is to give little bits to stay ahead. If this is suffering and this is the medicine and their suffering is increasing, I'm gonna stay just slightly ahead, but I'm not gonna do this. Here's suffering, here's the medicine. I'm gonna stay right ahead of it. And I can do that. We do that every day by just watching the person very carefully.
Why don't you jump ahead to the high dose?
Because I'm trying to do them good. So here's their suffering, and here's the medicine coverage of the suffering. If I stay like this and dose them every hour, then I never jump up here, which causes them to stop breathing and ends their life. It's the difference between, what I'm trying to do is allow the person to die of their natural disease process. Because I am never there to deliberately shorten their life. I don't want to make a somebody into a nobody, okay? I want to allow their natural disease process to take its natural course, and that is like a candle burning out, okay? I'm not trying to blow the candle out. And if I jump up ahead with the medicines, now I'm blowing the candle out, and that's not my right, and it's illegal.
In your opinion, is a palliative care extubation ever an emergency?
It's never an emergency because what we're trying to do is get all of an assessment of what this human being wants, what matters to that person. So we have to be cautious and careful and talk. And they're already on life support right now. We've already got them covered with some form of medication, and we're already watching their suffering. All we're trying to do is, everything is stable, all we're trying to do is say, when is this life support now not meeting the requirements of this person's preferences? And if we think that the person would no longer want that life support, then we, in respect of their wishes, will remove that life support, but it's not an emergency. We have to make sure we get it right. And so we take our time. And we almost never do that in the middle of the night.
Why not?
Because in the middle of the night, families are suffering. The family is suffering. The family is hurting. They're scared. They are in physical and existential pain. So we want that family to be at home, resting if possible, or asleep in the bed next to their loved one. And I don't know what sort of conversation or things that family needs to say to their loved one to help them heal. So I don't want to rush that. And I don't want to do it under the cloak of darkness. I want to allow people to get their sleep. I want to allow them to have the sun up and to be present with their loved one as the dying process goes. And that if we do it at night, it makes it seem like there's some sort of urgency. And then what happens is the family doesn't feel comfortable communicating that love. I've seen relationships rebuild and reconcile even when it's only a one-way conversation. I want to allow that to take its natural course.
What if the family comes to you and say, I want to do it now? Now, doctor, now.
If the family wants to do it right then I try and respect them, but I find out, is this in keeping with your loved one's preferences? And what changed that makes you feel like this is urgent? And so I still try and instill back into the conversation some degree of a pace.
and that's something that comes up. What is your obligation as the physician to the family when you're in the middle of a palliative extubation?
I am there to serve the patient, and in so doing, I must serve the family. So I'm of service to the family.
And when you say you're going to service the family, if it comes down to something that's best for the patients versus best for the family, what's the overriding factor that you have to look at?
What's the best interest of the patient?
And why is that, sir?
Because I am that patient's physician, and it is my duty as a healer to be present with that person to serve their needs, whether it be a comfortable dying process or a curative medication or procedure. They're my primary obligation. The reason I said earlier that I'm there to serve the family is that the patient is oftentimes not able to communicate to me, so the family is my conduit to understand how to serve the patient.
Now, the drugs you administer, what is the purpose of those in palliative extubation?
The purpose of those medications is to try and mitigate or reduce suffering, reduce human suffering.
And we've had some testimony about the synergistic effect of opiates and benzodiazepines. Can you explain that to us, please, sir?
Yes, all that means is that if I give you fentanyl, there is some degree of suppression of your brain telling you to breathe. But if I give you fentanyl and a benzo, or for example, midazolam, it's not just additive, it's exponential. The brain is now getting pummeled in two different directions by two different chemical compounds, telling the center in the midbrain to say, don't breathe anymore. Don't stop, don't send any signal to breathe. And so it's very dangerous to give both medications if we don't monitor the person carefully. Now I do it, but I do it, as I said earlier, very low doses, and I grow it over time, but I would never start high because I would think that I'm going to achieve that ceiling and cause some harm, like death.
Now, there's been also some discussion in the courtroom about opiates hastening the death of the patient in a palliative extubation. Can you talk about that?
Yeah, generally, we do not think that opiates hasten death when they are used in the right doses. If you read any article about palliative care and opiates, most of the articles are actually geared towards making me comfortable to give the opiates. And this is something very important. In the 1990s and early 2000s, there was a general fear of doctors giving opiates, and people died suffering. And that was wrong. And so lots of articles, including investigator friends of mine and ourselves, wrote papers to say, don't be afraid to give these drugs in doses of 2 milligrams, 10 milligrams of morphine, 50 milligrams of fentanyl, 100 milligrams of fentanyl. These doses help people to die comfortably. So the literature is filled with directives that say narcotics don't increase the likelihood of dying. But none of those articles are using doses of 500 micrograms of fentanyl, 1,000 micrograms of fentanyl, 1,500 micrograms of fentanyl. Those are never used in clinical practice to mine. I've never done that in my whole 30 years of practicing medicine. I've never given a dose of this drug like that. And the reason that none of us would do that is that we know that there's no clinical benefit at that circumstance. We can achieve the goodness that we need to achieve at much, much lower doses and keep the person safe.
Now, Dr. Ely, some of the things that have been discussed that could cause pain to a patient for palliative extubation would be a high lactic acid or acidosis. Can you tell us about that?
Yeah, if you exercise and you build up lactic acid in your thighs hurt. It's what stops somebody from running faster. You know, the lactic acid builds up. And in the ICU, patients do get lactic acid. That is not the way we measure if they're in pain from lactic acid is the CPOT and the RASS, you see. So we don't need a real-time lactic acid level to tell us if they're in pain, because we have these valid tools which allow us to do it right then and there. So I would never say to the nurse, what's their lactic acid? I need to know if they're in pain. No, because I would say instead, what's their CPOT? What's their RASS? If that CPOT's rising, we need to give more pain medication.
What about if they've been administered CPR? How would that affect their pain level?
If they had CPR, then they have what we call a nidus of pain, a source of pain, because they could have had broken ribs or something. But again, we go straight back to where's their CPOT, where's their RASS, because I don't know. So I need this objective information, and that's what we need in times of confusion is how do I get recentered to know what I'm doing? And the RASS and the CPOT are like our compass. You know, if I want to know where I'm going with this person, then I need to have my compass. And these are the clinical bedside evaluations of each patient that I care for.
And the pain medication you're giving, is it there to help treat the respiratory distress when you remove the ventilator?
If the person starts breathing really fast and appears short of breath, then I would assume that they are sensing the suffocation. And then I would respond by asking the nurse to give 50 to 100 mics of fentanyl and maybe 1 or 2 milligrams of a benzodiazepine. And that would keep them calmer and make them not aware of that suffocation. But that's a low dose that takes care of the bad and achieves me some good without causing bad.
Now, another term we have heard is agonal breathing. What is that, sir?
Yeah, agonal breathing is when if you have a lot of fluid in your lungs or pneumonia in your lungs and you can't take a nice deep breath, so somebody is strapping you down and you feel like you need more air but you can't, then I put you on a ventilator. On the ventilator, you're cared for, and so you no longer are agonal. But when I take that ventilator away to allow you to die your natural dying process, when I remove that positive ventilator help, you're on your own. And so you will struggle as you breathe to some degree, maybe, and you'll show me that you're having trouble breathing. And so that's why I say to the nurse, let's give them a little morphine and or fentanyl to make sure that they can't sense that. I want to tell their brain to stop being aware of that sensation. And we do that every day. And we do it with, as I said earlier, broken record, 2 milligrams, 4 milligrams morphine. If they've been on those drugs for a week, I might be up to higher doses. It could be that I'm at 15 milligrams of morphine, 20 milligrams even sometimes, but rare. Remember, even if I'm at 20 milligrams of morphine, that's 200 of fentanyl. So you see, I'm still in the 50 to 200 range of fentanyl, even when they have tolerance.
How would you prepare the family for something like agonal breathing?
That's a really important role of mine. I need to tell them, when we remove this tube, we're doing this because you have helped me to understand that your loved one would no longer want this life support. When we remove it, though, they might look uncomfortable, and I want you to be aware that I will protect them from feeling this discomfort. And the way that I'm going to do that, and I say this out loud, the way that I'm going to do that is I'm going to give them a narcotic, which is going to tell their brain not to be aware of this sensation. So they might look like they're short of breath to you, but trust me that we are doing our best to make sure they're not aware of that. So what I want you to do instead is hold their hand, whisper to them, tell them you love them, and tell them anything you need to know. And that way it gives the family the comfort level of talking to them, even though they see something that looks uncomfortable.
Now, one of the medications that we've heard about a lot is vasopressors. What are vasopressors, Dr. Ely?
Yeah, we call them vasopressors. And vasopressors are medications to lift your blood pressure when you're in shock. So if you're in the parking lot today and a car falls on them and you need to lift that car up, you might get a surge of adrenaline and allows you to lift that car. He's, Superman. That's a vasopressor. Your body did it. But when you're sick, your body might not be able to do that. So I could give it to you through the vein, and it just means that you're in shock. And we give these epinephrine or adrenaline drugs to get the blood pressure up.
What happens if you would remove them from the vasopressors?
If we remove them from the vasopressors, then usually, and we do this, it will make the blood pressure then plummet, and they will die of natural causes, and they'll die naturally, which often means, by the way, that we don't need much in the way of morphine or fentanyl, because their dying process is going to be rapid anyway. And so I can usually give them very low, very, very low doses if they're already on vasopressors. In other words, I'll say it another way. If you are on vasopressors and I'm removing life support, it means that I very likely need to give you almost nothing in the way of fentanyl, morphine, or benzos, because you're going to die very rapidly anyway, usually. It could still be hours to days, but it might not be that long. But I don't feel the need to keep ramping up these medicines because it's going to happen by nature. So there's no reason to impart a human action to cause that dying process.
All right, and we've heard that there is two ways of dying, by your heart stopping or you stop breathing. Can you comment on that?
Yeah, medically, cardiorespiratory, so heart, lung. So when you die of either of these two organs stopping, they usually kind of occur together. It's very rarely one or the other. Because if you are stopping breathing, it stops oxygen from getting to your heart, so your heart stops too. You see? And if your heart stops, you stop pumping blood, which then makes your lungs fail as well. So these things kind of go in tandem. So I'm never at the bedside thinking that was purely lung or that was purely heart. It's usually kind of all of that happening at once. Is that what you kind of wanted to know?
Thank you. One of the first things you'd mentioned when you took the stand was the doctrine of double effect. We've heard a lot about that. Can you explain it to us so us laymen understand it, sir?
Yes, okay. So the doctrine of double effect means that when I do something to try and help you, it might also harm you. And as long as I am always trying to help you, if the harm occurs, but it wasn't the intent, then it's happening as a double effect of the medication. So the medicine has essentially a capacity to do two things. I'm going to try and say this for you kind of two different ways, okay? The medicine has a capacity to help you, and it has a capacity to hurt you. The doctrine of double effect is said to be in place if I'm intending good and never harm, if the good is not achieved by the harm, and if the good outweighs the harm. I'm going to say these again. And a fourth criteria, that the good couldn't have been achieved any other way. I'll say them again. The good has to be the intent, never the bad. The good cannot be achieved by the bad. The good should outweigh the bad. And there can't be any other way to achieve the good. Now I'm going to give you an example and I'll stop talking.
Okay.
I think it's unresponsive at this point.
I can ask another next question. Can you give us an example, Dr. Ely?
Yes, here's an example. If a person is in pain or is short of breath, and I want to relieve that suffering, okay, I can give a low dose of a narcotic to tell the brain to stop, to relieve their awareness of the suffering or relieve the pain, and to try and help them. Okay. If, however, this is how the doctrine of a double effect would not be in play. This is how I would reach the doctrine of double effect. If instead of giving the low dose, I gave something that hit the ceiling, and now the way that I achieved the relief of the pain and the shortness of breath was by stopping their breathing and their dying occurred, because now the death, which is the bad, caused by my drug, has outweighed the good. The good was achieved by the bad. And I could have achieved the good by just giving a low dose. All I had to do was give 100 instead of 1,000 or 500. If I'd given 100, I would have done something helpful without causing the stopping of breathing. Their dying process could take its natural course. I wouldn't have created that because of my medication. Is that helpful?
So does the literature support what you just told us about looking at the dose?
The literature supports that it is appropriate to cautiously use these medications. And I told you earlier, an average dose, even in the last moments of death, would be the high doses would be in the neighborhood of 200 micrograms of fentanyl would be on the high end. And this is supported by the medical literature. And that is a way to go. There's no literature on using 500 micrograms, 1,000 micrograms, 1,500 micrograms of fentanyl. There's no literature on that at all, because nobody does that. So I couldn't find anything in the literature of routine use of those doses.
So in your opinion, with those type of doses you're talking about, 500, 1,000, 2,000, could be purposeful to cause the death?
Objection, Your Honor.
Let's rephrase.
Okay. Those type of doses, how would you take that as to demonstrate what the intent is of the physician?
The only logical intent that I can come up with for using those doses is to stop somebody from breathing entirely.
And that would lead to death?
It would lead to death, certain death. It would be a lethal dose.
So would you agree with me at most purposeful, at the least reckless?
Objection, Your Honor.
Okay. Format of the question, sustained.
Sure. That type of dosage, would you say that that would be purposeful action?
Objection, Your Honor.
Okay, again, form of the question.
How would you define that type of dosage as far as the intent?
Objection, Your Honor, as to how does he define intent. Intent is a legal term, and I don't believe he set forth any qualifications with respect to him having a JD.
Again, form of the question.
Medically, those type of doses given to a patient in palliative extubation, what do you believe the intent of that physician would be?
Same objection.
This time overruled.
I believe the intent would be to stop breathing and hasten death, cause death.
That's to a medical standard, correct?
Yes.
Your Honor, I'm next intending to get into the actual victims in this case. I don't know if
Maybe
this
it's
would be a
time
good
for a
time to take a
break
break.
We're going to give you your early 15 minutes. Okay, remember the admonitions.
All right.
Have a wonderful break, ladies and gentlemen. Let them get out of the way since you guys have to cross each other. We discussed the construction of these courtrooms. That was one of our complaints, but unfortunately we weren't writing the check, so. We do sanitize that area. So it was all that was, the whole room was done over the weekend, so. Okay. Doctor, you cannot discuss your testimony on the bench. You can answer factual questions, anybody that propounds upon you, but how you testify and what you testify to, you are not to discuss. Do you understand that?
Yes.
That you may step down, get comfortable, find a restroom.
Thank you.
Ms. Sawyer, anything for the record? Ms. Panasci? Okay, we're on break. Well, I didn't take my meds this morning. My muscle relaxer, which doesn't put you to sleep, and I have an NSAID that I can take.
No, he's fast. Well, when he gets into it's fast. And she's usually right there with the next question before he's finished talking. I'm gonna wait till it's back. How long did it be like for sure? And it could just be.
That's the lead up, right? So it's surprising. Okay. You know what? No, this is good. This is good. That actually, I couldn't have done that without him. He's elevated him because I was like, sir, this one of my higher part of this really fancy society. We're looking at all these guidelines. So I'll just be back. Sisters testify.
I'll start the bus today.
So he's not gonna like me. Listen, I don't, this is why I don't get to. Sorry. People are, yeah.
Oh. I didn't know what kind you like.
Straight up like you would call.
Okay. All right. Yeah.
Wait, this is amazing. I told them to go get something. This is gonna be awkward.
That didn't mean to be that much of a smart aleck when we went back on the record that one time.
Oh, it's okay.
It's your family.
We gotta giggle with this. I mean, it's a very respectful proceeding, but we don't fall into the quagmire getting too serious.
So this is
This isn't my favorite chair, but we didn't want to take it off the bench. We may have to this afternoon. See, I think they sent one of my chairs away when they moved this over. Because I went and got St. John's chairs, which are like really good chairs, but they had a clearance at one of the local places. So I got them for like 25% of their normal price. We got two of them. Well, for some reason, I don't think they both came over. Or someone else is sitting in one of my comfortable chairs.
Somebody's like, I want to share a laundry.
And I didn't want to walk around the courthouse peeking under people's chairs. But see, you know, being in private practice and having my own office with furniture and everything, you know, I was pretty good about getting a deal.
Yeah.
Because office furniture is usually by the pound. You know, you can tell a good desk by the weighing so much. And when I came to the bench, I basically gave it to all the guys in the office, chairs. I wasn't going to liquidate it. Now I wish I had some of it and had storage for it. I'd love to have. My desk was a Kimball, but it was a good Kimball. That thing probably weighed 300 pounds. And it was big, but it was a great desk.
Say that you're sorry. It's like, rebuild relationships. I'm ready now. You do it. We don't want to rebuild a relationship. I don't think different for a reason.
Just by himself. Did you check in with Rachel about check in with somebody that can get it? She's very sorry. I hope so. Some sort of grant or we can get her just my case was actually a murder of her husband. But she had before she somebody you're just doing.
Yeah, I'm Sonic practice tonight, so I might get home by 10:30.
10, she's like, I have to pay money, but that's okay, that's okay.
And it's my favorite night of television, too. NCIS and NCIS Hawaii off tonight. Having a bad hair day.
I think they're fairly well in order, so I'm just going to lift them up one of the times.
Do you want me to come out and do that? Okay, I was happy to.
Paul's we've been started watching Game of Thrones 2 weeks ago.
That's a long series.
Yes, we've been
Binge.
binging. I'll be your baby.
This weekend I didn't have time to binge anything. Oh, I got home on Friday, did 3 loads of laundry, picked up around the house, got the trash. Next morning I ran errands from 9 o'clock until
I can't even hang on.
4 or 5.
Wait, how are you?
You know,
I'm
got
gonna
home,
hold up the volume.
and then Sunday morning I get up.
I'll be big enough.
I'm moving, I'm storing some stuff in the kitchen. So I probably got 10 boxes of that. Get it over there. Then I went out and bought a suit and gas. Got 2 suits actually, and some shirts. You know, and get some gas. Huh?
So we
Go judge him.
Huh? What, you're across?
You know, sometimes like, you remember back in the day where you just use your telephone.
One of those just put your ears back and go. One of those you put your ears back and go. Because anywhere you can control damage, you try.
I just trying to set a meeting up.
So although I didn't sleep, I was really looking forward to this.
Yeah, so whatever people we can hook up with. I would really appreciate. She's a sweetheart. She just, her husband was awesome. Just got murdered. Just doing his job. So it was like, they were animated company. It was like, looking at our apartments. And, you know, our thoughts were that he
Why don't you go and gather them up?
Yeah, so it is like one of those victims of victims. And so just trying to do what I can. Because usually I take that muscle relaxer before I leave. I mean, it doesn't make me sleepy or anything.
Right.
And the next day,
All right.
Dr. He's in the restroom.
I got it.
where's Doc?
I got it.
He's in the restroom, Your Honor. He said he'd be right in.
be seated. The doc had to go to a room for a second. Coffee, everything good, guys? Everybody got coffee? I forgot the teapot this morning, that's my fault.
You know what, Judge, I have a traveling teapot, I'll just bring it.
It's up to you.
Yeah, I'll bring it. Thank you.
I do have 3 of them though.
Me too. I'm the one drinking it.
Oh, one I used for risotto,
Right.
so I don't think chicken broth is a good thing to make your tea out of. Did we lose the doctor?
He's in the restroom, Your Honor. We should have him in a minute.
Okay. That's the longest walk from that door to the stand. Come on down, Doc. Yeah. Doctor, remember, you're still under oath. Go ahead and get yourself comfortable. Ready?
Yes, sir.
Okay, you may continue.
Dr. Ely, were you asked to look at the medical records of the 14 victims in this case?
Yes, I was.
And did you in fact look at those medical records?
Yes, I did.
From there, did you draw up a report, your report regarding this?
Yes, I did.
And Your Honor, if I may approach the witness?
You may.
Dr. Ely, I'm handing you what I marked for identification as State's Exhibit 30. Could you identify that for us? And I believe it's in 2 parts.
Yes, in this binder, the first one says CV, and that's my curriculum vitae.
In the second part?
The second part is my report on the patients, which I believe was redacted from 25 down to the 14 that you're including today.
And is that a true and accurate copy of your report
Yes, it is.
that you prepared in response to this case?
Yes.
So I want to direct your attention to the first victim, Joanne Belisari. And State's Exhibit 1, which is 2 volumes.
Okay, hold on. When you say CD, what do you mean?
Oh, I'm sorry, my resume. CV is curriculum vitae, which is a resume.
Okay.
Those will be the medical records of Joanne Belisari that you examined in response to this case? Is that a yes or no, sir?
Yes, it is.
And I'm going to direct your attention. You can look at your, either the binder or what's on the screen. Can you tell us what this is, sir?
These are some summaries of my thoughts, my observations about her medical records.
All right, and what did you find important in looking at Joanne Belisari's medical records?
Well, this woman had she had a disease which is dangerous for the body, which is chronic obstructive lung disease and kidney failure. She also had a big problem with blood pressure, and that when the blood pressure goes too high, it can cause your brain to not work well. So her brain wasn't working well from the blood pressure. She had underlying lung disease, and she also had kidney problems. So those were underlying issues that she suffered from, and she did not have any cancer. It's diagnosed by looking down at her lungs. And the main thing that occurred was that at the bottom of the screen, it shows that at 23:32 that evening, she was given 1,000 micrograms of fentanyl at the time that she was extubated, and she died 8 minutes later.
All right, and she was admitted first to the hospital on April 22nd of 2015,
Correct.
and her death occurred on May 10th of 2015?
Correct.
Now, why is that amount of fentanyl important to us?
Well, she didn't, it's unclear from looking at these medical records how long she would live. She could live for days, she could live for maybe weeks. We don't know that. And when she was given 1,000 micrograms of fentanyl, she only lived for 8 minutes. And I think it's because her brain was completely shut off from delivering any more breathing by this, what I deem a lethal dose of the medication.
All right, and did you draw conclusions then based upon your review of those medical records?
Yes.
And were those conclusions made to a reasonable degree of medical certainty?
I think they are made to a reasonable degree of medical certainty. And I think it was unethical to give her 1,000 micrograms of fentanyl when we did not know how long her natural life would lead. And I think that we assured that she would not live by giving that dose, which to me is the cause of her death.
All right, and that's essentially, if I'm correct, the first paragraph here that you're talking about?
Correct.
What were your specific findings regarding that dose?
The specific findings are that there was no indication to give that dose, that if a desire for making sure that she wasn't suffering because of her chronic obstructive lung disease was present, she could have received 50 micrograms of fentanyl, 1/5 of the dose. I mean, what would that, 1/10, yeah, 5% of the dose. She could have been given 5% of that dose. And 2 times 10, 20, or I guess that's right, yeah. And done and achieved a good for her. She could have been safely escorted off of a life support device and then allow her life to go on, but instead her life was stopped.
Now, I note that you make a specific finding that the procedure of palliative extubation is not painful or uncomfortable. What do you base that on, sir?
We have studied thousands of patients who have undergone extubation and discussed with them if the extubation itself was painful. And patients don't describe that to me, that taking the tube out is causing them pain. What can cause them suffering, of course, is the shortness of breath. But as I said, 1,000 micrograms of fentanyl is not what you use to take care of that problem.
Was there any evidence that you saw of opiate tolerance within Ms. Belisari?
I do not think she had opiate tolerance. So I think that this medication was given to essentially a person who could not have tolerated it under any circumstances at all. She had received a few doses for breakthrough pain before, but very low doses. And what's interesting is that the cross tolerance from hydromorphone and morphine to fentanyl is not very good. In other words, if I get given morphine and hydromorphone, which is dilaudid, for multiple days in a row, I don't develop as much tolerance for fentanyl. Fentanyl is a unique beast. It doesn't have when you develop tolerance to morphine, you don't automatically have tolerance to fentanyl, which is why we are so cautious about that one specific drug, fentanyl.
What about whether these type of medications, the 1,000 micrograms of fentanyl, how would that affect Ms. Belisari's body?
Well, she'd be unable to keep living with that drug.
And is that based upon a reasonable degree of medical certainty?
Yes.
What specifically with her and her illnesses would have helped to contribute to that?
She has kidney problems, so she can't metabolize the drug. So it's going to come into her and stay built up. But even if she didn't have the kidney problems, I think that would be a lethal dose. You cannot keep breathing when you're given 1,000 micrograms of fentanyl. All of you would stop breathing.
And I'm going to go to page 2 of your report regarding Ms. Belisari. You indicate here, fentanyl is a high alert medication. What does that mean to us?
What it means to use anytime a person is given fentanyl, they have to be very carefully monitored for the likelihood that they will stop breathing. And if they are not going to be protected by being put on a ventilator, then we have to make sure that we don't give them a dose that would cause them to stop breathing, or otherwise we're causing the death. We don't ever want to cause the death. We want to reduce suffering, but never cause dying.
And in addition to her kidney failure and organs, her age, did that have an impact on how quickly this affected her?
Anybody of advanced age will be less likely to be able to tolerate this. And don't forget that her lungs were severely damaged. So she is that group of person that I was talking about earlier at the beginning of the day is how will I care for the most vulnerable members of society? And she falls into that category. So this is, I think, a reckless approach of giving medication to a vulnerable human being.
And what do you base that upon, sir?
30 years of medical experience and the summation of the medical literature and the science.
And that's also to a reasonable degree of medical certainty that it believes it's a reckless
Yes.
approach? In that report, true and accurate copy kept in the normal course of your business?
Yes.
The next patient, sir, would be Ryan Hayes. And if you examine Safety Exhibit 2, which is the medical records of Ryan Hayes,
Yes, I did.
based upon that examination of those medical records, did you author a report regarding the death of Ryan Hayes?
Yes, I did.
And did you make findings based upon the medical records?
Yes.
Those findings to a reasonable degree of medical certainty?
Yes.
What did you find significant regarding Ryan Hayes's medical background on or about April 3rd of 2017?
Sure. This is a person who had polysubstance abuse. So he had addiction. He had the disease of addiction. And unfortunately, he overdosed as an outpatient and was brought into the emergency department as a result of this overdose. And he was evaluated in the hospital and found to have severe swelling of his brain. So what that means is that when he overdosed at home, he already stopped breathing. And when he stopped breathing, he didn't get enough oxygen to his brain. And so his brain, the neurons in his brain were dying. Millions and millions of those neurons were dying. Now, what the long-term outcome of that is at this point in this man's life, we don't know. We don't know how much recovery he's going to get. He's a 39-year-old man. So he's a very young person. And even though there's that much damage, we have had people come back from that. There are people who live through that. And I don't know, since I'm not God, what his outcome will be. But what happened with him was this. His initial evaluation, he didn't have these baseline reflexes, a gag reflex, his pupils weren't working right, his corneals, et cetera. So when that's going on and the person's brain is swollen and they don't have these reflexes, we start wondering, are they all the way dead? And he was evaluated and not found to be all the way dead, meaning his brain wasn't dead. He would still breathe. So he wasn't completely processed to death. And then he was given 1,000 micrograms of fentanyl, and the dose was given at 22:57, and 33 minutes later, he was pronounced dead. So in summary, we have a 39-year-old man who, unfortunately, because of his disease of addiction, already has been placed at risk for lack of oxygen with ongoing brain damage. We need to see what's going to happen in the next 24 to 48 hours. That's our standard procedure. What will happen in the next 48 hours to this human being? But instead, that process was short-circuited by giving him 1,000 micrograms of fentanyl, which 33 minutes later resulted in his death.
All right, and so to be clear, to a reasonable degree of medical certainty, Ryan Hayes was not dead at this time before he received that medication?
He had not progressed to the full period of brain death, so correct.
And just, I want to go back to the first paragraph. You indicate, just so we understand, he had polysubstance abuse, and you indicate he was administered Narcan. Can you explain to us what that is?
Yeah, Narcan is a medication to override the effect of the narcotic. And if someone overdoses on a narcotic and we give them Narcan, it can allow them then to continue breathing and live on.
Now, you indicated earlier that he didn't have a cough, he did not have a gag, his pupils were fixed and dilated, no corneal reflexes. What does that mean to us as lay people?
That there very well might be some severe brain damage, but it's early, and we don't know yet what the full outcome can be. These things can recover.
Now, we talked a little bit about Glasgow, CPOT, all of that. Do you remember whether or not he had any ability to feel pain based on the review of the medical records?
I'd have to be shown the medical record because it's a lot of, I don't remember the details of that.
He was diagnosed with an anoxic brain injury. What does that tell us?
That shows that with an anoxic brain injury, it's very unlikely. In other words, what I was saying I don't remember is I don't remember his actual CPOT scores and that sort of thing, if that's what you're asking me. I would not be worried about this person being in pain. He already is in a deep, deep coma, and it's highly unlikely that he is experiencing or aware of any pain.
All right, then you went on to talk about the fact that at 2257, he received 1,000 micrograms of fentanyl. Did he receive any other medication at that time at 2257?
He also received 10 milligrams of hydromorphone, and 10 milligrams of midazolam. This is an astounding amount of medication. This is so far out of the norm of what we would do for somebody. It would essentially be like, if I was going to transport this human being safely through suffering, I was thinking about this morning. Maybe it would be like, I've never said this out loud to anybody before, but if I'm allowed to offer an example, it would be like if I wanted to get somebody safely through a school zone to keep a child safe, I might drive 10 miles an hour in the car, go very slowly, and make sure that the people crossing weren't hit. This is like driving 250 miles an hour through a school zone with people walking across the street. It's that kind of out there. To get any one of these medications might not be necessary, but to give all three in that high of a dose, it's mind-boggling to me why anybody would do that.
Well, then, what do you note on April 3rd, 2017 at 2314 and 2317? What is important to note there?
He wasn't breathing at all.
And then what
happened? He had been
happened?
breathing earlier. Earlier, he was put on the ventilator at 4, and he breathed 6 to 8, meaning that his body was saying, keep breathing, keep breathing, keep breathing. And so he was breathing above the breathing machine earlier, which was at 8 o'clock that evening. But at this time, he has no breathing whatsoever after those medications, which is not at all surprising. There's no way the body's going to keep breathing after receiving 1,000 micrograms of fentanyl, 10 milligrams of hydromorphone, and 10 milligrams of midazolam.
What happens at 2316 then?
He received more.
And what specifically did he receive as far as medication at this point?
He received 1,000 micrograms of fentanyl, 10 milligrams of hydromorphone, 10 milligrams of IV midazolam.
Hypothetically, Dr. Ely, if his pain scores is 0 throughout his stay at the hospital, what would be the purpose of administering this type of medication to him?
There's no purpose other than to end his life.
Did you, based upon this information that you found relevant, draw conclusions regarding Ryan Hayes?
I think that these drugs were given to intentionally cause him to die.
And is that to a reasonable degree of medical certainty?
I think yes.
Was there anything that you found in the record to show that he needed this type of medication and level of dosing?
There's no medical indication for these 3 medications in the doses they're given at all. The patient was already in a deep coma. He was not exhibiting any signs of ongoing suffering.
And again, palliative extubation, is it painful based upon your experience?
Not painful, and even if it was, you might give 1 dose of 1 drug of 50 micrograms of fentanyl, which would be fine. 1 dose of 50 milligrams of fentanyl, but to give 2 doses of 1,000 each, and the hydromorphone and the benzodiazepine, there's just absolutely nobody would do that in medicine.
What about his history of ongoing substance abuse? How would that affect those dosages?
No amount of tolerance to those medications would justify these doses of these medications.
And going to the second page of your report regarding Ryan Hayes, anything else regarding, was there any sign of symptoms of withdrawal that would account for these types of doses?
No, he did not show any signs of withdrawal at all. And so I also saw no support for the medication use with regard to that either.
All right, now you mentioned Narcan here. Why did you mention it at this point?
Well, because you might think, oh, if there's Narcan in the body and I think he's suffering, let me give more of a dose of this drug. But there's no Narcan in his body at this point. It would already have washed out. So that also is just, it's kind of not that big of a point, but it's just, there's no support for these drugs at this point.
And the Narcan, I think you said previously, would also wash out anything else he had taken as far as the illegal substances from his system?
That's the goal.
Okay. You comment at this page about the pain score, and Your Honor, if I may approach, I think I found what he was looking for. I'm handing you what's been marked as the exhibit 2, hang on just a second, 2D.
2B would be
2D,
2D.
yeah.
Okay, 2D or 2B?
2D as in dog, Your Honor.
Okay.
And actually, Diane, okay if I just publish this?
Sure.
Okay. I'm just going to put it up here for you, Doctor.
Okay.
This is regarding, first off, 2D, you see the number at the bottom?
Yes, I did.
All right. And this is regarding what patient, Dr. Ely?
Oh, I'm sorry. This is regarding Mr. Hayes, Ryan Hayes.
All right. And this is what you're referring to pain score. Is that accurate?
Correct.
And what do we have as the history of the pain score at this time?
Yeah, so what you see here is that on April the 2nd, throughout the day, as you're going through the evening, the pain scores are rated 0 all the way down until suddenly somebody puts down 4 10s.
All right, and I want to direct your attention. The first 2 10s are 2257 on April 3rd,
Correct.
and the second 2 10s are at 2316.
Correct.
All right, going back to the first page that you had talked about regarding Mr. Hayes. What time, how do I get rid of this?
You gotta go to the mechanism at the bottom and hit clear.
Look at that. All right, what time was the first dosage of fentanyl, hydromorphone, and midazolam given in paragraph 7 of your report?
2257.
And what about the second dose of those medications?
Was it 2316?
Patient in Mr. Hayes' condition able to feel 10 on pain?
No, and is that yes, or is that just a single word
Yep.
answer you want?
That is perfectly acceptable, sir. You also note on the second page of your findings an issue with that 10 on pain. What is that, sir?
Yeah, if you remember earlier, I was telling you that the CPOT score goes from 0 to 8, so there's no 10. And what I think happened here.
Objection, Your Honor.
Okay,
As speculation.
there's no 10.
Okay,
You can't have a 10.
stop,
Okay.
stop, we have an objection.
I can re-ask the question, Your Honor.
Ask the question. that-
What is wrong with this?
Okay, I'm sorry.
I'm sorry?
But
Objection sustained. Re-ask the question,
Thank you, Judge.
a new question.
What is wrong with a pain scale of 10 using the CPOT?
It's not an accurate representation of the scale. So somebody wrote that down, made a mistake, or did something out of context from medical practice.
And based upon your review of Mr. Hayes' medical records, based upon that, would he be capable of feeling a pain score of 10?
That's an answer. Objection.
I will permit it. Go ahead.
You can answer that.
No,
And is that to a reasonable degree of medical certainty?
yes,
You also indicate in your report that Mr. Hayes had not yet appreciated the full effect of the medication administered to him at 2257. Explain that to us, please, sir.
yeah, he was given doses just 20 minutes earlier that would take down an elephant, and they had not had the full effect because the drugs are still increasing in their effect on the body at that time. So the amount of impact of stopping breathing is growing inside his body at the time that he's then given a double dose even more. We would have wanted to see that drug go play out for 3-4 hours at high doses before ever touching him with any more medication. But instead, only 20 minutes later, he's given the same amount again, which just completely ensures that he cannot breathe.
And based upon your review of the records, do you have an opinion as to a degree of medical certainty as to what caused Mr. Hayes' death?
Absolutely.
And what is that, sir?
He received lethal doses of fentanyl, hydromorphone, and benzodiazepine.
Did you also review the medical records, States Exhibit 3 of Beverly Schertzinger?
Yes,
And based upon that review, did you draw a report?
yes, I did.
And did you reach conclusions based upon that review?
Yes, I did.
All right. And based upon your review, what did you find that was significant from Ms. Schertzinger's medical records?
Well, she developed a blood clot after coughing and came in the emergency department. She was verbally alert and she was oriented. She was determined to have internal bleeding, which was the complication of a procedure that she had. And it caused her, when you have this much bleeding, it can cause you to go into cardiac arrest. That made her then have the need for a ventilator. So she was put on the ventilator to protect her during this time. And she, on the ventilator at 2254, was obtunded, not oriented. So a coma. And at 2320, she was palliatively extubated with PRN sedatives, but the amount of sedative she was given was extremely high, 500 micrograms straight out of the gate, and 4 milligrams of midazolam. And then she was off the ventilator at that point. So she'd already had trouble breathing earlier. She was now taken off the ventilator and then given those medications, and she died 14 minutes later.
And that occurred on October 9th of 2017, her death?
Correct.
And she first came into the hospital on October 2nd, 2017.
That's right.
You used the word on October 9th, 2017 of obtunded. What does that mean to us, sir?
Obtunded means that if I press your chest or if I press your fingernail beds and cause pain, that you don't react. So you're in a coma.
Now, you also comment after her death, did the biopsy come back regarding Ms. Schertzinger's liver biopsy?
She had lung cancer, and it was believed that the amount of lung cancer she had, the severity of it, that she would live for years.
Based upon your review of the medical records, did you draw conclusions to a reasonable degree of medical certainty?
Yes, I did.
And what were those conclusions, sir?
I think that in a patient like this who has a type of lung cancer who can live for years, that the medication that she was given caused her death. She did not die of lung cancer, and she did not die of the complication from the procedure. She died of the medication she was given, which stopped her from breathing.
Was there anything that you saw within the medical records to support this level of dosage of fentanyl and midazolam for her?
No.
What other issues did you see within those medical records?
Well, this is a human being who went to the doctor to try and see what was wrong with her. A cancer was diagnosed, and she was not given the chance to get curative treatments for that lung cancer.
Was there anything regarding prior opiate therapy which would have led to her needing this type of dosage?
No.
Anything within her own body that would cause this type of dosage to be a problem for her?
Well, for one thing, when you're in shock and you're obtunded already, then you're very vulnerable to these medications. You already have ongoing brain that's not working well, and then you add this degree of medication, so you're going to be very unlikely to be able to fend off that degree of medication. That's my answer.
Do you have an opinion as to to a reasonable degree of medical certainty as to what this dosage to her, what it resulted in?
I think it resulted in her stopping breathing and caused her an untimely death.
So I'm next going to direct your attention to Danny Millette. Did you review State's Exhibit 4, which are the medical records for Danny Millette from Mount Carmel?
Yes, I did.
From your review of those medical records, did you draw up a report?
Yes, I did.
And did you reach a conclusion to a reasonable degree of medical certainty based upon that report?
Yes.
What information to you was relevant in reviewing Danny Millette's medical records, sir?
This was a sick man. He had a lot of underlying medical problems. He had diabetes, blood pressure problems, lung disease, and he came in with a gangrenous right toe, which meant that his blood vessels in his body were already damaged from the diabetes and hardening of the arteries. So he was a very vulnerable person at the time that he came into the emergency department. He was found unresponsive by his family, by his wife, and he had been living in an extended care facility. So you are already getting the idea this is a frail human being. He's not thriving in life at this time. But people live in frail circumstances with these diseases for many years. We just have to be careful with them.
What about when he finally did come into the hospital, was he ultimately on a ventilator?
Yes, he was a full code. He had advanced life support. He was given vasopressors, as we discussed earlier, and he, though, regained his circulation. He responded to that life support, and he had shock, kidney problems, liver problems. He had anemia, and on the 5th of, I'll stop.
All right. December 5th, 2017, did you review what his Glasgow scores were at that time?
Yeah, so this sick gentleman had Glasgow scores of 3, which is the lowest you can go on the Glasgow coma scale, meaning that he was in a deep, deep, deep coma.
And on December 5th, 2017, it notes that his code status was changed to DNR CCA. What does DNR mean to us, Dr. Ely?
It means do not resuscitate. So we're going to allow his life to take its natural course without any more CPR. We're not going to try and increase his death. We're not going to try and cause him to die, but we're not going to shock him or give him chest compressions.
And on December 5th, 2017, what type of medication was given to Mr. Millett in the course of palliative extubation?
Yeah, at the time that he had a GCS of 3 in that deep coma, he was then given 1,000 micrograms of fentanyl through his veins. And that same mysterious pain score of 10 appeared.
Was he given any other medication around that same time period?
He also received the hydromorphone, 2 milligrams, and 4 milligrams of IV midazolam, the benzodiazepine.
Based upon your review of the medical records and your expertise, to a reasonable degree of medical certainty, did you draw any conclusions regarding how those drugs affected Mr. Millett?
I think they stopped him from breathing and caused his death.
What did you find significant regarding his medical records and these doses?
Well, he would not be able to tolerate those doses given that he had underlying liver and kidney disease and heart disease. So those organs were already so tender and frail that if somebody was worried about him suffering, which he was in a deep, deep coma, so it's unlikely that he would exhibit any pain or suffering, you'd have to give extremely small doses, maybe 25 micrograms of fentanyl or 1 milligram or even a half of a milligram of the benzo, and not both.
And you indicate that up until the time of the administration of this medication, his pain scores were also noted as 0?
Yeah, that was what was so odd to me. It's 0, 0 all the way down. There's no evidence of pain, and all of a sudden it jumps to this undocumentable level of pain because 10 isn't even a real thing. So I don't know what actually happened there. I wasn't there. But it's almost as though somebody said, I better justify the amount of medicine I'm giving, so let me make sure that
Objection, Your Honor, he just said he wasn't there, so anything else is speculation, I move to strike.
Your Honor, he is an expert. He's allowed to at least give his opinion regarding that.
I'll permit it.
You can finish your sentence, Dr. Ely.
patients don't go from 0 to 10. Nobody does that unless you just all of a sudden jab them with a knife or something. Patients go from 0 to 2 and from 2 to 3 and from 3 to 5. But to go from 0 to 10, there's just nothing in his chart that supported that he all of a sudden went off the scale on the pain chart. And I mean off the scale because 8's the highest. So I don't understand. It doesn't make any medical sense.
Now, moving on to the second page of your report regarding Mr. Millett, you talk a little bit about 4 milligrams of midazolam and what that would be appropriate to be used on as far as a patient. Tell us a little bit about that, Dr. Ely.
Well, that's a lot of midazolam. I mean, if I was giving you midazolam, I would give you 1 or 2 milligrams. But your liver works, your kidney works. But if I had already given you 1 or 2 on another occasion, I might give you 4. That'd be fine. But I wouldn't give 4 to somebody who was already in a coma and didn't have a working liver and kidney.
Now, you also talk about the fact that he was given fentanyl and hydromorphone. Why is that significant?
Well, they're both narcotics. There's no reason to give both of those. I've never given those two together, ever. Absolutely no reason. It'd be like giving 2 different types of blood thinners, heparin and Coumadin. And your blood is already thin on one, and I add another one, which can only cause you harm at that time.
And did you draw a conclusion based to a reasonable degree of medical certainty as to what effect the medication administered to Danny Millett had on Mr. Millett?
I think those medications ended his life, killed him.
Dr. Ely, I'm next going to direct your attention to Brandy McDonald. And showing you States Exhibit 5, the medical records of Brandy McDonald, did you examine those in the course of your review of this case, Dr. Ely?
Yes, I did.
Based upon that review, did you draw up a report regarding Ms. McDonald?
Yes, I did.
Can you tell us what you found significant regarding Brandy McDonald from her medical records?
Yes, Brandy McDonald was a very unfortunate 37-year-old who had ovarian cancer. So she had ovarian cancer, which we know had already spread throughout her body. And she was undergoing chemotherapy to try and control the spread of this cancer so that she could have as much time with her loved ones as possible. She comes in the hospital with a problem of vomiting and a severe worsening of her liver and kidney from the chemo.
She entered the hospital on January 11th, 2018.
That's right.
What was significant that occurred on or after January 14th of 2018 in her hospital stay?
She was vomiting. She couldn't keep anything down, and she was found, based upon her blood work, to have a very, very high level of acid in her blood, meaning that she was not getting blood to her vital organs very well. And so this acid was building up, and she got sicker and sicker until, okay, so I'll stop there.
And I note again that we have a DNR CCA status. Again, a do not resuscitate, is that correct?
January the 14th, yes.
What happened after January 14th that you looked at regarding Ms. McDonald?
Later that the family had decided, based upon her wishes, and that she not undergo heroic support at that point, but they wanted to let her life take its natural course. And on January the 14th at 5:45, she received 50 mics of fentanyl for a pain score of 8.
In your review of the records, did that appear to relieve her pain at that time?
She still had pain afterwards.
Okay, what happened next?
She was then given 1,000 micrograms of fentanyl,
Any other medication at that time also?
as well as 6 milligrams of midazolam.
And was that again in the process of palliative extubating her?
Yes.
Based upon your review of the records and your expertise, did you draw a conclusion to a reasonable degree of medical certainty what that medication did to Ms. McDonald?
That medication killed her. There's no reason whatsoever to go from 50 to 1,000. Nobody would do that. You'd go from 50 to 100, 50 to 75.
Was there anything else in the records to support giving that large dose of medication to her?
I found nothing, and don't forget that in addition to that, she had already disease from the chemotherapy of her liver and kidneys and other vital organs. So we know that she cannot process that amount of medication. So we have to be sure we cover her suffering, but we have to do it in a way that's within the standard of medical care. 50, 100 micrograms, which can be monitored carefully and then given more over time.
And in looking at the second page of your report on Ms. McDonald, I note you talked about the synergistic effect of opiates and benzodiazepines. What do you mean by that regarding Ms. McDonald's case?
Well, these drugs, when given together, are going to have this additive effect on each other of stopping you from breathing. We do want to reduce suffering, but in this case, she didn't have a need for both the benzo and the pain medicine. I would have just given her some pain medication because that was her main complaint.
And again, based upon your expertise, your review of the medical records, and to a reasonable degree of medical certainty, do you have an opinion as to how those drugs, medications given to her, the fentanyl, the midazolam, affected Ms. McDonald?
I think it prevented her from being able to take a breath.
And would that have killed her?
Yes.
Dr. Ely, did you next look at the medical records of Francis Burke, which is marked as State's Exhibit 6?
Yes, I did.
Based upon your review of Ms. Burke's medical records, did you draw up a report?
Yes, I did.
And based upon your review of the medical records, what did you find significant regarding Francis Burke's medical stay at Mount Carmel West, which began on January 13th, 2018?
This is a 73-year-old woman who came in the hospital with a large bleed inside of her head. It was in the left side of her brain. and she had swelling inside of her head, which was shifting the brain over to some degree, which was very dire, no question. And neurosurgery was consulted, and they didn't think they could fix it.
What else did you find significant?
She had a pain score documented again of 10. I don't know why people are documenting a pain score of 10 when that's not actually a thing. They'd have to put 8. But
Did you look?
the issue was that before that, it was zeros. And so she got these zeros, and all of a sudden it shifts to 10. And I said earlier, that doesn't make any clinical sense when somebody's already in a coma.
Okay. What about other medication that was prescribed to her prior to the fatal doses?
She was given a reasonable dose of fentanyl, 100 micrograms of fentanyl at 1648, which is fine. There's no problem with that. You can monitor what that does to the person and see how they're able to tolerate that.
Okay. And according to your review of the records, did she tolerate that?
It seems as though she did.
What happened next that was significant in your point of view?
The decision was made to change her code status to DNR. And then she was given at 12:02, 1,000 micrograms of fentanyl, and the pain score was again noted to be 10. I don't know how they determined that because she didn't give any evidence grimacing. She had no external signs of pain that I was able to find. And she was then pronounced dead 17 minutes later.
And did you draw a conclusion based upon your experience and your review of those medical records to a reasonable degree of medical certainty as to what happened to Ms. Burke?
Yes, I did.
And what was that, sir?
I think it was unethical to give her that higher dose of fentanyl when she'd already tolerated the earlier lower dose and there was no evidence of ongoing suffering.
All right. And you talked a little bit about the need for symptomatic management and how this dose could affect a patient like Ms. Burke. Tell us a little bit about that.
I'm sorry, repeat your question?
Sure. Let's focus on how this type of dosage could affect Ms. Burke.
Right. So she's already got this big bleed in her brain. We know that's severe. What we want to allow her life to do is to take its natural dying process, which could be that she could wake up in a couple of days and have some interactions with her loved ones. That can absolutely happen. Even if that doesn't happen, remember that my job is to allow her life to take whatever its natural course is and allow the candle to burn out on its own. But what the medicines did was they blew the candle out, stopped her from breathing, and killed her.
And is that based upon a reasonable degree of medical certainty?
Yes.
I'm next going to direct your attention to Jeremiah Hodge.
Can you lower it down a little bit?
Sure. Give me just a second. And I'm showing you what's been marked as State's Exhibit 7. These are the medical records of Jeremiah Hodge. Did you review these in the course of your drawing up a report regarding Ms. Hodge?
Yes, I did.
All right. And based upon your review of those medical records, did you draw up this report?
Yes, I did.
What did you find significant from those records regarding Ms. Hodge, Dr. Ely?
And this is a woman who came into the hospital with a full-on cardiac arrest. She's 57, young woman, and she has very profound problems in oxygenation and in blood pressure. She is determined to have that her whole heart is not pumping well enough. So essentially she's having a big bad heart attack. And she has reasons to have all this. She has diabetes, she has bad cholesterol, and she has blood pressure problems, hypertension. So this is the natural result of heart disease that's gone bad.
And she entered the hospital on April 1st, 2018 and remained there that entire day. Would that be accurate?
Yes.
At some point she ended up intubated?
Yeah, she was having difficulty breathing, so she put on a breathing machine.
And at any point, did you note an improvement as far as circulation or consciousness?
She did. Her circulation recovered. to some degree. She did not regain consciousness, but her circulation started to stabilize. So what it would make me want to do as a doctor is say, okay, well, she's blood flow is going again. Let's see where this goes. Over the next 24 to 48 hours, family, we don't know. This is scary for you, I know, but let's see how she does over the next 2 days.
During the time period that you looked at the medical records, did you note what her pain score was?
Her pain scores, I can't recall. If you can point to me.
I'm going to refer you to number 3, paragraph 3 of your report, doctor.
She wasn't exhibiting pain.
What ultimately ended up happening as far as drugs in conjunction with palliative extubation, sir?
Yeah, there's this seemingly rapid movement within 15 minutes of moving her towards a high dose of fentanyl, 800 micrograms of fentanyl, 6 milligrams of midazolam, and there weren't any pain or anxiety records to document why she would need those medications, especially in those doses.
And in fact, you note that this was the only pain and anti-anxiety medication she received during her stay at that hospital?
Correct.
All right. Based upon your expertise, your review of the medical records, do you have an opinion to a reasonable degree of medical certainty as to what caused Ms. Hodges' death?
I think the fentanyl and the midazolam caused her death. And if you look at the time of administration, the time of death, there's only 6 minutes between the drug given and the death. So she died 6 minutes after the administration of those medications. And you don't die that quickly when your circulation is regained. Her circulation was back. So I would expect her to keep going. Let's see how she does. But this ended her life.
And you indicate that a patient who presents unresponsive with continuous coding, as the case is here with Ms. Burke, is unable to have a response to pain stimulation. Explain that to us, please.
Well, she would not be able to exhibit pain in that circumstance just because of the degree of medication she was given after getting the medicines. But before that, she was not exhibiting suffering either by the medical records.
So to a reasonable degree of medical certainty, what would be the purpose of giving her 800 micrograms of fentanyl and 6 milligrams of midazolam?
There's no palliative reason to give those doses of those drugs because she wasn't exhibiting the suffering. So the only thing I could understand would be that you'd be trying to end her life, shorten her life.
And next I want to talk to you about James Allen. And I'm showing you what's been marked for identification as States Exhibit 8, the medical records from Mount Carmel West on James Allen. Did you review those, Dr. Anderson?
Yes, I did.
And based upon your review of those records, did you author a report?
Yes, I did.
What did you find significant about Mr. Allen from those medical records in this case, sir?
He had a severe infection. We call it cholangitis. You know, you have a gallbladder, and there are tubes sticking the bile from your gallbladder down into your GI tract. And when those get blocked up by stones, you get this problem of cholangitis. The good news is we can remove the stone and give you antibiotics and usually save your life. So that was the problem that he had. He did undergo a really rapid heart rate during all of this because that happens a lot in sepsis. And when that happened, his blood pressure dropped and he was put on life support.
And he entered the hospital on May 24th of 2018
Yes,
and remained there until May 28th, 2018 upon his death.
right.
You note in, and I'm going to, I believe you just to refer you to, it's number 3. He went into atrial fibrillation with rapid ventricular rate, became hypotensive, experienced dark bloody secretions on suction. Explain that to us so we understand, sir.
A large number of people who get infected like this, their heart starts to quiver to some degree, a little bit in one of the chambers, and that's called atrial fibrillation. It doesn't usually kill you. It's something we can control with heart medicines. There are millions of people in the hospital with atrial fibrillation right now. And all we need to do is slow your heart rate down. So that's not a lethal problem.
What did you note regarding his pain scores and the Glasgow coma scores during the time period, Mr.
Oh, it was very, very encouraging. His pain scores were all zeros. There were some dashes, but it was very encouraging that he was not in active pain.
And you indicated he remained stable in ICU and his body accepted the treatment provided up to his death. Explain that to us, please.
He was doing well. I mean, he was improving and stabilizing. His GCS scores were 8. That's not a dense coma. He was opening his eyes, withdrawing. He was grimaces to pain. So this is a person who, very unlike the other patients, was not in a profound end-of-life state.
What ultimately ended up happening with Mr. Allen, Dr. Ely?
What happened was that on the evening of May 28th, his code status was changed to DNR, and he was given 1,000 micrograms of fentanyl, 6 milligrams of midazolam, and that ended his life. In fact, 20 minutes later.
And this was again given in the procedure of palliative extubation?
Yes, but it doesn't meet any of the criteria for palliative extubation. The patient did not have elevated pain scores. He did not appear to be suffering. He was actually tolerating things to the degree that we could let his life go on and have its natural course, but it was ended in 20 minutes by these lethal doses of fentanyl and midazolam.
And based upon a reasonable degree of medical certainty, your expertise, what did those medications do to Mr. Allen?
I think they killed him.
And you go on to talk a little bit about there was no clinical basis to remove Mr. Allen's breathing tube at that time. Explain that to us, please.
I'm sorry, repeat your question.
Sure. You go on to talk about there was no clinical basis to remove Mr. Allen's breathing tube at that time. Explain that to us, please.
Yeah, okay, we haven't discussed this at all yet, so this is a good one. If I have somebody on life support, we can still make you a DNR and leave you on the life support. Just because I don't want to get chest compressions or get shocked doesn't mean that I don't want my full chance at living. So I have lots of patients every day who are on life support that I make DNR, and the agreement I'm making is I will respect your wishes to not go through chest compressions and shocking, and yet I think this life support can get you through to the other side so you can live out your life. And this particular patient is the first one we've gone over yet that really seems a great candidate for that. That I don't think there was any, I don't know why he was taken off the breathing machine.
And going to the second page of that report, you again talk about fentanyl being a high alert medication and how that would affect this patient, Mr. Allen specifically. Can you explain that to us?
Yeah, if you look up fentanyl in drug books under adverse reactions, it doesn't just say respiratory suppression. It also says low blood pressure, cardiac suppression. So it's hitting both. This is not true that the drug is just affecting your breathing. And remember, this person has a global problem with their heart. So 1,000 micrograms of fentanyl is absolutely going to play a high alert situation for somebody with a profound heart problem. And if we want to let his life take its natural course, we need to not give him a medication which poses such a threat to his cardiac function.
Dr. Ely, I want to talk to you next about Troy-Allison. And did you review States Exhibit 9, which are the medical records of Troy-Allison from Mount Carmel Hospital?
Yes, I did.
And from that, did you draw up a report?
Yes, I did.
What did you find significant about Mr. Allison's stay at Mount Carmel Hospital, which began on July 15th of 2018?
Well, on the 15th of 2018, he came in with he was found unresponsive, decreased responsiveness, and he had a big kidney problem. His kidneys were acutely failing. We measured his kidney, they measured his kidney function, and he was in outright kidney failure. They did an upper GI to look and figure out what was going on, and one of the things that they found was a swelling of his food pipe, his esophagus. His kidney function, which is referred to there as AKI, which stands for acute kidney injury, his kidney function resolved, and he was discharged home on antibiotics to take care of that swelling of the food pipe. He did have diabetes, so that puts him at high risk, but he had no history of alcohol or other drug use. And then he comes back to the hospital in the emergency department with respiratory distress, elevated blood sugars, and this kidney insufficiency. And so he gets a CT scan, which is fairly unremarkable. And you want me to stop talking? Is that enough?
No, what else?
Okay. So the supervising physician is looking over him, and they figure out, they project what they should do for him. And he gets further assessments and sent to the ICU because he's not doing very well. And they get a blood gas, which reveals a lot of acid having built up in his blood and a really, really high sugar level. So his diabetes has gone through the roof. And that's totally fixable. We have problems with diabetes of that nature all the time, every day, and we take care of that.
At some point, was he intubated?
Yes.
And during the time he was in the hospital, was any type of pain or agitation noted?
He was not having a lot of agitation and pain. He was, he had, let me catch up here in my thoughts. He was basically, on the life support, not doing well. They were trying to get him back from this big lactic acid level that he built up, and trying to stabilize him, but they were having a difficult time stabilizing him. And then he did not have any signs of pain or suffering, but they were still having a lot of trouble getting him stabilized on the life support. And then he was given this dose at 1:25 in the morning of 1,000 micrograms of fentanyl with nothing else, and he died 3 minutes later.
And how much did he receive as far as fentanyl?
1,000 micrograms.
And do you recall whether or not they did have to perform CPR on him at some point?
They had already done CPR on him earlier.
Okay. Based upon the medical records, your review of them, and your expertise in this area, did you reach a conclusion to a reasonable degree of medical certainty regarding that dosage of medication, 1,000 micrograms of fentanyl, and how it affected Mr. Allison?
Yes, I did. I think that this medicine, again, ended his life. I think it caused a death. And what doesn't make sense about it is that if you're having problems from diabetes and you're on life support and we're trying to stabilize you, let's keep going. This is something that we can get you back from. And I need more time. I'm thinking as a doctor, I need more time. I need 6 more hours. I need 12 more hours to get this all under wraps. But instead, we give a lethal dose of fentanyl and stop his life. And it goes counter to anything that I would understand was the goal.
And his kidney injury, how would that affect his ability to assimilate this drug, fentanyl?
That's the other problem, is that you can't process fentanyl when you have kidney failure like this. That's how you get rid of the fentanyl. So it's going to ensure he gets a drug in his body that he can't reduce. And so the full brunt of the fentanyl is going to get there and stay there and keep you from breathing.
Dr. Ely, I next want to direct your attention to Bonnie Austin. And showing you State's Exhibit 10, which are Bonnie Austin's medical records from Mount Carmel. Did you review those in the course of drawing up this report?
Yes.
And from there, you did draw up this report?
Yes.
What did you find significant about Ms. Austin's stay at Mount Carmel West, which began on September 30th, 2018?
She came in unresponsive and was found to have a collapse of her lung. So she was given a chest tube to allow that lung to re-expand. And in evaluating her further, she was found to have pneumonia in both of her lungs. She already had a history of lung disease and high blood pressure and kidney disease. she was, so she was very, very sick with pneumonia and was going to be given antibiotics to come back from that. That's the hope at that point. And on the same day that she came in that night, she was given 600 micrograms of fentanyl, 6 milligrams of midazolam, and she died a mere 21 minutes later.
And prior to
21 minutes later,
receiving that medication, what did you find significant regarding her pain and Glasgow coma score?
She didn't have evidence for giving these high doses of drugs. She was unresponsive. She did not respond to verbal or physical stimuli. So it'd be as though you'd be sitting there looking at somebody in a coma, super sick, with no evidence that they were in pain and suffering, and no need to give much medication. So again, if I wanted to stay just above what suffering might come, I might give 25 or 50 micrograms of fentanyl, but I would never go and give 600 and 6 of midazolam.
And again, this was done in the procedure of palliative extubation?
Well, I don't think that that's justified, but that may be what somebody said that they were doing, but that doesn't make medical sense.
And based upon your expertise, your review of the medical records, and to a reasonable degree of medical certainty, do you have an opinion as to what this level of medication and drugs did to Miss Austin?
I think it killed her.
During her stay at the hospital, did Miss Austin receive any other type of pain medication that you noted?
Not that I saw.
So certainly tolerance would not be an issue with Miss Austin.
She was essentially naive to the medication, so her body had not seen it. It wouldn't have any tolerance built up whatsoever, and that's why she couldn't tolerate maybe even 100, maybe 200 micrograms of fentanyl, much less what she was given. And then on top of that, the synergistic effect of the benzo, which also stops you from breathing.
Dr. Ely, I'd next like to talk to you about James Timmons. And showing you what's been marked for identification of States Exhibit 11, the medical records of James Timmons from Mount Carmel West. Did you review those records?
Yes, I did.
Based upon that review, did you draw a report?
Yes, I did.
And what did you find significant about Mr. Timmons' stay at Mount Carmel West, which began on October 22nd of 2018?
He had essentially a drug overdose. This is a 39-year-old man who came in unconscious, found down. He was given the Narcan, trying to override it. And the toxicology screens were positive for cocaine and cannabis, THC, marijuana. So it was determined that this was the cause of these problems. But when you're down, you can develop damage to your body. And he developed what they thought was a compartment syndrome. So he underwent a procedure to relieve that. It was successful. He was alert and doing okay. He was interacting with his brother after the surgery and no longer reported pain. He was not complaining of pain at that time, although I would have kept him on some low doses of pain medication because he had this surgical procedure. And after the procedure, he dropped his blood pressure, and the attempts at recovering from that were not continued, and a conversation ensued that made people decide that this 39-year-old did not warrant any further care, support. So support was withdrawn, and at 3 a.m. on the day after he was admitted, he was given 1,000 micrograms of fentanyl, 10 milligrams of midazolam, and he died just 13 minutes later.
Now, first off, what is compartment syndrome? Can you explain that to us?
Compartment syndrome is if you get unconscious and lie on the ground too long, your body's own weight will damage part of your muscles. And that's what happened to him. I don't know how long he was down, but he was down too long. And so you might think of like the anterior portion of your calf. If you were on your stomach, lying on your stomach, that extra portion of your calf, all that muscle would get damaged. And then when we get you up, get you in the hospital, it starts swelling like this. And it's surrounded by a tissue, a very tight connective tissue that only has so much room to move. And so if you feel that it'd be like this water bottle, but now all of a sudden I try and shove 3 times too much water in this, and that's gonna get tighter and tighter and tighter. And then when it gets tight like that, no blood can get into that part of your leg. So we call that a compartment syndrome. It's a syndrome where the compartment is too tight now and no blood can get in there. So it actually is a medical emergency, a surgical emergency.
Now, you noted that on October 24th, 2018 at 3 a.m., he received 1,000 micrograms of fentanyl, 10 milligrams of midazolam. Did he receive additional medication shortly after that?
Yes. 5 minutes later, he also received hydromorphone, 10 milligrams, and another 10 milligrams of midazolam.
And how long after that was it before he was pronounced dead, sir?
8 minutes.
Based upon your review of the records, your expertise, do you have an opinion to a reasonable degree of medical certainty as to what caused Mr. Timmons's death?
Yes, the medications that he was given at 3 o'clock and then again at 3:05 caused his death.
Did you also believe, or do you believe, that there was nothing left to do for Mr. Timmons?
There was a lot left to do for Mr. Timmons.
Explain that to us, please, sir.
This was a patient who was suffering from addiction who could go into rehab. He could get his leg, his compartment healed up, and he could recover from that and find and live a life of recovery, like thousands, millions of people do all over the world. And I don't understand why, he couldn't be given that chance.
Now, because he was a street drug user, how would that affect the idea of opiate tolerance on him?
It would make him, he would have tolerance in his body for sure. He would have built up that tolerance, but we don't develop tolerance so well to fentanyl. And he wouldn't also have tolerance to the benzodiazepine because he probably wasn't taking those. So I told you earlier that cross tolerance from street drugs doesn't work so well for fentanyl. And I don't know that he was chronically taking benzodiazepines. So the double types of narcotics he got and the double doses of benzos, a person can't live through that.
Now, how would opiate tolerance affect Mr. Timmons if, hypothetically, he received 14,000 micrograms of fentanyl during the surgery for his compartment syndrome?
Well, if you're on a ventilator on life support, you can tolerate it because we're going to breathe for you anyway. But it still would, we would need more medicine to control his pain, but not anything in that realm. This is so far beyond Thunderdome at that point.
What about the use of midazolam or fentanyl and hydromorphine together in regards to Mr. Timmons?
Those drugs are synergistic. They're going to both work to stop the brain from sending a message to the body to breathe. So you're shutting it down, the ability for the body to breathe.
And to a reasonable degree of medical certainty, what do you believe killed Mr. Timmons?
I think the combination of benzodiazepines and double narcotics that he received stopped him from breathing, stopped his heart from working, and killed him.
All right, I would like to next talk to you about Sandra Castle. Did you review what's marked as State's Exhibit 12, Sandra Castle's medical records from Mount Carmel West in regards to this case? And from that, did you draw up this report?
Yes, I did.
What did you find significant about Ms. Castle from her medical records?
She had a cardiopulmonary arrest at her house. The family witnessed it. They called EMTs. They came, they shocked her. They eventually got her circulation back. She had recurrent ventricular tachycardia, which is a very life-threatening condition, but they were able to.
Hold on.
Oh, sorry.
You used the syllables about yay long. She didn't get it down, so she's asking timeout.
Okay.
Do you need him to spell that?
I just didn't understand what he said.
I'll say it again.
Go ahead.
Go ahead.
Ventricular.
I'm sorry, slow down just a little bit.
Okay.
He was trying to, but
Ventricular tachycardia. for which she got defibrillated, meaning shocked. And then she was brought to the hospital.
What else did you find significant? Well, and let me back up. That occurred on November 10th, 2018.
Correct.
Between that date and the date of her death on November 13th, 2018, what else did you find significant about Ms. Castle's stay in the hospital?
When she had that episode at her house, she did have a period of time where she wasn't getting enough oxygen to her brain. And so her brain suffered injury from lack of oxygen. She had a lot of underlying lung diseases. She had emphysema. She had diabetes.
And was she intubated at some point during her stay in the hospital?
Yes, she was.
And when was she actually extubated?
On November the 13th at 4:42 in the afternoon.
And hypothetically, if you were told that she received doses of morphine between that time up until the time she died, would that surprise you?
No, she was trying to be kept comfortable. She wasn't awake though. She wasn't waking up and responding to her family who were there. So I found the medical records to indicate that she was probably undergoing a comfortable dying process. How long that process takes, I don't know. Could be days and weeks is what I would tell the family.
What happened after that that you found significant?
Well, on the 13th, in that afternoon and the evening, she was given 1,000 micrograms of fentanyl, 10 milligrams of morphine, a cocktail that would absolutely lead to death in somebody who was unable to tolerate that. No human being could tolerate that, actually. And she died a matter of 23 minutes later.
Okay, and you said morphine. Did you mean midazolam?
I did. 1,000 micrograms of fentanyl and 10 milligrams of midazolam. Sorry, this combination of narcotics and benzos, once again, both of which stop you from breathing.
Prior to that, her receiving that dose, a few hours earlier, what was noted for her Glasgow coma score?
She was found to be comatose.
Which means what to us?
Well, she's not arousable, not engaging with anyone, and not exhibiting any signs of suffering.
Was Ms. Castle still alive at the time she was administered the fentanyl and the midazolam?
Absolutely.
Based upon your review of the medical records and to a reasonable degree of medical certainty, do you have an opinion as to what those levels of drugs, the 1,000 micrograms of fentanyl and the 10 milligrams of midazolam, did to Ms. Castle?
Yes, I think that they killed her. The main point being that they weren't used judiciously. She was given a dose that would stop her from breathing.
Now, you talked about you would expect her to get slightly higher levels of morphine throughout the time period. Why is that, sir?
Not necessarily slightly higher. I would expect to be giving her something.
Okay.
She could be getting 2 milligrams of morphine every couple of hours. She could be getting 25 to 50 micrograms of fentanyl every couple of hours. That would be very reasonable to do for a woman like this.
If she were receiving that, would there be any reason to then up it to 1,000 micrograms of fentanyl and 10 milligrams of midazolam for her?
I've never seen that done in 30 years of medicine. It's just completely not done.
And to a reasonable degree of medical certainty, do you have an opinion as to what killed Ms. Castle at this time?
The lethal doses of medication she was given took her life.
I'm next going to direct your attention to Ms. Rebecca Walls. And I'm pointing your attention to State Exhibit 13, the medical records from Mount Carmel on Rebecca Walls. Did you review these in the course of writing this report?
Yes, I did.
What did you find significant from Ms. Walls' medical records, sir?
She had bladder cancer. This is a woman who had bladder cancer, and she came to the emergency department responsive. She wanted to be evaluated for complaints of nausea and non-bloody vomit. She had belly pain. So at that time, they reviewed her thoroughly, and she did not have a fever. Her heart rate was fine. Her breathing seemed fine. Her oxygen levels were fine. But they thought that based on her x-ray and her physical exam, that she had water in her lungs, some swelling in her lungs. So that's a very common problem. We treat that all the time, just by giving you fluid pills to get the fluid out of your body, which then leaves your lungs too. So she was giving a very standard course, but with an echo, we were wondering, why does she have this fluid in her lungs? And it was found that she had disease of one of her heart valves, the aortic valve, and that her heart was, these valve problems were causing her to build up the water in her lungs. So that's what I found in the chart.
All right. She was admitted to the hospital on November 13th, 2009, or I think it should be 18. Am I correct? That's just a typographical error?
Yes,
All right. And then until she died on November 19th, 2018?
correct.
Was there anything else regarding her medical stay up until the procedure of palliative withdrawal and extubation was done that you found significant?
She did have some pain, and she was given she was given pain medications. They were giving her to her through an IV, and she was able to tell us how much pain she had. So this is a good situation because we could actually ask her and she could communicate how much pain she had, which means that I can give a dose, see how it works, give another dose, and increase it if I need to.
And you note that it was done via continuous infusion. What is that to us?
That means that instead of me giving you a shot of the drug every 2 or 3 hours, I'm just going to let the drug dribble in continuously throughout the day.
What happened after that?
Well, at 127, she got 1,000 micrograms of fentanyl and 10 milligrams of midazolam, and she also had the sedatives going through the infusion as well. I don't remember the exact dose of what those were, but these boluses were giving on top of what she was already receiving, and she died 5 minutes later.
And based upon your review of the records, your expertise in the area, do you have an opinion as to a reasonable degree of medical certainty as to what caused Ms. Walls' death?
Yes, I think that the receipt of the fentanyl and the midazolam killed her. She had no sign at that time whatsoever that she was dying. She had a valve problem, which millions of people have. She had some fluid in her lungs, which I can get rid of with a fluid pill. We can take care of these problems, but these medicines stopped her life.
And lastly, Dr. Ely, I'd like to talk to you about Melissa Penix. And I'm showing you what's been marked for identification of States Exhibit 14, the Mount Carmel medical records from Melissa Penix. Did you review those in the course of drawing up this?
Yes.
What did you find significant from those medical records, sir?
This is an 82-year-old woman. She had a problem with coughing up blood, and it was making her short of breath. She was on several blood thinners. She was on aspirin, Plavix, and Eliquis, which are multiple different types of blood thinners. And she came in coughing up this blood, and on the CT scan, she had evidence throughout both of her lungs of what looks like pneumonia, but if you're coughing up blood, you think this is bleeding in your lungs. So it looks like she was bleeding inside of her chest. She also was having problems with her kidneys, and she had a problem with blood pressure and some anemia already. And the reason she was on those blood thinners was for her heart. So anemia, heart disease, heart failure, given blood thinners, and now the blood thinners they've crossed over from something good for her into something bad for her. We said earlier we want to give medicines that cause goodness, don't cause badness. Now we're out of whack now. The medicines are causing more harm than good. She's bleeding throughout her lungs, and that's what brings her to the hospital.
All right, and her hospital stay started on November 15th, 2018 and ended with her death on November 20th, 2018?
Correct.
What else did you find significant regarding her stay in the hospital, maybe any pain medication she received?
She was put on the breathing machine, and over the course of the 19th and 20th, she was given the right approach to her suffering. She was given some doses of morphine. She had some pain scores monitored. When the pain scores went up to 5, she was given some more morphine. These are all very reasonable things to do. It's what you'd want anyone to do for your mother or your father. Let's keep her pain controlled. Let's see how she does with this bleeding in her lungs. Hopefully that blood can clear out and we can get her on the other side of this. That's the approach that was taken on the 19th and 20th.
And actually on the 20th, she is noted to have a pain score of 9. What did she receive as far as medication to treat that?
She initially received 1 milligram of hydromorphone, which is Dilaudid.
Then what happened when she was palliative extubated later that day on November 20th?
So from those reasonable doses of morphine and Dilaudid, which as I said were, 1 milligram of hydromorphone, 15 milligrams of morphine, she was then escalated in a bolus to receive 2,000 micrograms of fentanyl and 10 milligrams of midazolam at 22:49. She was extubated 1 minute earlier, and she died 4 minutes later.
Based upon your review of the medical records and to a reasonable degree of medical certainty, did you draw a conclusion as to what that medication did to Ms. Pennick?
No doubt that medicine killed her.
Are you done with this record?
I believe so, Your Honor.
Well, it's probably a good time to take lunch.
Your Honor, I think I'm done, so if I can have just a second, I think we can finish it up. And Doctor, just to show you, that was the second page of Ms. Pennick's report.
Yes.
All right, Your Honor, yes, we can break from lunch. I think I'm done, but just in case I think of anything over the lunch, I can finish it up
Okay.
right afterwards.
Ladies and gentlemen of the jury, if we do an hour, would that be okay with you all? Okay, so we can start it back at 1 o'clock. Okay, remember the admonition. Have a wonderful lunch, guys. All right. Okay. Doctor, remember the admonition earlier? Down to the same thing. We'll see you at 1 o'clock.
Okay, thank you.
Go to the restroom at 12:45.
Yeah.
Ms. Swan, sorry. Ms. Sawyer,
Nothing for the record, Your Honor.
Ms. Menashe,
No, Your Honor.
okay?
Just that, Your Honor, I just want to confirm the scheduling, because as I heard the witness say, he didn't have to be in the ICU until next week. And I was told that we were under some kind of time pressure with respect to him only being available today. And I want to make sure that our cross-examination is done in person.
He has a Down syndrome adult brother he needs to be back to take care of tonight, which is why it's only available 1 day.
Yeah, I'm the primary caregiver for my Down syndrome brother-in-law, but in addition to that, I have multiple meetings with patients tomorrow.
Okay. What time is your flight?
I believe it's at 5.
At 5?
I'm not gonna look and see.
5:59, I believe, so he'd need to be out of here probably 4:45, 5 o'clock. We can get him there. We have a squad car available to rush him.
Oh, it's a smoke.
Okay. We'll do our best.
Okay, thank you.
Okay, we're down for the break.
Sam, do you have a state? Oh, I'm not here. I do it right now. Here we go, right here. I did it right here. All right, let's do this. Okay. You guys are doing these.
Yeah, it was, well, we could, this was got. Do you have an extra one? Yes. I don't know.
What's the number?
There's an hour time difference, so it's really tough.
He covered the natural healings of the leaves.
we're not agreeing to the decision.
Well, we can get, we'll get there.
I'm gonna need, is Alex, are you on the phone? Are you on the phone? No. Do you want to, because is it almost in that order script? Yep.
Did you just get it out of the dry cleaner?
Yes, of course. So I'll tell the fun story. The other day I got my car out. I drove it here the next day. And I took it on. I barely got to drink my coffee.
Stayed pretty busy, didn't it?
This whole thing in the same area. I did the,
It's in that.
yeah. I know, I was so tired. There were two cars. And he was and I said, oh, this car don't go right in. Well, get this fixed. Back up. Put it straight and I just straight. I'm very good about that. Yeah.
Two separate. Paula, could you count the pages in the report and announce it?
I know it's pretty thick.
Well, this is Rob used to run the Chevy dealer when he came. Actually, that's what he's doing. So, I guess they kind of touch up all this stuff.
I got 22 done.
Thank you.
Putting the front page where he talks a little bit about his credentials.
22. 22. Thank you. Yellow paint. Oh, I don't know the number of search times because the report changed. Control F. In there. No, but this is the longer.
Let's do.
Opioid nurse. That's the way I wanted to do it. Honestly, it's too good. I'm gonna have to write.
I just got a text from Dr. Donald Bill that says the live feed is still on right now.
Judge, we had
Is there no vocal file?
It just says the live feed is on. From,
From Channel 10 or from us?
Judge, we had a close encounter with a juror at lunch. We'd like to put it on the record what happened.
Okay. Let me figure out this problem first and I'll get to you next.
Thanks, just let you know.
Since that's what all the trolls were griping about this weekend was the feeds.
The feeds.
Something about we didn't know the difference between a green light and a red light.
It is.
well, that was,
I mean, today. It's like a, I don't know.
obviously,
No, I'm just reading it. I keep very carefully take the cover off and keep it away. Yeah, go ahead. Let me just see what page I'm on. 82.
can we call the camera?
Is your camera running? Is it running?
I'm gonna.
It's okay.
Anything good happen?
Probably. I'm not gonna worry about it. Can we go on the record here whenever you get ready there? Sam? Okay, we're on the record. Everybody's present in the quorum, including the defendant. There were some issues about the stream being on. We're still investigating that. I don't think anything was said on the stream. If there was, or they watched me eat lunch. It's about the extent of it. Okay. It's my understanding, Ms. Grubb, you want to put something on the record.
Yes, Your Honor. Ms. Bucher, Ms. Sawyer, and I were in the room to the left of the restroom eating lunch, and we were assured that it was safe. But a knock came at the door, and a juror wanted to come in and warm some soup. So we got up and left and did not speak with her. I just wanted to make it clear on the record that we, had an encounter with her and did not engage with her.
That's the only microwave on the floor.
There's one, but not one for each room.
Right, that's where it's at though.
No, there's one in, the smaller deliberation.
Okay. Well, why don't we direct them to go there from now on?
I can.
Okay?
I guess Judge Reese is in the BJ's office, is that right?
Let's kick them out.
Objection. Apparently, the clerk's or the court's website is where one of my colleagues.
So that's the camera up. Okay. That, there should be no volume though. Are they saying there's volume?
I believe so. I will check.
Okay. Well, that's a Paul problem.
Yes, I was able to hear discussions until about 5 or 10 minutes ago per one of my esteemed colleagues.
I just turned the microphone off like when I came back in because it wasn't on. So it might not be on.
Okay. That would make sense.
I need a sticky number. I forgot to turn it off.
It's okay. Anything else for the record? Did the defense have any questions of Ms. Grubb about what happened?
No, Judge.
Okay.
Thank you.
I guess you can turn that back on there.
I'm just gonna make some whooping from the very beginning.
It's a couple minutes away. You can wait till then. Oh, you got it on?
Have one.
It's up to you.
Are you gonna use medical records or can I switch them back over out of the way?
Yeah.
No, I just.
Okay, thank you. No problem.
Well, good night. I don't know if that means you have to join on at 8:30. Okay. Yeah.
I'll send you what she had sent. Just copy.
Okay.
Screenshot. It's on the messaging if you're logged in. It's just like a messaging.
I'll just start from this.
Where'd Sam go?
Maybe just step out.
Where's the doctor?
He said it was also showing up on the staff site. I know there was some conversations in here because the two sides were split up.
One last time, we got 5 minutes. Right?
So, you know, agreed, expert. Somewhere.
I need to get. Could you catch that? It was showing up on the dispatch site, not just in court, so that.
Not much I can do about it now. We just have to be careful with the mics off.
Testify, carry,
Okay.
Just so you all know. Sam, whenever you're ready as well. Okay. You want to turn on the machine?
Oh, sorry.
Yeah. It gets admitted as evidence. You ready?
Yes.
Come on. David.
If that's admitted evidence, he said he just wanted to look at it real quick. You didn't tell me what you
You
did.
guys haven't even seen the beginning of it.
That's my book.
You guys are on
You said you
live
wanted to
feed.
look at
Hey, y'all on live feed right
I'm
now.
sorry.
Well, I mean, come on. Okay, if you need to, okay, I mean,
I didn't intend for it to be taken from you to admit it's evidence.
okay. All right. I'm not done with it yet. That's my only problem.
All rise. Thank you.
The shortest seat. The shortest seat, David. This is on you guys.
All rise. Apologize.
Okay. Sorry, everybody's staring at you right now, but that's okay. Ladies and gentlemen, you can be seated. Hope you guys had a nice lunch. We're gonna scribe. We'll probably take a break around 2:45 and then see where we're at. So we're gonna work hard here this afternoon. Any other questions?
Just a few, Your Honor. Dr. Healy, I want to make it clear for the record, you are here paid by the state as the state's witness, am I correct?
Correct.
And your fee is $500 for out-of-court work per hour?
Correct.
And $750 an hour for in-court testimony?
Correct.
And at this point, based upon your review of not just these 14, but the 25 medical records. The state has paid you thus far $10,000 for those reviews.
That's right.
Dr. Ely, in any way are you connected to Mount Carmel Health Systems?
No, I'm not.
And are you connected in any way to Trinity Health Systems?
No, I'm not.
Thank you.
And can I comment one more thing about your
Certainly,
question?
sir. What else would you like
The previous question.
about Mount Carmel Health Systems? Yes, please tell us.
About the amount that I was paid. The amount of time I spent per review was a little bit, there was 25 cases. And at $500 an hour, it takes a long time to review these cases. So I recognize that $10,000 might sound like a lot of money, but it's very labor intensive to go over all these records.
Thank you, sir. I have no further questions, Your Honor.
Ms. Menashe.
Thank you.
Can we turn this on, the Elmo?
On the floor.
Yep, give me a second. Wait just a second. I don't.
Switch over to this?
Yeah. Oh, maybe it's because my computer's not. Let's go this way.
I'm hitting
Lights
it.
are on and everything.
All the lights are on, that's why I don't.
On your computer?
No, I unplugged it.
Okay.
Okay, I'm gonna take it down and bring it back up.
Okay,
That's been changed. This one hasn't though.
I would think if you put it on the overhead now, it'll show up on the computer in front of you.
Oh, I want to put it like that. Nope.
Okay.
Well, hold on. This might do it.
Oh,
Hello.
it's like, don't leave home without it. Good afternoon. Diane Menashe on behalf of Dr. William Husel.
Nice to meet you.
Nice to meet you. During your direct examination, you mentioned how many peer review articles and other publications you had written. I want to go through a number of articles that you've written, showing you what's been marked as defendant's exhibit.
Sorry.
1 indicates letter to the editor, does it not? And the title is Death, Secular versus Faith-Based Considerations. And I'll take you to the last page. Does it appear that you authored that letter to the editor?
Yes.
Okay. I want to draw your attention here to this paragraph if we could. And again, this is a letter to the editor that you wrote, correct?
Correct.
And you state, do you not, as a practicing intensivist, ICU physician, and a Catholic, my opinions are based on the teachings of the Church, especially Pope John Paul II's encyclical, how do you say that word?
Encyclical? Evangelium Vitae?
Angela Vitae, and my anecdotal experience in caring for thousands of dying patients. Those are your words, correct?
Yes.
And you go on to say, do you not, I would preface this by saying that I consider myself a student, not a teacher, of this masterful moment in life, the transition from earthly life into death and the hereafter. Those are your words again, correct?
Yes.
Showing the witness what has previously been marked as defendant's exhibit Eli 2. Does this picture and article look familiar to you, called A Swimming Pool in the ICU?
Yes, I wrote it.
And just to be clear, it indicates that this is authored by you June 17, 2016. Is that correct?
Yes.
And is that you in the tub?
No.
Okay.
It's his son. It's the man's son.
Okay, and where are you, if anywhere, in that picture?
I'm not in that picture.
Okay. This entire article that you wrote, is it not, is about giving a baptism in the ICU.
Yes.
And on page 2, as you're discussing this baptism that was given in an ICU, you write the following, do you not? A senior physician protested that the patient was on a ventilator and said he'd never seen a bedside baptism like this in 50 years of practice. And then you wrote, did you not? There are no shortage of opinions about whether this was appropriate, safe, or even possible.
That's right.
Those are your words.
Mm-hmm.
And here today, the state of Ohio is paying you $500 an hour or $750 an hour. Would you agree with me, Dr. Ely, to talk about what's appropriate, safe, or even possible?
Yes.
And just so I'm clear, this article that you wrote about a swimming pool in the ICU is talking about how you sanction this practice
Yes.
of having a bathtub in the ICU to baptize those that are palliative extubated?
He wasn't extubated at the time. He was still had a tube down, but yes.
So is it your preference then that the baptism happens while they're still on the bed?
Well, it's completely up to the patient.
And just as because you authored this article, I'm curious, if this is done in a hospital, who pays for this?
It was voluntarily done in accordance with the patient's wishes.
That wasn't my question. Who pays for that? There's all the nursing staff and everyone to be around in an ICU unit to have a bathtub so that someone could be baptized. Who pays for that? Do you know?
Well, this particular incident was done at a Veterans Administration hospital. And so everybody in that picture is an employee of the government. And we consider it our job to do what the patient wants, their wishes. So if the patient asks for, in this case, we asked the patient,
Dr.
what's
Eli.
the matter with you? What do you want? And they said they want a baptism, so we provided it.
But yet, that's an interesting thing. Let's talk about that. You do what the patient wants. That's what you just told this juror, right? But on your direct examination, you talked about instances where the family makes the decision, right, to end life support saving measures, and you, as a physician, think more can be done. Do you remember that testimony?
I don't remember those being connected.
Okay, let's talk about showing you what's been marked as Defendant's Exhibit Eli 3. A doctor's prayer seeking saintly aid. Does this article look familiar to you?
Yes, I wrote it.
And again, you wrote this article, correct?
Right.
And I want to, just so the jurors know, that's your name at the end of the article.
Yes.
And just want to highlight some of the things that you say in the article. You say, and I quote, Jesus is there with my patient and me too, correct? Right?
Yes.
And you go on to say how in the morning, when you prepare for work and you walk to the patient's bedside, is this an ICU patient, by the way, when you do this walk?
Any patient.
Any patient, that you write, I kneel, thanking the dear Lord for his many gifts, asking, how may I serve you as I come to the bedside of my sick patient? How might I be an instrument of your healing and peace? Is this why, when you were asked on direct examination what you do, you mentioned that you're a healer?
Well, I think that the call to be a physician is to be a healer. It is not related to this belief. People are healers if they chose to be a physician, regardless of their spiritual path. Some of my favorite physician healers, some of the people I know who to be the best, are atheists and agnostics, Buddhists, Muslims. So it has nothing directly linking it to Catholicism or Christianity.
Well, you would agree with me that Jesus is not a Buddhist concept, correct?
Well, I love many things about Buddhism. One of my favorite, Tao Te Ching 65 is one of my favorite Buddhist concepts.
So,
Answer her question.
yes, thank you.
Jesus was not a Buddhist.
Okay, so, and then I want to go on continued in this article. So, these are your words. So also, do I engage the spiritual counsel of my quote unquote colleagues on high who have already walked the paths I currently tread? And then do you not in this last paragraph note, I have learned that this sacred journey is much more direct, quick, and sure if I walk it consciously beside the Blessed Virgin too. Those are your words too, right?
Yes.
And she keeps me staring at Jesus, guiding me along a more peaceful path than I would otherwise choose. And the name of this article is A Doctor's Prayer Seeking Saintly Aid, correct?
Yes.
And you wrote this article in your current capacity as a physician.
I didn't write it underneath the cloak of being a physician. I wrote it as just a person expressing spiritual values.
Sorry, let me go back to this then, since you made that mention. However, it says associated with your name on this article that you are a professor of medicine and critical care at Vanderbilt University and president of the Nashville Guild of the Catholic Medical Association, does it not?
It does.
And that is certainly your professional credentials associated with your name?
I always include my professional credentials.
And similarly, you included your professional credentials when you wrote Defendant's Exhibit Eli 4, correct?
Correct.
And this article is called His Enduring Gift. What do we make of the Eucharist and transubstantiation, correct? And just...
Sorry, did you answer?
Yes.
Okay. And this is another article that is written, at least co-authored by you. Do you agree?
Yes.
I want to go back to this back page, the second page of this. When you quote, do you not, Dr. Eli, the privilege of suffering?
Yes.
You do. And then you go on to say, as a physician, let me draw your attention here, I incorporate science into my faith to acknowledge that the Eucharist meal enters into the actual workings of every cell in our bodies. This potent reality must change life intrinsically, and even down to the most basic of events. Those are your own words, are they not? Eucharist meal enters into the cells of every body.
Right.
And you incorporate that belief as a physician.
Yes, I bring my faith into my practice.
It was mentioned about the Nashville Guild, which is it a subsidiary or of the Catholic Medical Association, or is it an affiliate? What's the appropriate word for that?
It's just a guild of there are many around the country, hundreds of them around the country.
And you founded the Nashville Guild, which is associated with the Catholic Medical Association, correct?
Correct.
And on September 25th, 2019, during the Catholic Medical Association annual educational conference in Nashville, you spoke, did you not?
Yes, I did.
And during that speech, you indicated the following, did you not? Quote, "The church has truth. I'm going to bring the truth to patients of all faiths and no faiths with love." End quote.
Yes.
And then you went on to say, did you not? The beauty of faith-based healthcare is that science and faith are not separated. Neither staff or patients have to put their faith aside. Do you remember saying that at the conference?
Yes,
To an audience of your peers?
yes,
And then you also said at that same conference to the crowd, quote, by ending a person's life, we destroy a person's intrinsic worth. We turn a somebody into a nobody. Do you remember saying that?
yes.
Now, I know Ms. Sawyer asked you about your CV, which lists a number of awards that you've received. I did notice, though, that you didn't include that you had received an award for outstanding service to the pro-life movement. You didn't list that in your CV, did you?
I don't know if it's on there or not. If it's not, I'll add it.
But you have received that award, have you not?
Yes, based on my work with euthanasia.
No, based on your work with the pro-life movement from conception to natural death.
Yes, which was awarded because of euthanasia.
Doctor, are you part of the pro-life movement?
I'm not part of a formal pro-life movement.
Are you an advocate for pro-life?
I do nothing formally to advocate for pro-life.
But you received an annual award in recognition of your work for the pro-life movement.
Because of my work with euthanasia.
Well, you don't believe in euthanasia.
Right.
Okay. And then I want to go to this, showing you what's been marked as Defendant's Exhibit Eli 6. Now, admittedly, this is an article from the Dispatch, which is not authored by you, correct?
Correct.
But it is attached to your CV.
I don't know.
You don't know that you have actually attached this to your curriculum vitae?
It's in my CV.
Yes.
If I was interviewed for the article, I would have included it in there.
Okay. And so so when you're interviewed and quoted in the media, you then attach that interview to your curriculum vitae?
Yeah, there's a section in this curriculum vitae, the CV, which it has for media. So if I'm involved in media in some way, then I put those media links into the CV.
And so you're using those media links as a way to bolster or a way to somehow raise your profile. Would you agree with me on that?
Objection as to the word bolster, Your Honor.
Okay.
It's just a standard thing that people in academics do to include a media section in their CV. So all of us put media engagements onto the CV comprehensively. It's standard.
When you say all of us, who's all of us?
People who are in a professorial role at academic medical centers keep a CV. And the way that we do that is there are certain sections on the CVs that are, for example, at Vanderbilt, there's a usual profile for your CV.
My question, though, is not about your CV. My question was, when you say we do that, who is we? I'll try and keep my questions more succinct.
People who are in academic medicine.
People who are in academic medicine and hired as experts giving media interviews?
Oh, yes.
As a matter of practice, they
Yes.
are. And I assume that if you attach this interview to your CV for others to see, that you would stand by the article's representations of what you said.
Not true.
No.
No.
So you would attach to your CV something that is actually inaccurate.
I would attach to, that's not what you asked. You said that I would stand by it. Because I put whatever I'm in the media for on the CV, regardless of if I think it's accurate or not, because it's just protocol for me to put my media engagements onto my CV. But there may be things in that article that I completely disagree with.
Okay. But it would just be on your CV anyway.
Correct. In other words, I don't pick and choose.
Another question.
Showing you what's been marked as Defendant's Exhibit Eli 7. Do you recognize this?
Yes,
And right there, see
Yes.
that you authored this?
I did.
Is it Sonnet 30, XXX,
Yes,
Love, Dignity, and Dying?
yes.
And in this article, do you not talk about a particular patient named Jessa?
Yes.
And when you talk about Jessa in this published article, do you not talk about how some team members continue to view her quality of life as unacceptable and even, quote, hellish? Correct?
Yes.
But despite your colleagues saying that she's suffering and she's in what could be described as hell, you go on to indicate that you begin to read her Psalms after asking Zach if she might like that.
Well, what happened was that her
No,
husband.
doctor, I'm just curious. Oh, I'm sorry. I'll just keep it Zach. You asked Zach, do you not, if Jessa would enjoy being read to, correct?
Her husband.
And then, is that correct? Yes,
Yes.
you do. And this is in your role as an ICU intensivist. You asked if she'd like to be read to?
Yes.
And then as an intensivist in an ICU unit, you read her Psalms.
He told me what her favorite readings were, and he wanted me to read to her, so I did.
And so you did. And then as time went on, you indicated that Jessa had lifted us above the physical realities of our existence into something mystical. Mystical isn't a medical word, is it?
No.
And then you go on to say, do you not, I cannot explain it, and I almost do not even want to try. Let's just say that she gave us a private treasure, one I will always savor as a gift I never expected or deserved. And this is a woman that your team members in the ICU had described her situation as hellish. Correct? Yes or no?
One team member, but the others disagreed with her, and
I'm
she
sorry.
herself disagreed.
Dr. Eli, let me focus you. Does that appear to be team members plural or team members singular?
Plural.
Your words, right?
Okay, do you have a copy that's not marked that we can attach
Absolutely.
one and prime?
We'll do that.
Okay.
Let's talk about the doctrine of double effect, because I'm showing you what's been marked as defendant's exhibit, Eli 8. You recognize this?
Yes.
And this is another article that's at least co-published by you, correct?
Yes.
And it's called Distinction Between Good Palliative Care and Attending Death. And I bring this article up because as I heard your direct examination, when you were asked about the definition of doctrine of double effect, you looked for a long time at the jury and you gave a bunch of examples about good outweighing bad, bad outweighing good. Do you remember that outweighing you used a number of times?
Yes.
And outweigh was a word that you reiterated a number of times to this jury. Would you agree with me?
Yes.
In this article, you write, do you not? We must always ask yourselves, quote, is everything we are providing, such as sedatives and narcotics, intended to comfort and ease suffering? If the answer is yes, any potential side effect, such as hypertension or respiratory suppression that may result in the shortening of life or ethically justifiable because of the rule of double effect, even if they may be foreseeable. Doctor, I don't mean to cut that short, but would you agree with me as the text continues on, that being your own words, that nowhere in the definition of doctrine of double effects do you ever mention this outweighing or weighing process?
Yes, that is implied in that sentence that you just read.
I remember on your direct examination, you mentioned a number of times that you were a member of the Society of Critical Care Medicine. Is that right?
Right.
And that you have been regularly, repeatedly, a number of times throughout the world, been part of committees through that organization to work on guidelines. Do you remember that testimony?
Yes.
Showing you what's previously been marked as defendant's exhibit Eli 9. Do you recognize that?
Yes.
Fair to say it's a Society of Critical Care Medicine. It's the standard operating procedure manual. And I assume as a member of the Society of Critical Care Medicine, and as someone that's on a committee to work on the guidelines, you've reviewed the procedures manual.
I don't know this particular document.
You're not familiar with the procedures of the organization?
I did not author this document, and I cannot say that I'm familiar with this particular document, no.
Okay, then I want to just turn to this page 8 of the document, marked as Defendant's Exhibit Eli 9. Page 8 of the document. It appears there's a section called Expert Witness Rules. Would you agree with me?
Yes.
And the acronym for the Society of Critical Care Medicine is SCCM?
Yes.
Correct? Okay. And would you agree with me, second paragraph highlighted, guidelines panel members are discouraged from serving as expert witnesses in legal proceedings. An expert witness for the purposes of this manual is an individual who testifies at trial or gives sworn evidence in a case in which that individual is otherwise unaffiliated during that individual's term or for 1 year after publication of the guidelines. You are currently affiliated with this organization, correct? You indicated that.
I'm not currently a member of this guideline committee at all. I haven't been for the past 5 years.
Now my question, you're currently affiliated with this organization, are you not?
With the SCCM, yes.
Yes, and then it goes on to say that disclosure must be made to the organization, and the individual must declare that such testimony is not given on behalf of SCCM.
But it's only on behalf of the guideline panel members. I'm not a guideline panel member.
Okay, I want to just focus your attention right here. One moment. So when you testified on direct that you're part of this guideline committee, when was the last time you were part of a guideline committee?
We published those guidelines in 2013, and I've not been on the guideline committee in the past 10 years.
So it's 2022. So you actually, and I heard your testimony to say you were constantly on this guideline committee, but did you now your testimony that the last time you were on a guideline committee was 10 years ago?
I said I've been repetitively on guideline committees for over many years, but the guidelines I talked about today were those of the SCCM that were published in 2013. And I came off of that guideline committee after we published that document, which is why I'm able to testify if necessary. I've never done it until today. It's my first ever time to testify in court is today. But I've not been on that guideline committee in a decade.
Okay, and the decade is 2012?
2013. We published it in 2013.
I'm going to talk to you, and this is a summary, Your Honor, and I have shown this to the state. You indicated a lot of issues with the pain scoring. And I'm going to talk about each patient individually. But until then, I just wanted to go to a point generally. You indicated that pain scales of 10 were not possible. Remember that testimony?
For the CPOT.
Right. And I just wanted to make sure that we're clear as we are about to enter into discussing these patients, that there are.
Council sidebar. Ladies and gentlemen, entertain yourselves.
Your Honor, I moved it up.
Well, it's a little late.
Okay, well, I just moved it up.
Okay, on the break, we will talk about it.
Okay, so thank you, Judge. Sorry about that. So I just want to make sure we're clear, though, that according to the medical records that you reviewed, as policy at Mount Carmel West, the individual that enters in the pain score on the electronic medical record is a nurse.
Usually.
Well, in every instance, in every patient that we're talking about today, it's a nurse.
I think so.
Okay.
But there are times when other people do it, so.
Okay, I'm just talking about the 14 patients that we're here for today. In every one of those cases, the individual that typed in the pain score was a nurse.
My knowledge.
And you know that Dr. Husel is not a nurse.
Correct.
So I want to just go through, just as a summary, that then every person, according to your testimony, that had put in a score of 10 or 8 was a liar.
I didn't say, I never used that word.
Okay? You said it's not possible and it could not be.
Do you want me to explain it or not?
So on cross, right? It's a little different from direct. And so I'm going to ask you questions, and then I'll make my questions tighter so it's easier for us. Tricia Sauber, with respect to Joanne Belisari, put in a pain score of 10. You were not at bedside, correct?
Correct.
You did not interview Tricia Sauber, correct?
Correct.
Going to Ryan Hayes, it indicates that the nurses, 2 nurses, Troy Redmond and Tyler Springer, both independently indicated the pain score of 10. You interviewed neither Troy Redmond nor Tyler Springer in the course of your work in this case, correct?
Correct.
Beverly Schitzringer, Nurse Derek, it was bad to have. More was me than anyone. Derek Dreyer is the nurse on that, and pain score is an 8. Is that correct?
Correct.
You never interviewed Derek Dreyer, correct?
Right, I never interviewed any of these people.
Okay, so that goes Jacob Deemer, a 10, Jamie Burke, a 10, Derek Dreyer, a 10. You never interviewed any nurses.
That's right.
Did you request to interview nurses when you saw that there were pain scores of 10?
No, I just expressed that it didn't make any sense to go from zeros all day long to a 10 all of a sudden out of the blue.
And of course, you're familiar as being someone that works in the ICU, that things in the ICU can be chaotic at times, right? And you have,
Gotta give an all
Yes.
response.
and you have no independent reason to believe that, for instance, Ms. Sauber is a liar. Is that correct?
My judgment is
That's
based.
just my question, doctor, is you have no independent evidence. And I remember
Okay,
you
right.
said you go on the evidence
Right, I do not.
that she's a liar.
I do not know if she's a liar or not, and I didn't use that word.
Same question. Any nurse that entered a 10, you have no independent evidence, correct, that they're lying.
I never called them a liar.
I want to go to, before we talk about the patients, I want to talk about the importance of accuracy in your report, because it dovetails on the questions about the pain scale. Being accurate in your report, I'm sure, in a case like this is very important, is it not?
Yes.
And do you write your own reports?
Yes.
Do you actually physically type them, or do you have
I have somebody else type them.
you have someone else type them?
I'll usually dictate them.
Okay. And then, but surely, in advance of
You got no signal.
giving a report over, surely in advance of giving your report over to the state of Ohio, you reviewed it for its thoroughness and accuracy, correct?
Yes.
And then again, I presume
But
that.
there are some errors in there, though.
Okay, and did you make the state of Ohio aware of those errors?
I just know that I, over the time in rereading it, that I noticed that there were some things in there that weren't totally accurate, and I don't know so I think I missed a few, like numbers of 8 to 10 or something like that, and there could be a few of those in there.
So, and I just want to be clear. So what has been marked as State's Exhibit 30 has errors in it.
There are no errors on drug medications where I can be specific if you'd like for me to. I think that there might have been a few times where somebody included a different type of visual analog scale instead of the CPOT. And the visual analog scale is another way of measuring pain. And sometimes a nurse might write 10 instead of 8 because they're using a visual analog scale. So when there's a discrepancy between an 8 and a 10, if it was the CPOT, that wouldn't have made sense. But if they were using the visual analog scale, it could have been that. It still didn't explain why it went from zeros to 10, but that would clear up the 8 to 10 issue.
That would certainly clear up the 8 to 10 issue and the things that you said about the 8 to 10.
But the main point that I was making was that you don't go from zeros to 8 or 10 in a matter of minutes. That's the point I was trying to make.
And so I just want to be clear, before you got here today, and you knew that you would testify under oath about this exact report, did you communicate to the state of Ohio that there are errors in your report?
When I was reading this last night on the plane over, I thought,
Did you communicate to the state of Ohio there were errors in the report?
no, I did not.
Okay, so I want to talk to you about the difference between an opiate and an opioid. Opiate is O-P-I-O-T-E, correct?
Well, I don't think you spelled it correctly, but I know what you're getting at.
No, you tell me, what's an opiate? How is it spelled?
O-P-I-A-T-E.
Okay, and what is an opiate?
Opiates and opioids are two different words that are used interchangeably for narcotic medications.
Doctor, actually opiates and opioids are not used interchangeably, correct?
Well, in common parlance in the hospital, lots of doctors and nurses do use those terms interchangeably.
Okay. In the CDC guidelines? Thank you. Sticker, please. Your Honor, may I approach so I don't have to toggle back and forth? Thank you. You like that?
Just want to ask you some questions about your testimony that the words are used interchangeably.
If I may approach, showing the witness what's been marked as the evidence exhibit Eli 10. Just generally, Doctor, what's the title that appears on defendant's exhibit Eli 10?
Guidelines for prescribing opioids for chronic pain?
And that's issued by, it appears, the CDC?
Correct.
Does it say opiates and opioids, or does it just say opioids?
It says opioids.
And actually, if you could, the third sentence down with respect to, if I may approach him.
Opioid therapy?
No, the last sentence. Does it not indicate there that the guideline is not intended, the CDC guidelines are not intended for palliative care?
It says the guideline is not intended for patients who are in active cancer treatment, palliative care, or end-of-life care.
Also, wouldn't you agree with me that opioids are drugs like heroin, other natural type drugs versus opioids are opiates? But then there's also a synthetic component that makes something an opioid.
Yes, but what happens in real life in the hospital, a doctor will say, did she take an opiate? And another person might say, did she take an opioid? So in regular practice at the bedside, people just use either of those words interchangeably on a regular basis. I'm not sure where you're going with this, but I just want to make the distinction
Okay, Todd,
yeah.
it's not your job here today to anticipate the question, okay? You're better off to answer the question, we can move on to the next one.
Okay.
Because
Mr. Nashi.
thank you, Judge. Because it's important, is it not, that fentanyl is an opioid, correct? The other medications you talked about, the Dilaudid and the Versed, those are opioids, correct?
Correct.
They're not opiates. You would agree with me, right?
I actually, to be totally honest with you, I couldn't even tell you, there's no clinical practice distinction between these two drugs. All three of those drugs get referred to in regular clinical practice as both opiates and opioids on a routine basis, day in, day out in the hospital. It just happens. People don't make that distinction clinically. And there may be on paper some distinctions, but in regular practice, it's not one.
Okay, so what I will do then is, as we go through the medical records, I will show you how every time in this case, the word opioid is used. But would it surprise you to know that in your report,
use the word opioid 0 number of times.
That's kind of what I'm getting at.
Wait, I want to spell it right.
Okay, the question was, did you not?
I did.
You use the word opioid in your report?
Opiates.
Oh, so you use the word opiates repeatedly throughout your report, do you not?
Yes.
You never use the word opiate.
Right, correct.
Okay, let's slow down for a second. Poor Sam here's fingers are about ready to blow.
Fair enough.
Okay,
Yep.
are you caught up there, Sam? Remember, she's got to get this down.
Yes. So going
Let her
back,
finish the question, and then you answer.
so going back to these issues of,
Okay, you got to speak up. I can't hear what you're saying.
and I just so we're clear, the report that you testified to today with respect to the 14 patients is 22 pages in length. Does that sound accurate?
Yes.
And I noticed on your direct examination that when you oftentimes gave opinions, you indicated to the jury that you gave opinions to a reasonable degree of medical certainty, correct?
Correct.
And you do so use that language because there is no 100% in medicine, correct?
I used that phraseology because I was asked it by the trial jury, but yes.
Oh, so the state of Ohio asked you to use that phrase?
Well, today, when she asked me, is that to a degree of medical certainty? So I said yes, but I do agree with it.
You would agree with me, just in your general understanding of science and medicine with your advanced degrees, that, like, for instance, even DNA isn't 100% certainty, correct?
In the realm of infinite possibilities, DNA is as certain as you can get to 100%.
But it's not 100%, right?
Well, I don't think anything in life is really 100%.
And you would agree, would you not, that experts with similar training and similar qualifications can have different opinions?
I do agree with that.
I'm going to go to issues with completeness. Now that we've talked about accuracy, I'm assuming that it was also important for you to make your report in this case complete
Yes.
and thorough.
I think it was complete and thorough.
And I know you mentioned the state is paying you $500 for out of court, and today you're receiving $750.
That's right.
I noticed on the first contract that you signed in March of 2019, there was no cap. Is that correct?
I guess so. I don't remember.
And the second contract you signed, though, recently with the attorneys at this council table has a cap of $30,000, correct?
Yes, I think so.
So tell me, in addition to the $10,000 that you have billed, how many hours have you spent reviewing the records in this case?
It's all included in that.
So in the $10,000, it includes all the review of the records.
Right. I have no other time spent reviewing it.
And the math on that, if I'm right, is 20 hours.
Correct.
And then included in that 20 hours is also the writing of your report, the dictation of your report.
Right.
Is also included in that $10,000 bill the time that you spent with the original prosecutors on this case, Ron O'Brien and/or Jimmy Lowe?
That actually was the bill to them. I haven't billed anything to this team to my knowledge. Maybe I did, but I'm not sure.
And I'll get to that second part of the work, but the first 10,000, did that 20 hours of work, we know it included reviewing all of this, it included dictating your report, did it also include meeting with prosecutors Ron O'Brien and Jimmy Lowe?
On one occasion, they came to Vanderbilt and we met for a few hours one day.
And how many hours was that meeting?
I think maybe like 4 hours.
And I won't get into what was discussed, but did they bring with them at that 4-hour meeting any medical records?
They did bring medical records. I'd already had some given to me.
And when you say you had some given to you, how had those been provided?
Mail.
And were those records that you had been provided by mail, was that the only time in this case that you ever provided records by the state of Ohio?
No, they have also emailed me medical records just recently, last week.
Okay. And did you update your report then accordingly to indicate that you had received supplemental information?
No, I did not. The report was already generated. And last week when I got the information sent to me again, which to my knowledge is just the same information over again, I did not update that report.
Did you review them? Did you review what they sent you a week or so ago?
I reviewed it to some degree. It was just very busy last week, so I didn't go back all the way through it. I reviewed my own report again, and medical literature is what I focused on to see if there was any new medical literature giving us any evidence of high doses of fentanyl, and I couldn't find any.
Well, they sent you those 3 articles, did they not?
Yes, and I read those.
And those articles that they sent you didn't talk about any max dosages, did they?
No, there's no mention of a max dose because technically.
No, and Dr. Eli, actually, those 3 articles they sent you aren't even about palliative extubations, are they?
Those 3 were not about palliative extubation.
And so the visit with Mr. O'Brien and Jimmy Lowe was for 4 hours. Do you remember the day of that visit?
No, I do not.
Do you remember the time of year
I really don't.
or the year?
It was probably 2 years ago.
So 2020? I'm sorry.
I don't know the year. I do not know the year accurately.
But the meeting took place down in Tennessee.
Yes.
And I know I asked you about interviewing those nurses on the screen, but just to be clear, at no point in time have you ever interviewed any nurses with respect to these 14 patients. Correct?
That's right.
Nor have you interviewed any attending physicians with respect to these patients.
No, my opinions based today are on the records themselves.
Right, nor have you interviewed any treating GI docs or nephrologists or any other doctors that are noted in these medical records.
I've not spoken to any of the clinicians. I went on the medical records.
And is it fair to say that throughout the course of this case, you had the ability to email the prosecutors if you had questions or needed supplemental information?
I could. I have their email addresses.
Did you at any point in time email them and ask them for any audio interviews that the nurses might have given to the police?
No, I consider it their responsibility to give me if they think there's something important. So I've not pursued any of those interviews.
And so have they ever mentioned to you the patient name of Tracy Young?
I don't recall that name.
Have they ever talked to you about a patient that actually received 2,500 micrograms of fentanyl over the course of time from Dr. Husel and lived for over 9 days?
I do not know about that case, but that's not surprising because over a period of time, that happens on a routine basis.
So someone could live on a routine basis after a palliative extubation for 9 days after receiving 2,500 micrograms of fentanyl?
If the drug is given in multiple smaller doses over time.
Let me be clear. Same answer, doctor, if the dosages were 500, 500, 1,000, and 500?
It is in the realm of infinite possibilities. It is conceivable. It is highly unlikely, but it is possible.
And we know it's conceivable. Well, the medical records speak for themselves, right? Do we agree with you on that?
Yes.
You mentioned, and I use this as, for example, you mentioned throughout your report in today's testimony that palliative extubation does not cause pain. Do you remember that? It's not painful. Remember
what
that?
I said was that after interviewing many hundreds of patients, over thousands actually, that is not a common complaint at the time of extubation pain. And by the way, I'd like to
Wait, doctor,
Hold on. Questions and answers.
just want And sometimes I ask questions that state the obvious, but I still have to ask them.
Okay.
You talked about the thousands of interviews that you did with patients that survived the palliative extubation, right? You would agree with me that,
I'm sorry. Did you answer that?
Oh, yes.
you would agree with me that anyone that died after being palliative extubated couldn't be interviewed.
Yes.
We don't know if they suffered pain.
We don't.
I want to go back to, one moment.
Right here.
Yep.
You talked about, on your direct examination, the dosages that you've given of fentanyl in your practice, in your career, right?
Yes.
And you indicated, I think, that while you've given 1,200 over a 24 period of time, but not as one dose.
Correct.
And then you talked about dosages that you have given on an individual basis, like 100 or maybe in a circumstance 200, correct?
Correct.
But do you remember telling these jurors that nothing over those amounts would ever be necessary?
Without having had prior doses of fentanyl. That, in other words, it would only be necessary if the person is receiving multiple doses of fentanyl and working their way up to those doses. It would not be necessary.
So it's your testimony then that the first dose of fentanyl that a patient receives, decision to palliatively extubate is made. The first dose of fentanyl, 5 necessary. That's your testimony.
I know of no cases where anyone has ever given as a first dose 500 of fentanyl unless the person has been already on these narcotic drugs. If they have been on those narcotic drugs, then that is absolutely possible. And there's no technical upper limit if the person had been receiving them over time, which was not the case in these 14 patients to my knowledge.
Showing you what's been marked as,
Okay.
there's no option other than counsel-only documents.
There's no other availability?
No, we asked.
Ladies and gentlemen, you're disregarding those words, counsel only. That's a logistics issue, okay? It's not relevant to you.
Thank you.
Showing you what's been marked as defendant's exhibit Eli 11. Just drawing you to your attention, since you've reviewed these medical records, does this just generally appear to be similar to other progress notes that you looked at in the Mount Carmel West records?
It does.
And if I could draw your attention down to this level right here, it indicates that there's a nurse progress note. Do you see that?
Yes.
And the time on that, nurse progress note right here, does it say, it says, does it not, patient extubated at 2010?
Yes.
500 micrograms of fentanyl and 6 milligrams of Versed given before extubation.
Right.
And it looks, that's RN Haas.
Right.
And then, fair to say that the next progress note, doctor, does it appear to be written 5 minutes later?
Correct.
And does it say, patient lifting self out of bed, gasping for air, orders for more sedatives given?
Right. And that is exactly what I would do too if that person was experiencing that.
So you would wait, so doctor, you would wait for the patient to lunge and
No.
gasp for air?
If I saw them do that, I would, out of the desire to reduce their suffering, I would actually give that order for more sedation.
And you recognize that 500 was given?
Yes.
I'm going to go through the patients now.
I'm just generally going to have your report up here, just in case there's any questions or you want to refer to it. But I'm going to go through each patient.
Okay.
Joanne Belisari. She gets to Mount Carmel on the 22nd of April, correct?
Correct.
And then 9 days later, on May 1st of 2015, she's transferred to the ICU and intubated. Is that right?
Correct.
And then a full week later, on May 8th, she's still intubated and in the ICU.
Correct.
Noted in paragraph 3 in your report that you noted the medical record that said she had active fixable respiratory issues. Do you see that?
Yes.
But isn't it true that not included in your report was page 260 of your medical record that read, quote, patient is on full vent support measures, including vasopressors and mechanical ventilation. Without such measures, she would not survive, end quote. That doesn't sound fixable, does it?
The way that person worded that, no.
And then let's talk about here that you indicate Ms. Belisari had multi-system organ failure, but continued to receive aggressive support measures. Do you see that in paragraph 3?
Yes.
I noticed in your report that you didn't list the life support saving measures that she received. Is that fair to say?
Well, when you're in multi-organ failure on life support, it's kind of part and parcel. We know that somebody's probably on vasopressors and mechanical ventilation at that time.
You would agree with me that as part of your work as an expert witness, that it's important to be objective, would you not?
Yes.
And certainly fair.
Yes, absolutely.
And if there's facts that don't coincide with your opinions, or that might even be helpful to Dr. Husel, to maintain objectivity, you would want to include those.
Yes, absolutely.
And so this is why I mentioned the aggressive support measures, because isn't it true that with respect to this patient, there was 14 life-saving measures that Dr. Husel himself gave Ms. Belisari?
And that's absolutely fine, but the relevance here is that there was nothing in her clinical story that built up a case that would require 1,000 micrograms of fentanyl at the time of her extubation. So that's the main point.
But Dr. Eli, I remember the prosecutor asking you about intent. And we know that the doctrine of double effect is all about what your intention is, right?
Right.
So isn't it important to look at the whole picture as an objective expert? Despite being hired by the state, you still want to be objective, don't you?
Absolutely.
Isn't it important to look at the whole picture when being asked by the state of Ohio as to that man's intent is to have a clear understanding of the 14 things he did to save her life before he ordered the dosage fentanyl?
In every case here, I reviewed very thoroughly the entire set of what was being done for these people. And I agree with you that it's important to be comprehensive in the evaluation. And after that evaluation, nothing justified 1,000 micrograms.
Okay. And you know what?
Let's have a new question.
So you didn't include the life-saving measures that my client
Okay,
provided.
counsel, let's approach. Ladies and gentlemen, get busy over there.
They don't, I mean, maybe.
Oh, I see. Oh, right side. I also know that. I want to cross the line. What is this thing? I'm sorry. This is just
Can you get me something out of my briefcase? Can you open my briefcase and get there's an orange lumbar support pillow? I'll get it at break, sir. I'll get it at break. I'll get it at break. I'll get it at break.
Which one is the right hand? This one is yeah. Which one is
Okay, ladies and gentlemen, thank you for your patience with us. Ms. Menashe, next question.
Thank you. Next question, or
Or you repeat the same question.
I'll go to the next, but we're on the same line. Thank you, Judge. So just a leading, so I can circle us back. The aggressive support measures. Would the aggressive support measures be, would an example of that be giving a blood transfusion to a patient when their hemoglobin is low?
Yes.
And then you know, based on your review of the medical records, that Dr. Husel did that an hour before Ms. Belisari's family made the decision to withdraw life support.
Correct.
He did that.
Yes.
And similarly, backing that up, would another life support measure be to restart vasopressors or increase the dosage of vasopressors?
Yes.
And you then know, based on your review of the medical records, that 2 hours before Ms. Belisari's family made the decision to withdraw care, he did that for Ms. Belisari.
Yes.
Going to paragraph 4 of your report, you talked a lot about the Glasgow coma score. Did you not on your direct?
Yes.
And we'll just call it GCS, but I wanted to
Yes.
restate the acronym on the
Okay.
cross. It indicates that she was 3, was it not?
Correct.
And I know your testimony, that your preference is is for the nurses to score the GCS along with other scoring metrics. That was what you testified to on direct, right?
Yes.
But you know, based on the review of these records, that seems to have not been the general practice at Mount Carmel Health.
In many cases, it wasn't. They used both tools, but a lot of times they were just using the GCS.
And not a significant number of times they're just using the GCS, correct?
Yes.
So I heard your testimony about what you and best practice is to have the 3 scales and cumulatively look at that. But at Mount Carmel West, and more often than not, they're using the GCS scale.
Which is fine. I mean, a GCS of 3 is deep coma, so it provides a lot of information in this case.
And so, and also the GCS is measured by a nurse, is it not?
Yes.
And in this case, she's noted a GCS of 3, and we know from your direct that that's the lowest score possible on a
Correct.
GCS. Like
Yes.
virtually no chance of surviving at a 3.
No, that's not what that means. Because I can make you a GCS 3 by giving you medications and such. So the GCS of 3 doesn't mandate lack of survival or the duration of survival. We've had people with GCS of 3 live for 10 days to a month and then recover.
But Dr. You do the scale so that you have a metric.
Right.
So that the nurse does the GCS, right?
Right.
So that when someone like Dr. Husel walks in or pulls the electronic medical record up, he understands where he is and where the patient is,
Right.
correct? So it's important.
Yeah, absolutely. I'm supporting its use big time because it helps you know if you need more medication. In this case, it would indicate you don't.
And the 3 is the basement.
3 is the basement. No more meds needed.
And the 3 was in existence before the fentanyl was ordered, correct?
Correct.
The 3 was in existence before her family, as indicated by the medical records, decided to withdraw care, correct?
Withdrawal support.
Withdraw support,
Right.
correct?
And it's what indicates that she's not suffering to the degree that would require 1,000 micrograms of fentanyl. It tells us where we are.
So I'm gonna work again on my questions being more specific so that I'm sure to ask yes or no. I want to talk about, we're now going over paragraphs 1 through 4. Let's talk about what isn't in your report with respect to Ms. Belisari. We talked about this opioid naivete or lack thereof. I didn't notice in your report that you indicated that in fact she had received over her 10-day period of stay the equivalent of 12,000 micrograms of fentanyl. Did you include that in your report, doctor?
No, and this report is not, I never intended this report to be comprehensive like that. It's a succinct summary of an incredibly thick amount. So I do not claim that it contains all of those things. But over that many days, that's not that much fentanyl.
So it's more than 1,000 micrograms of fentanyl a day. And I heard you just now say that you didn't include all the details in your report, but certainly when a doctor is determining an appropriate dose, that tolerance is an issue to be considered, is it not?
It is.
With respect to the time of death, You were asked as to every patient, your opinion as to the cause of death. Just want to be sure that we understand one another. Based on your entire review of these medical records, right? You do not know, as you sit here, but for the fentanyl, when Ms. Belisari would have died, correct?
That's right.
You do not know, based on your review of these medical records, the moment in time when her heart stopped beating, correct?
Correct.
Further, you do not know, correct, if her heart stopped beating first or her breathing stopped first.
And nor would it be relevant.
To move to the next patient. Ryan Hayes. And the code sheet, so here's a sticker. Oops. Again, section of your report with respect to Ryan Hayes, just as a courtesy, I have it up there. Are you familiar, based on your review of the records, the code sheets that Mount Carmel used as a matter of practice, what those look like?
I have seen them, but not recently.
Okay? A moment. May I approach, Your Honor?
You may.
What's been marked as as well. You can just flip through those.
Okay, hold on. Is it DFY 12?
Eli 12?
Which one, what is it? You said defense 12. I just want to make sure it wasn't an Eli in there. You said defendants 12. I didn't hear Eli.
Eli 12.
Okay. Just clarify. I think he's ready for you.
Do those, based on your review of defendants Eli 12, do those appear to be code sheets belonging to Ryan Hayes?
Yes.
And do you agree with me, based on your review of the records in this case, that code sheets like the one that I'm showing to you are created internally when someone at Mount Carmel West is having cardiac arrest,
Yes.
is actively dying?
Yes.
And you would agree with me, would you not, that there's even a box at the top of the code sheet that indicates whether they survived or died?
Correct.
And for purposes of the record, the patient on this code sheet appears to be whom?
Do what?
Where my pen is, the patient?
Is Ryan Hayes.
Okay. Fair to say, Dr. Eli, and I'm happy to put your report back up, but in your report.
You put it back up just for a second, if you will.
Your report?
Yes, please.
Sure, of course.
If you're going to ask me about it.
Sure. You do not include the dates or times or the information with respect to the code sheets.
Yeah, I did not. I mentioned that he had come in. Yeah, correct.
So, but you would agree, would you not, that when you're making statements about which patients can live and which patients can die, it's important to have a better understanding how many times a patient has actually been actively dying and been saved. Do you agree that's important information?
Yes, I do. And I absolutely factor that into my thoughts about the cause of death.
Were you provided the autopsy report with respect to Ryan Hayes? Did the state provide you with that?
I do not recall seeing his autopsy report.
Would that have been something important for you to review when coming to your conclusions with respect to Ryan Hayes?
No, not really.
And I mean, tell me, circling back to that completeness question, tell me why it wouldn't have been important to review the autopsy report.
Because the autopsy report won't tell me the effect of a medication on stopping somebody breathing. There's nothing in the autopsy report. And this patient already has brain damage from being found down from a drug overdose. The key factor here was that because of what had already happened to him, there was no medical indication to receive 1,000 micrograms of fentanyl, 10 milligrams of hydromorphone, and 10 of midazolam. And the autopsy report gives me no help with determining the inappropriateness of those medications.
Okay. But then tell me if that's your same answer after we talk about Narcan. Because in your report on paragraph 1, you indicate, do you not, that he's given Narcan. Let me find the exact sentence, sorry. Was administered Narcan. Do you see that?
Yes.
And the way that you present it in this report is that he was given Narcan nasally.
Okay, yes.
That's correct, isn't it?
I think so.
However, the medical records indicate that he was given Narcan at the hospital through an IV.
Okay.
You would agree with me, would you not, that Narcan through the nose, when administered, leaves my system in 6 hours, right?
Yes, yes.
And we know that Narcan stops the effects of something like fentanyl.
It's attempted to, but it's actually not as effective against fentanyl as it is other drugs.
Okay, well, just EMS arrives on the scene and there's an overdosed individual. Drug unknown. Common practice that you surely know as an ICU physician is for EMS or medical personnel to give an injection of Narcan, right?
Yes.
To try and save their life.
Yeah.
To stop the effects of whatever drug that's inside their body from killing them, right?
Yes.
Lifespan of Narcan in the nose is 6 hours, right?
Generally.
Narcan through an IV, 72 hours. Correct?
Correct.
And you know from the Ryan Hayes records that he got Narcan through an IV in the hospital, right?
Correct.
So when you said on direct that there was no indication from the medical record that the dosage that was given was appropriate, you didn't even take into account that in Ryan Hayes' system, when the fentanyl is being ordered, Narcan is still active in the system.
It is, but the reason that there's no indication for the high dose has nothing to do with Narcan. It has to do with his clinical circumstances. He's not exhibiting signs of suffering that would necessitate those drugs.
Hold on, stop. Next question.
I want to make sure to show you so there's no misunderstanding.
Okay.
Just generally, and again, you reviewed Ryan Hayes' entire medical file, correct?
Correct.
Included in his medical file was page 12. Just want to make sure, because I certainly want to make sure that I'm reading it correctly, that at the bottom of page 12, it indicates, does it not, a central line and an A line were placed in the emergency department. 10 milligrams of Narcan were given. Correct?
Right.
And that's through an IV.
Right.
And the time of that was on 4/2,
Correct.
and we know that his discharge date was 4/4, correct?
Correct.
So within 72 hours, he died.
Right.
For the record, Sam, what I
There will be
just,
no active ongoing Narcan.
Hold on, stop.
Okay.
for the record, Sam, what I've just shown the witness, I'll mark that as joint exhibit 2, page 12. Thank you. I'll put Ryan Hayes back up there. Also just want to indicate that in your report, you say that the tox screen was negative. Do you not?
Yes.
Okay. And that's actually not accurate. The urine screen was negative, but the tox screen was positive, correct?
You have to tell me. If I made a mistake, please correct me.
Okay. And that would be important
Yeah.
to know?
Well, I think we're going to treat him as a narcotic overdose, whether it's positive or negative, because fentanyl oftentimes doesn't show up on the report. But yeah, go ahead. Please correct me if I was wrong.
Well, and you say that you would treat him as an overdose anyway, because you know that he came in as an overdose.
That was the working diagnosis by the medical team.
And you know from his records, which any doctor prescribing would have access to, that he had a history of polysubstance abuse.
Right.
And that he had been it's even in the medical records, was it not, that he had been in jail for using drugs.
Right.
It brings me to this point. On direct, you were talking about how many people in today's culture are overdosing from fentanyl. I want to be clear. There's a difference between fentanyl on the streets, right, that is killing people, and the fentanyl that is medically being prescribed within hospitals.
Well, correct that the synthetics could have variations.
That's right. They're not the same drug, correct?
They're kissing cousins.
Okay. Kissing cousins are still different cousins, though, right? And what's carfentanil?
A metabolic byproduct?
Different from fentanyl.
Yes.
And carfentanil is something that might show up in a toxicology report.
Yes.
And what's ethanol?
Alcohol.
And ethanol is something that might show up in a toxicology report, correct?
Right.
And morphine would be the same, would show up in a tox report?
Yes.
And I know you talked about with respect to Ryan Hayes, Rick, quote, quite possibly had received an anoxic brain injury.
Right.
Because he was found unresponsive, right?
Correct.
And it was unknown by the person that found him, as indicated by the medical records, as to how long he had been out.
Right.
And what do we know about unconsciousness and how it affects the brain after 10 minutes?
That doesn't make sense as a question. Can you rephrase that?
Sure. How does, if I'm unresponsive and unconscious, and I've been that way, I've used fentanyl, I've been down for 10 minutes, what if any impact would that have on my brain?
It doesn't matter the unconsciousness. It matters the degree of time that you didn't get oxygen. But I think that's what you're getting at.
10 minutes without oxygen.
10 minutes without oxygen, big time acute ischemic injury. And that's what was presumed to be going on with him probably.
And 15 minutes?
But we don't know how long he had low oxygen levels, so I don't know the
The
answer.
question is, in 15 minutes.
Yeah, 50 minutes, even more likelihood of permanent damage.
In 20 and 25?
If the oxygen levels are low.
Okay.
I don't know what his oxygen levels were.
Everybody stop. Let's get Sam happy first. Okay? Madam Corey Porter, are you happy yet?
I'd be happy if everyone would speak one at a time.
Okay, well, let's see if they'll do that.
Okay, we'll try to.
Okay? Ms. Menashe,
Yes, thank you.
you can either re-ask the question or new question.
Does that want to keep Sam happy? Paragraph 6.
Not in paragraph 6, I note,
is the fact that not one, but two doctors other than Dr. Husel described Mr. Hayes as quote unquote terminal in the medical records. You didn't note that in paragraph 6 or anywhere in your report. Is that correct?
Correct.
And just for sake of accuracy and completeness, is it relevant to you that doctors other than Dr. Husel would have made a determination as to a patient that they were terminal before the decision was made by the family to withdraw support?
Yes, it is, because if multiple doctors agree that his prognosis is bad, it makes me even more certain of how vulnerable he was to receive high doses of drugs that he didn't have indicated.
Circling back to that question I asked you about carfentanil. You've talked about the equivalent of morphine and fentanyl. What's the equivalent, if you know, of carfentanil and fentanyl?
I do not know that.
You don't know how much stronger or weaker carfentanil is?
I do not.
The Mars report on Ryan Davis. The Mars report on Ryan. During your testimony about Brian Hayes, you talked about the dose amounts, and those are included in your report, are they not?
Yes, they are.
And I noticed that you included the times that he received the fentanyl that was ordered by Dr. Husel. Is that correct?
Yes.
Based on your review of the record, you would agree with me that the fentanyl was, how much was administered on the first time?
1,000 micrograms.
A moment. You want me to take a break?
I said it's 45, but we can take a break now. Would you like a break? You guys want a break? They want a break. Okay, we're gonna take 15 minutes. Okay? Remember the admonition, David, call them up.
All rise.
Have a wonderful break, guys.
All right, to get something out of this.
Same instructions as before.
Okay, thank you, Judge.
Okay?
Big Judge,
Yes?
on the break, he indicated to the bailiff that he wanted to get something out of his briefcase. I didn't make any further inquiries. He said he was going to wait until the break. I didn't know if you wanted to inquire with the witness.
We want to see if something out of Yeah, you can do that. That's fine. That's remedial. I can live with that.
Thank you.
good. You know, it's really arduous, but.
Okay, I want it, this is Joanne Belisari. I need to get it off my desk when I do it. It's for, to admit into evidence.
Okay.
Sorry.
No, that's okay.
Yeah, I have a bottle of water.
There's a lot of procedures. She does codes. I need stickers with codes, all that regularly. This is it. Tweaking your.
I don't know. I think so. I think he went back there to go back.
Ask him real quick.
I told him he was looking at 245. What is your preference? I'm guessing, well, a lot of times I walk in with it.
He's available right now if you want to take a couple minutes.
Okay, because we walk in together usually about 7.
Channel 10, are your mics live still? I see the camera up in the air.
Yeah, it's plugged in behind you.
Is it still live or are they able to hear what we say on the stream?
Yeah, it's still on.
Okay.
Audio, or I can't. Audio is?
So they're getting a picture of the ceiling,
I know there is. Yeah. There's a cord.
but they still don't hear what's said.
It's still on, so you try to turn it off. It's whatever comes with your ear. There's some stuff that's the cords camera.
That one's where the courts meet.
Yeah.
you're still under chair, let's go and take another chair out of here. Thank you. Mr. Nash.
Thank you, Judge. I left off with Ryan Hayes, and again, I have the portion of your report up there. But I wrote down, you indicate in your report, do you not, quote, there is no pain to treat. Did you see where you wrote that?
Yeah, and I based that on number 3 above.
Okay, so just showing you what's been marked.
The patient was not moving, et cetera.
But again, you reviewed the medical records in this case, correct?
Yes.
I want to go over what's been marked as Joint Exhibit 2, pages 403 to 402 to 403. Fair to say that this is a medical administration record for Ryan Hayes.
Right.
Okay. And as part of your review in this case, you looked through Ryan Hayes' file and you saw this document, did you not, from 4/3/2017?
Yes.
So I want to go through it with you on the heels of your statement that there was no pain to treat. It looks as if, does it not, that the fentanyl is given, and at the time the fentanyl is administered, the nurse has indicated a pain score of 10, correct?
Yes.
And I understand your testimony regarding a 10. I just am questioning what the record says. And the time at which the fentanyl is administered is what?
The 2257.
Would you agree with me that there is a assessment done approximately 15 minutes later as to whether the fentanyl has relieved the pain with medication? Do you see that?
Yes.
And what is written there?
No.
So that's approximately 15 minutes after the 1,000 micrograms of fentanyl is administered to Ryan Hayes. Nurse Tyler Springer indicates that pain is not relieved. Correct?
Correct, but the other records indicate something different.
Okay, hold on.
Okay. Let's take it into your work in the ICU. When you walk up to a patient, do you want to know 20% about that patient, or 60%? Or if possible, would you like to know 100%?
All of it.
Okay, so that's why I'm asking you about the MARS. That was in the records you reviewed, correct?
Right, but they don't make sense in accordance with the rest of the documentation. That's why I want to know the 100%. I got to have the whole picture.
You don't,
And again, maybe I should ask this for every patient. You weren't there on 4/3/2017, correct?
No, I have to go by what the nurses tell me.
And so I want to talk about what the nurses are saying and telling you through the medical information they entered into the MARS.
Right.
Let's go back to it.
Okay.
Because wouldn't you agree that when a nurse enters in information, that nurse is speaking through that medical entry?
Yes.
So what Tyler Springer is telling you as to 4/3/2007 is that the 1,000 micrograms of fentanyl did not relieve the medication. That's what Tyler Springer is saying, correct?
That's what's documented there, but the rest of the records don't support that.
And then, next page. Tyler Springer has also indicated, has he not, there's another assessment for the Dilaudid, separate assessment. Would you agree with me on that?
Right.
And as to whether the Dilaudid has relieved
the pain, it is indicated in the medical record the answer of no.
Unfortunately.
Is it unfortunate because it contradicts your testimony on direct?
No, I think it contradicts their own documentation in the other areas of the record.
In the ICU where you work, when a nurse, independent of you, goes to a machine, a monitor, and puts information to an EMR, right, electronic medical record, do you come from a place of distrust with your nurses, or do you come from a place of trust?
A place of seeking the truth.
And that's seeking the truth.
Yes.
So let's go here. You would agree that it indicates that it says a no as to whether the pain was relieved, correct?
That's what the paper says.
Okay. And it was after those notations made by nurses, a nurse, that the additional 1,000 micrograms was ordered. Is that correct?
Correct.
And noted there, when the second 1,000 is ordered, is that the pain score is a 10. Would you agree with me on that?
Yes.
And again, the 10 is reiterated, correct?
Yes.
You know, I left this out, but I want to make note of it. Those entries that I just asked you about were from Nurse Springer. Correct?
Correct.
You would agree, though, that the initial pain scores noted up here are by Nurse Redmond.
Yes.
And this is Ryan Hayes,
Yes.
the medical administration record.
Yes.
You realize, because you've reviewed all of these patient files, that at the end of every patient file is a discharge summary, correct?
Yes.
And the discharge summary is done by the attending physician for every one of these 14 patients.
Yes.
And fair to say that Dr. Husel was not the attending physician for any one of these patients.
That's right.
And in your practice and experience, fair to say that the attending physician in its discharge summary reviews and summarizes what has happened to the patient before the expiration of their life.
That's the ideal. That's what you're hoping happens.
And then they sign off on the discharge summary.
Yes.
Showing you what's been marked as Joint Exhibit 2. Page 9. Does this appear to be a discharge summary for patient Ryan Hayes?
Yes.
And it appears, does it not, that the document is electronically signed by the attending physician?
Yes.
Correct?
Correct.
And discharge information is included right here, and it lists the number of physicians that had interactions with the patient.
Correct.
And if we could, the final diagnosis is listed, and then a brief summary. Would you agree with me on that?
Yes.
And the time of when the person expired is included at the very end.
Right.
I know I asked you about whether you had an opportunity to review the autopsy report as to Ryan Hayes. I forgot to mention, an autopsy report is done by a forensic pathologist.
Yes.
And based on your experience and training, part of a forensic pathologist's job, is it not, is to perform an autopsy and, if possible, determine the cause of death.
Correct. But
Okay, you answered the question.
And just so I'm clear, you were never provided the autopsy report with respect to Ryan Hayes in this case from the forensic pathologist.
That's right.
Different question, were you provided the death certificate with respect to Ryan Hayes as of the cause of death?
I believe I was, and I realized that it wouldn't say fentanyl overdose.
Okay, let me show you the death certificate. Showing the witness was marked as defendant's exhibit RH2. Does this look familiar?
Yes.
And this at the top, fair to say certificate of death?
Yes.
And I just want to make sure that now that you indicated you've seen this, you must remember then that the cause of death is listed as acute mixed drug carfentanil, fentanyl, morphine, and ethanol toxicity, correct?
Yes.
And again, you're not sure what carfentanil is.
Well, I know I said earlier that it's a kissing cousin of fentanyl as well, and it's very appropriate for the medical examiner to list all those medications because they were all exposures in this patient's clinical course. We want to be very comprehensive in filling out death certificates, and I fill these death certificates out all the time, and we're taught to be as broad as you can to encapsulate as much of the likely path towards death as possible. It does not indicate a single cause, such as the drug that precipitated the actual death. That would never appear on a death certificate.
But my question was, had you seen it? And you had, correct?
Yes.
And you didn't indicate in your report that the death certificate says that actually the individual consumed all of those drugs. And it does use the word consumed, does it not?
Right, and because my report was focusing on what was the proximate cause of his death.
Right, but we want the truth.
That is the truth.
Okay.
That's what I was seeking.
Let's talk about the next patient. Beverly Schertzringer. This was the patient, again, your report's on this screen, but she had a blood clot. Then she had a CT scan, did she not, which was revealed this mass on her lung.
Right.
And it turned out that the lung cancer was later assessed to be stage 4. Correct?
Yep.
And then she had this biopsy within Mount Carmel West. And as a result of that operation or that procedure, she had massive internal bleeding.
Correct.
And that's how we find her to get to the ICU.
Yes.
Okay. And she's actually intubated before she even gets to the ICU, right?
Right.
And you would agree that in your report, you don't really talk about the massive internal bleeding. If you go to paragraph 1, you just indicate until undergoing a biopsy and ultimate transfer to the ICU.
I think it's a very accurate representation of what happened. Developed internal bleeding that led to an ICU stay. That's got to be massive.
I want to talk about, do you include in your report all of the other critical illnesses that she had other than just the stage 4 lung cancer? Do you include her atrial fibrillation, the fact that she had aortic valve stenosis? Do you indicate in your report that she'd been a chronic smoker since she was 15?
No, those are not indicated there. That's a good point.
But based on your review of the record, you would have to agree with me that those issues included, and also kidney failure, that she doesn't come to Mount Carmel West in 17 as a healthy individual.
I think you're making a great point. Yes, she's even more vulnerable than the report indicates.
In paragraph 2, you indicate the patient initially received fluids but no other curative treatments were performed or initiated. Do you see that?
Yes.
Okay. And in your report with respect to Ms. Belisari, you used the term aggressive support measures. Here you're using curative treatments. What's the difference?
Aggressive support just means that I'm willing to take on things like a ventilator or vasopressors, antibiotics, that sort of thing. A curative procedure would be something, as in the case of a cancer, where we actually either get surgery to remove the cancer or some form of chemotherapy, et cetera. Of course, she couldn't have had any of that. It's not negligent that she didn't get it. I was just including it in the report. And the main reason I included it was because that was still on the horizon for her.
You would agree with me that after getting vasopressors 3 times, her blood pressure was 38/21, correct?
Correct.
Tell me, well, tell the jurors, when my blood pressure is at 38/21, what's my state?
She is in shock, and in addition to that, it indicates she was in no distress at this time.
That's not my question.
I didn't know my finger would do that, sorry. No distress, heart rate, respiratory vitals, not an issue. So she actually was having vital sign issues with the low blood pressure, and I was trying to calculate whether or not she clinically would require those high doses of fentanyl.
Okay.
Because she was a vulnerable patient. I don't know if you can remove those blue dots, but sorry.
I'm going to take ownership of this again. I'm just ask you more succinct questions, because my questions are different from those that were asked if you want to go back.
Okay.
Because I'm asking you, my blood pressure, Diane Menashe, is 38/21. What's my state?
You're in shock.
Tell me where, and near death.
Anybody in shock is at risk for death.
Tell me where in this report do you include 38/21?
It's not included.
But yet you say she hasn't received chemo as a curative measure or had surgery on the tumor.
Right.
38/21, I'm not surviving.
Oh, no, people, no, you're not going to do the surgery then. The idea is, could she, if we get her out of the shock, undergo subsequent therapy to give her months to live with her family?
And then you testified, and I noted it down, wrote it down, that she was opioid naive, and it's indicated in your report as opiate, but I'm just going to go to opioid. Tramadol is an opioid, right?
Non-opioid.
It's a non-opioid.
Tramadol is, well, why do you ask?
Well, no, you don't get that.
Okay.
You want to catch your flight?
Yeah, good point.
Let's answer her question.
Because she took, here's my question, and not an answer. You reviewed the records, and so you know that she was regularly taking Tramadol.
Yes.
Right?
Yes.
But you testified to this jury that she's opiate naive.
So corrected, thank you.
Showing you what's been marked as Defendant's Exhibit Eli 14. Does this look familiar? Let me try and clear that.
Touch the bottom left-hand corner, that'll get rid of those, of the screen above you.
No.
No,
I got it.
screen.
Okay, got it. Yep, as we learned. Okay, thank you. Showing you what's been marked as Defendant's Exhibit Eli 14. Tell the jury what patient this code sheet appears to belong to.
This is Beverly Schertzinger.
And again, this is a code sheet, is it not?
Yes, documenting that she's in DEA.
Code sheet, cardiac arrest, actively died, correct?
Yes.
And it indicates up here that she survived this incident when she coded. Is that right?
Right, you can see ROSC below PEA.
And I just want to draw your attention, does it appear that this column is the time of the arrest?
Yes,
Okay. And the physician's signature, does it not indicate William Husel?
yes, it does.
So William Husel is in the room when this patient is coding, saving her life.
Yes.
With respect to Beverly Shirt's thing. 3 questions. First question. Fair to say that you are unable, as you sit here today, to a reasonable degree of medical certainty, to say, but for the dose of fentanyl, when she would have died.
I cannot say when she would have died, but for the dose of fentanyl.
And based on your review of her medical records, you cannot say the exact moment in time when her heart stopped beating.
I do not, well, based on her time of death, is what I would say.
When her heart stopped beating. You don't know that exact time, correct?
I think it's the same time as her time of death. That's how we pronounce death, is by no heartbeat.
And so then the time of when her breathing stopped, you can't say that with certainty either, can you?
I can't recall if there's a documentation of no respirations after she got the medication. I'd have to review the medical records to see that, but I'm assuming that both of those things stopped around the same time.
And that's your testimony today, that you would
As far as I know right now, but I'm happy to, if you show me something that counters that, that's fine.
Okay, well, let me ask you this, because I know we talked about accuracy and completion, being complete. In any of your patient summaries, do you include the time when the patient's heart stopped beating?
When a doctor...
Yes or no?
The time of death is the time that we feel no pulse, and therefore the heart is stopped.
In your report, do you include the exact time of the breathing stopped?
They're both considered the same time, so no. The time of death is my assumption of breathing and heart stop. That's as close as I can get it to accurate.
So the only time you include is the time that's entered into the computer.
Right. I wasn't there, so I have no availability at any other time.
I'm going to go to the next page. Danny Millett. Oops, sorry, members of the jury. Mr. Millett comes into Mount Carmel West already intubated.
Okay.
Is that correct?
Yes.
Okay. He has the situation at the rehab facility. He's intubated before he even gets to Mount Carmel. Is that correct?
Yes.
And he's on high doses of vasopressors. And even before getting to the ICU, would you agree that he codes multiple times?
Yes.
Codes, cardiac arrest, actively dying. Correct?
You keep making those things in the same sentence, but it's not necessarily, that's why we code somebody, is to prevent them from dying. But
Right. And a code is cardiac arrest,
yes,
which means I'm in the process, right?
of dying, we want to intervene and stop.
And you want to save me.
Yes.
Okay, so if I'm in cardiac arrest and I live, I've been saved, right?
Correct.
And you indicated on your direct that this was a quote-unquote sick man,
Oh, yes.
very sick,
Very.
and had just prior to this hospitalization, had 2 other surgeries within just the last couple of months, one of which was an amputation of a toe, correct?
Yes.
And when we talk about how sick he was, he had had prior bypass surgery, he'd had a stroke. right? He had aortic valve disease. Would you agree with me that he had a number of ailments?
Yes,
He was also in the records noted to be obese.
yes,
And I only mention that for tolerance issues, not for any judgment purposes. That makes sense, right?
yes.
His GCS score was noted as a 3.
Correct. And that's why I pointed out above it, it says stuporous in 3.
You mentioned in your report and on direct that he was opioid negative. Do you remember that?
I can't remember each person I said that in, but if at the time I said that, it's based on my assumption, yes.
And I agree that you've only reviewed the patient file with respect to their last hospitalization, correct?
Yes,
But you certainly knew from his records that he had recently had an amputation.
oh, sure.
And we can presume, based on your training and experience, that when someone has an amputation, they're likely to receive pain medication. Do you agree with me?
Yes,
And we know that he'd also had another recent surgery, correct? That was in his medical records, right?
right.
And that he was at a rehab facility when he went into a RASS and had to be intubated.
Right. I just didn't have any documentation of what he had been receiving, so I had no awareness that he was receiving high doses of narcotics prior to this.
Okay, but did you even include anywhere in your report that he had the prior surgeries and information wasn't available, but could impact your final opinion in this case?
Well, his right great toe amputation I do mention, and the report summarizes his current stay. So that's what I limited it to in terms of this summary.
And I want to go here, going back to the GCS, it's documented as a 3. He's at a 3, is he not, for 7 hours?
Right.
13:45, he's a 3. 16:27, he's a 3. 20:45, he's still a 3, right?
It's a great point. That's exactly what makes number 6 so relevant, that he wasn't justified to give him any more medications if he's already in a sustained coma. You're
So
making my point.
I want to go to Danny Millett's code sheets. Sticker, please. Sticker when you get a chance. As I've done with every patient. Showing the witness what's previously been marked as defendant's Eli 15. Patient name on these code sheets.
Danny Millett.
And I want to just flip through them. Just generally, code sheet,
Yes.
heart rate sheet. Do you agree with me on that?
Correct. Yes.
Okay. Code sheet,
Yes.
heart rate sheet,
Yes.
code sheet,
Yes.
code sheet,
Yes.
heart rate 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 sheet,
No.
oops, code sheet,
Yes.
heart rate sheet,
Yes.
code sheet,
Yes.
code sheet,
Yes.
code sheet,
Yes. These are done at 2-minute intervals, so we often have much paperwork.
code sheet. 2-minute intervals, every code, a new code, right? Correct? Is that a yes for the court reporter?
If you put it back up, I can tell. Are those all individual codes, or was it consistency? Was it code sheets of one
Sure.
code?
Let's go through it. Date, 12/5/15, right?
Yep.
Okay. Survived, transferred. So, did you see that?
Yes.
12/15/17, 11/48. Do you see that?
Yes.
Okay. That one's not marked, right?
Right.
It's to the survival.
So it goes
So
to-
this one. This is 11/48, so that is a duplicate. Oh, I'm sorry, but when I say duplicate, times are different, right? He's coding, and the times are changing. Do you see that, doctor?
It was the same code, isn't it?
The same code. 1151 going on.
I interpreted this to be all the same code, just continuation of sheets, because you're,
Stop.
1 second. Oh. Okay, so going here.
New
well,
code.
That was new code. That was one code that lasted the span of several hours. 2 hours at least. Here, let's go through it. 1151, does that appear?
yes,
Okay. And I'll just show this for a point of reference. We're going 1210.
okay,
Same date, same time. 12:30, I'm just using this to show a period of time.
okay, yes,
Okay? Then, give me 1 second. Okay. 12:30, same code. All right, and then now we have at 12:49, right? So that was
Right.
12:30, now we have 12:49,
right,
right? Different code.
right,
Different heart rate sheets, correct?
okay, yes,
Okay, and the time listed here goes to 12:56.
Sure.
Does that seem correct?
yes,
Okay, and then it goes on to 1321,
right,
1329,
right,
okay. And this is the same, he's coding this whole time,
right,
and 1332.
right,
And then it notes resuscitation ended 1333, correct?
right.
So, with respect to same thing, same issues that you noted with Danny Millette on the pain score. But you would agree with me that the medical records speak for themselves, right? You have no evidence that anyone's manipulated or changed any of these medical.
I do not know that, yes,
So with respect to Danny Millette, not included in your report, nor can you say to a medical degree of scientific certainty the exact time by which Danny Millette would have survived but for the vet.
yes, I could never know that about anybody, about any human being.
I want to follow up. Did you ever see the death certificate for Danny Millette?
I don't recall seeing that death certificate.
I ask you this because I think on, with respect to the last patient, you mentioned that death certificates are oftentimes over-inclusive.
I didn't say over-inclusive. I said as inclusive as we can be.
Okay. I'm showing you what's been marked as Defendant's Exhibit DM2.
Yes?
What appears to be this individual's name?
Danny Millette.
Okay, and does this appear to be a death certificate?
Yes,
And if you see on the Defendant's Exhibit DM2, cause of death is indicated as what?
sepsis and bacteremia.
And death certificates. Those are signed by the attending physician.
Yes,
The attending physician who has the benefit of reviewing the entire record
right,
and signing off on the discharge summary.
right.
I'm going to go to Brandy McDonald here. One moment. Brandy McDonald is the patient trying to, who had ovarian cancer, correct?
Yes,
And the cancer had spread, had it not?
yes,
In your report, I know that you had mentioned that she had deteriorated overnight and was intubated in the ISU, or in the ICU, correct? Okay.
yes.
Did you note in your report that in fact it was Dr. Husel that intubated her?
No,
And intubation would be considered by you as an aggressive support measure?
yes,
In your report, you indicate that there were additional curative measures which had not been exhausted prior to her extubation, and then you testified to that. Do you remember that?
yes,
You're aware, are you not, when you reviewed the record, that Ms. McDonald had an attending physician at Mount Carmel West?
yes.
And that's Dr. Chan. Do you remember that?
Mhm.
And in the medical records, was there not a significant amount of record keeping as to the discussions that her attending physician also had with her GI doctor and her nephrologist, correct?
Yes,
And also discussions that her attending physician had with the ICU team.
yes,
The word team was used,
absolutely.
correct? So discussions with the GI, the nephrologist, and the ICU team. And didn't her attending physician then note after all of those discussions that the patient's condition was, quote, critically ill and poor prognosis?
Yes, absolutely.
Nowhere in the attending physician's note does it say that additional curative measures should be pursued, correct?
I did not see that stated.
And you haven't spoken with the attending physician?
I have not spoken with that attending physician.
If you can please let her finish the question.
Okay.
You indicated that a palliative extubation is never an emergency. If you were the patient and I am, and you're on death support, and I am your designated power of attorney, it is true that I speak for you when you cannot speak for yourself, correct?
Yes,
And if I know as your power of attorney, as your sister, as your wife, whatever I am to you, that you do not want ever to be on a bed, and I make the decision for you to withdraw all life support saving measures, that might seem like an emergency to me, right?
the word emergency, I'm thinking about a code, like people running down the hall.
Because there is something, is there not, as someone that is working in palliative care, where I, as your power of attorney, might, in your best interest, want you to die without all the tubes in you.
Oh, yes, absolutely. I think the distinction here is urgent versus
Okay, well,
emergent.
Stop. Next question.
And I asked you that specifically with respect to Ms. McDonald, because her family, and I know you reviewed the medical records, was very clear that she would never want to be on that.
Right.
Never.
She should be taken off the ventilator.
With respect to Ms. McDonald, I know in your report, fair to say that you do not include, nor can you have an opinion with a reasonable degree of medical certainty as to the time that she would have died but for the fentanyl.
Right, I would never be able to tell that.
Where's that? Were you ever shown Miss McDonald's death certificate or provided that information in the file?
Can I go back and add an answer to your last question?
No, you're kind of stuck here.
Okay.
With respect to her death certificate, her being Miss Brandy McDonald, did you ever receive her death certificate to your recollection?
Not that I know of.
Okay. Showing you what's been marked as Defendant's Exhibit BM2. Does this appear to be Brandy McDonald's death certificate?
Yes.
And if you could see at the bottom, what does it appear to be noted as the cause of death for Miss Brandy McDonald?
Hepatic failure, metastatic ovarian cancer.
And hepatic failure is noted as days, is that correct?
Right.
And again, with respect to Brandy McDonald, death certificates are filled out by the attending physician.
Yes.
And after they have the opportunity to review the patient file and do the discharge stage.
Right.
Turning to James Allen, if we can. I have the portion of your report up there for you to refer to if you need to. Just want to talk about Mr. Allen a little bit. He was an 80-year-old, correct, smoker with dementia, is that right?
Right.
And I want to talk about the conditions that he had prior to what you describe in paragraph 8 of your report. So he had COPD, correct?
Yes.
He had cardiopulmonary arrest,
Yes.
acute hypoxic, respiratory failure, suspected due to be a GI bleed, right?
Yes.
He had atrial fibrillation,
Right.
acute kidney injury,
Yes.
kidney failure, right? Septic shock,
Yes.
and then chronic systolic heart failure with EF 10 to 20%. Do you remember that note in the file?
Yes.
And the normal EF, is it not, is between 50 to 70%.
Right.
So, and he had 10 to 20%, normal is 50 to 70%, right?
Right.
And that, doesn't that mean that the blood isn't effectively moving throughout the body?
It means that he has heart failure, yes.
Blood goes more slowly than it might if he didn't have heart failure.
Right.
And then he had this aspiration pneumonia due to the vomiting, right?
Right.
And his vital signs were noted as not stable.
Right.
And then when he's intubated, he's noted to be very critical. Correct?
Yes.
And the code blue is called and he goes to code. Would you agree with me on that?
Yes.
It's noted in his file, oh, and I'm sorry, but he also gets CPR, right?
Yes.
CPR, you mentioned something that I want to circle back to on your direct. CPR can break someone's rib.
Yes.
Not,
Yes.
potentially more than one rib could be broken.
Could be.
And that's just as a side effect, if you will, of doing those chest compressions.
Yes.
And potentially, having a broken rib could be painful.
Although they documented a pain score of 0.
That's not my question. My question is potentially.
Potentially.
You give me CPR. I'm done. You bring me back. And I have one broken rib. That could potentially cause me pain, right?
Yes, it could.
But your intention, double back, is to save me,
right?
Right. That's ridiculous.
You mentioned, I need this stick. You mentioned the absence on other cases of notations about the pain visual cues that were being received. In this patient's chart, it actually indicates that he's grimacing, right? That he's experiencing pain.
He did have some of that, yes.
And then it notes in multiple occasions that the grimacing then he's grimacing and he's having withdrawals. Do you remember that at 2050?
He's not having withdrawals. It says he withdraws. It means he withdraws to pain. You're confusing the circumstance. They're trying to cause pain. So he withdraws and grimaces to pain when they stimulate him.
Okay, so somebody grabs his arm and he withdraws.
If I squeeze his nail bed or something like that, he'll manifest a sign of pain, but their actual pain scale did not indicate in the absence of doing that he was in pain.
Not my question. The documents indicate that he's grimacing and that when he's touched in some way, he withdraws, right?
Not that he's grimacing. I'm sorry for the subtle difference, but that he grimaces if I cause him pain.
I understand because he feels.
Yes.
He feels,
Yes.
right? With respect to, the speaker. Before the fentanyl is ordered in this case, just as I've done with the other patients, and this time, James Allen, showing the witness what's been marked as defendant's exhibit Eli 16. On 5/28, it appears at 9/10, he coded, is that correct?
Yes.
Correct. And this is, the code goes on, same date?
Okay.
And there's no, it appears, heart rate sheets to this. Does that sound accurate?
Yes.
Okay. And here it notes that he survived.
Right.
And that's in the ICU.
Right.
In Mr. Allen's medical records, I trust that you reviewed the notes that Dr. Ralston made.
Yes.
I'm sorry?
Yes.
And Dr. Ralston, not Dr. Husel, right? Dr. Ralston had extensive conversations with Mr. Allen's son. Do you remember that?
Yes.
And discussions about end of life and the records indicate, do they not, that the son was quote unquote realistic about his father's limited reserve and end of life issues.
Right.
And that's not a Dr. Husel note, that's a Dr. Ralston.
That's right.
He's having a conversation with the family
Yes.
about palliative extubation and a likelihood that Mr. Allen might or might not survive, right?
Right.
And it's then that the medical records indicate, do not, that the patient's family goes to the nurse and says, we want to withdraw all life support saving measures. The nurse then goes to Dr. Husel,
Right.
right?
Yes.
So the family initiates that procedure with respect to Mr. Allen.
Yes.
Were you shown the death certificate with respect to Mr. Allen?
No.
Showing you what's previously been marked as defendant's exhibit JA2. Does that appear to be the death certificate from Mr. James G. Allen?
Yes, it does.
And just to orient, because I know it's a common name, age appears to be 80.
Yes.
And the causes of death that are noted by the attending physician in the death certificate, if you could read those to the jury.
Septic shock, Pseudomonas septicemia, and cholangitis. Days.
And obviously, not one of those causes is the fentanyl.
And you would never see fentanyl listed there.
But the attending physician didn't list it.
And they would never do that.
Can you show me that? Thank you. Because it reminds me of Defendant's Exhibit RH2, where fentanyl is actually listed.
Because the patient came in with a known overdose of fentanyl prior to coming to the hospital, so they were listed.
Doctor, it can't be your testimony now that the overdose was caused by a known drug when he came in.
The difference between that particular death certificate and all of the subsequent death certificates is that this death certificate is including medications because the patient is an addict. So the person who filled out the death certificate knew they were an addict and included medications as part of the process of their dying. None of the other death certificates, and she'll go through all of them, I'm sure, to do the same thing, will ever show fentanyl because it was something administered at the time of death, and none of us would ever include that on the death certificate. So that'll be a recurrent theme, that this one showed the drugs because it was part of their history of being an addict, whereas the other ones will not include a medication given to provided at the end of life. No physician would ever put that on the death certificate.
I'm going to pull another one while we are.
Well, I'm using never to admit to, I should take the word never out and say it would be highly unusual.
Okay, it would be unusual.
Yes. I should not use the word never.
Okay, I want to just go back to James Allen because I remember your testimony about likelihood of survival, and I want to make sure that we have the notes from Dr. Ralston. We have the family initiating the conversation. And then isn't there also in the medical records the note from Dr. Mahoney that reads, I quote, "Unfortunately, I'm afraid you will not survive this episode." Correct?
This hospitalization, yeah.
Yes. And Dr. Mahoney is separate and apart from Dr. Husel.
That's right.
Same thing as to James Allen. Thank you. There is no time of death in your report, nor can you say with any reasonable degree of medical certainty as to when Mr. Allen would have expired but for the fentanyl, correct?
Okay, I'm glad you, no, I didn't say correct.
Oh, yeah, okay, great.
Yeah.
Is that in your report?
Yes, the time here, 20 minutes, sorry, I did it again. The time here, 23:20 to 23:40. And I want to answer this more accurately, that there was no indication that this person would die that rapidly on removal of the life support, but for the fentanyl.
Okay, and that's not my question. I appreciate that was your testimony on direct. My question is distinctly different. My question is, here today in this court, based on having reviewed these medical records, you cannot say to a reasonable degree of medical certainty as to what time he would have died but for the fentanyl, correct?
I'm trying to process the question. Bear with me here. I think that he would not have died but for the fentanyl in this short of time frame.
Okay.
It's the big screen that you gotta use clear. Is that what you're trying to do?
Okay, yep.
Up there.
Yes, please, sorry.
I think you just do this.
I want to just go back.
Bottom line. This, right?
If we can, just to clarify something. I know now you said it's unusual, but we also know that James Timmons was a polysubstance abuse, had a polysubstance abuse history, correct?
Yes.
Okay, just want to, you would agree with me, yes or no, that the cause of death says recent cocaine and fentanyl use, correct?
And that's yes, and it's a super example of what I'm talking about.
Oh, and so Timmons and Hayes have fentanyl in them, correct? Just a yes or no, in their death certificates, it says fentanyl in the
Yes.
drug users, does it not?
Yes,
Okay.
because it was their history.
And in the others, the attending physician that reviewed the entire patient chart, including the orders of fentanyl that Dr. Husel gave to every one of those patients,
and that attending physician reviewed this file, went to write their discharge, filled out the death certificate, and found those causes of death.
Because those are the disease processes.
No.
Yes.
Troy Allison. I know it's a lot, but every patient deserves the same time and attention.
Absolutely.
So I want to be sure to do that. Troy Allison, 4 heart attacks and prolonged CPR. Would you agree with me?
Yes.
And cardiogenic shock, which required the vasopressors,
Yes.
and acute respiratory failure, which required the mechanical vent,
Yes.
correct? Kidney failure, liver failure, endocrine failure.
Right.
He had severe metabolic acidosis that was not compatible with life. His pH was a 6.53. Would you agree with me?
Yes.
He had cellulitis of the leg, suspected pulmonary hemorrhage, correct?
Yes.
And then he had a suspected GI bleed. It's Troy Allison.
Yes.
I want to talk about the notes in the file as to other doctors. Because any patient at Mount Carmel isn't in the ICU, isn't just seen by one doctor, correct?
Right.
Dr. Woodard, in the ER, physician note, did he not, wrote patient in severe critical condition.
Yes.
Quote, emergent life-threatening condition, end quote. Correct?
Correct.
Quote, incapacitating systemic disease, end quote.
Right.
That's in the ER. And then we had Dr. Patel, do you remember that he had notes in the file as well with respect to Mr. Allison?
Yes.
And he wrote, quote, poor prognosis, correct?
Yes.
There were, in Mr. Allison's file, also chaplain notes, were there not?
Yes.
And I should have asked you this about the other files, but there's chaplain notes in a number of
There are.
files, right?
Very encouraging, yes.
And the chaplain is able, it seems, from the medical records, to actually have discussions, spiritual care individuals have discussions with the family, and then they enter in summaries with their discussions.
Yes.
And those are in here.
They are.
And separate and apart from the doctors and nurses, it appears they're actually entering in their own notes.
Yes.
And with respect to the chaplain note associated with Troy Allison's family, did it not say, quote, the family opted to withdraw the ventilation support, knowing this patient did not wish to be on life support?
Yes. Yes.
And the chaplain in Cassandra Wilson was the chaplain specifically, spent 150 minutes of death support with Troy Allison's family.
Yes.
Like 150 minutes total, right?
Yeah.
So that's over 2 hours.
Right.
Really spending time with the family to make sure that they understood the decision they were making and what we have to make.
Right. That's beautiful care.
And yet on your direct exam, you testified, and I quote, let's keep him going. Remember saying that?
My point is to allow his natural dying process to occur. And I agree with the family's decision to support him and remove the life support. That's it. The decision to remove life support does not equate to determining death by giving drugs. There's a very important distinction there. So I support the family. I support the chaplain's note. And that family never asked for him to receive a lethal dose of medication.
Okay. My question to you was that on direct, you testified, I just wrote down the words and tell me if you say these words in conjunction with one another, let's keep him going.
Let's keep him going equal, allow him to die naturally. That's what I meant by that.
Okay, because certainly the family, over 2 hours with the chaplain, because that's not how Troy Allison wanted to live.
I do not think that the family has made it abundantly clear that Troy would want to have his life support removed. And that's critical. We have to do what the family wants. That's why we did a baptism in ICU, because somebody asked for it. But it doesn't mean kill them with a drug. There's a big, huge distinction.
How does how did the baptism come in with Troy Allison? He didn't ask to be baptized.
I'm showing how we will go to any extent to try and listen to someone's end-of-life wishes and provide them the end-of-life dignity that they ask for, which in this case did not include a lethal dose of a drug. Nobody asked for that.
And so I go back. If Troy Allison has the power of attorney, because he can't speak for himself, and I'm the power of attorney, I speak for Troy, right?
Right.
I decide, because Troy has told me I have that power and that privilege.
Right.
I speak for Troy.
Absolutely.
Did you review the death certificate in Troy Allison?
No.
Showing you what's been marked as Defendant's Exhibit TA2.
Cardiopulmonary arrest, acute upper gastrointestinal bleeding, acute respiratory failure, and seizures.
Gastrointestinal, we call that like the GI tract, is that right? James Timmons. James Timmons, I know we just briefly showed you his death certificate. I say this not out of disrespect, but just to be factually accurate. Like Mr. Hayes, he had a history of substance abuse. Is that correct?
Right.
And I just want to talk about, I noted during your direct examination that you indicated that you didn't know how long he had been down. But actually, doctor, isn't it true that in the patient medical records, it indicated that he was found, quote, down for likely 48 hours? Remember that?
Yeah, I was kind of focusing on the word likely. I mean, I don't know, but yeah, it's an extended period of time, they thought.
I mean, 2 days, and then the note goes on to say that he's in the basement for 2 days. That's a long time, is it not?
It is, which evolved as compartment syndrome.
Right, to be without a pulse. So I'm just curious, though, the 48 hours that he was down isn't included in your report, correct?
No.
And then he was placed on, and he was also found with a needle in his arm, right?
Right.
Okay. He was placed on immediate dialysis, was not, CPR was started, correct?
Yes.
Okay. And of course, you've noted his polysubstance abuse and cocaine abuse, which was noted in his patient file, right?
Right.
And he's given the maximum dose of vasopressors when he's in there.
Right.
Right, like trying to keep him alive.
Yes, absolutely.
And when he's even on 2 vasopressors, his blood pressure was a 78/46. Does that sound right?
Yes.
And I want to go back to that chaplain note again. Do you remember that the chaplain note in James Timmons' file, even that note indicated, quote, critical diagnosis?
Yes.
Have a second. And then Dr. Ralston, do you remember that name as another ICU physician? Different shift?
Yes.
But at Mount Carmel West.
Mm-hmm.
There's a Dr. Ralston ICU note with respect to James Timmons, is there not, 13 hours before he
he passed, he being Timmons, that said, quote, without the ventilator, vasopressors, and interventional critical care, the patient would die.
Right, correct.
And then Dr. Bastati, internal medicine note, 16 hours before Mr. Timmons passed, wrote, quote, high mortality risk. Does that sound right?
Yes.
I just want to show you what's been marked as defendant's exhibit. Eli 17, the code sheet on him, it appears 1022, 1848, resuscitation ended. Do you see that?
Yes.
And this sheet, 1022, resuscitation ended at 2:36 and recognized at 2:25. Oops, sorry.
Yes.
You see that? So these appear to be different code sheets. Is that fair to say?
Correct, yes.
And this one, this code sheet right here at 2025. Can you tell me which physician signature is on that code sheet?
William Husel.
So at 10/22/2025, William Husel is in the room in the ICU saving James Timmons' life.
Right.
And then tell me if you could, 10/22/2018, 2308. This seems like a third code sheet. Is that right?
Yes.
And again, so this is about a few hours later.
Right.
And again, tell me if you could, the physician signature here.
Dr. Husel.
So again, Dr. Husel, several hours later, is in the room in the ICU while Timmons is coding and he's saving his life.
He's running the code.
I asked you those questions about Dr. Ralston's note and Dr. Stissi's notes because I wrote during direct examination, you talked about maybe James Timmons could have walked out and had rehab and a life of recovery. Do you remember testifying about that?
Yes.
Want to talk to you about the note also that I think is not included in your report with respect to the patient's reaction to the fentanyl when it was administered. Do you remember in the medical records, the nurse Jake Deemer note as to how the patient responded to the 1,000?
No, I don't remember what she wrote.
It could have been a man too.
Okay, good
The
point.
nurse, she.
Either one,
right?
yeah.
Before I get to that though, I missed this with respect to Mr. Timmons' intolerance. We know that he has a polysubstance abuse issue, right?
Right.
And then he was intubated for 30 hours, and over that time, did he not, he got 6,200 micrograms of fentanyl. Do you remember that?
Yes.
Medical records?
Yes.
So 30 hours, 6,200 milligrams. And so I mentioned that to you in your discussion as to whether he was opioid naive or tolerant.
I think he would not have been opioid naive and tolerant.
Can I have that document? Getting a document to show you. Because I think in the medical file, you would have not only reviewed what happened to Mr. Timmons in the ICU, but also the drugs that he was administered in the ER before he got sent to the ICU, correct?
So my question was about the 6,200 micrograms of fentanyl that he was given before the decision was made to palliative extubate. I want to pull a sheet to also show you what he was given in the OR, sorry. Well, while we're looking for it, in evidence, we've introduced a document that says, with respect to Mr. Timmons, he was administered in the OR. So he was administered over 14,000 micrograms of fentanyl. If a patient order form indicated that, would you have any reason to disagree with that?
Well, the person's under general anesthesia in the OR on a ventilator, so they're going to give what they need to give, and they could receive that much on a ventilator. That's the key difference.
Oh, right. I was just adding them out
Yes.
to the opioid conversation.
Okay.
Okay. And
I don't remember that number, but if you say so, I take your word for it.
okay. And also, I want to just go back to the chaplain conversation with respect to Mr. Timmons. There is a note that the spiritual care team and/or chaplain spent 90 minutes of what they call death support with the family. Did they not?
Yes.
Showing you what's been marked as Joint Exhibit 11, page 279. I just wanted to close the loop.
Okay.
So, indicates patient, would you agree with me, is James Timmons?
Yes.
And the order details, would you disagree that it's over 14,000 micrograms of fentanyl?
That's what it says.
Okay. We'll go to Rebecca Walls.
Hold on, before you go any further, council approach. Go ahead and talk it up, guys. You gotta pull your part around here, come on. Okay. Ready?
Yep, thank you, George.
I was talking to Sam, but
All right, let's go to Rebecca Walls. It's late, so we'll mix up the order of things. Rebecca Walls, fair to say that you indicated time of death was 1:32?
Yes, 5 minutes after she got the fentanyl.
Just want to point out, showing you what's been marked as Defendant's Exhibit RW2. Were
Right.
you provided this death certificate?
Yeah, no, I didn't see it before.
Okay. I note this because you mentioned 1:32 is 5 minutes after. Again, so we're clear, the death certificate is filled out by the attending physician,
Right.
who has the opportunity to review the entire patient medical record.
The diseases that they have, yes.
Right, and then fills out the discharge summary and closes out the file, right?
Based on the diseases the person has.
The time of death is listed as 021 here, is it not?
Yes.
30 minutes after one.
I don't know which one's accurate.
In Walls, chaplain note, Rebecca Walls, the chaplain notes indicate that 180 minutes were spent with the family. Does that sound about right?
It's beautiful.
Sound about right?
Yes.
And you mentioned on your direct examination, the cover of darkness. Things were done under the cover of darkness. You remember that expression?
Yes.
There's nothing cover of darkness. Did you agree with me? In fact, you said it beautifully, that the spiritual care team is there with the family at night for 180 minutes.
That is true.
And you know, do you not, that in the ICU unit at Mount Carmel West, the lights are off. It is not dark there, right?
It depends. We turned the lights down quite a bit at night. I wasn't there to see the lights, but it was a figure of speech, not literal.
I'm sorry. One moment. I'm gonna let that. Okay. So 180 minutes with the family. And we know from the other patient files that the spiritual care team chaplains are there, right? So this isn't, you're familiar with the expression, like a lone wolf, right?
Yes.
But this is, we have nurses, we know from the patient files. We have nurses, right? We have charting nurses, right? We have chaplains, spiritual care people, all these people there in the ICU for any one of these 14 patients. Would you agree with me?
Yes, I agree with you.
And we're not sure about the dimmer switch, but we are sure that in the ICU, the lights are not off. Would you agree with me on that?
I have no idea. We turn the lights off all the time in the ICU at night.
Oh, okay.
It really is dark up there a lot of times.
So Rebecca Walls. Miss Walls was at Mount Carmel West for 6 days, correct?
Yes.
And she had cancer as well, did she not?
She did.
Okay. And I just want to kind of go through her multiple acute diagnoses included acute respiratory failure requiring the mechanical ventilation, correct?
Right.
She had the cardiogenic shock requiring 2 doses of 2 times she got vasopressors, correct?
Correct.
She had the kidney failure.
Yes.
The acute blood loss anemia, which required multiple blood transfusions, correct?
Yes.
She had congestive heart failure.
Yes.
Severe aortic valve stenosis, correct?
Yes.
She had had a stent replacement due to aortic issues previously, correct?
Yes.
She had edema.
Yes.
And she had metabolic acidosis.
Yes.
And I want to talk about what other doctors, not Dr. Husel, what other doctors wrote within Rebecca's patient file. Because I know down direct, you said there was no evidence she was dying. Do you remember that testimony?
Yes.
Okay, let's go to the note that Dr. Wadakati, and I might be saying that wrong, it's Woidtke. The internal medicine physician note, 17 hours before her death, said, and I quote, critically ill, prognosis guarded, she looks very ill. Do you remember that note from Dr.
Yes.
Wadakati?
Mm-hmm.
Then Dr. Closer, Closer, in the ICU day shift, wrote, did he not consult palliative care, poor diagnosis. I don't think she's going to survive. Remember that?
Yes.
And then there's also Dr. Riley's, the nephrologist physician note. Do you remember that?
Yes.
So we've got lots of doctors looking, eyes on Rebecca Walls.
And everybody is agreeing, yes.
Okay, everybody's agreeing that he writes, Dr. Riley, 13 hours before the decision to palliative, the extubator, she remains ventilator and vasopressor dependent, now with increasing lactate, an ominous sign, especially on dialysis. Do you remember that?
Right.
All notes separate and apart from any observation Dr. Husel makes.
Yes.
And this is another one of those cases, is it not, Rebecca Walls, where actually it's the family who goes to the nurse saying, our loved one, Rebecca, would never have wanted machines or to be resuscitated. Do you remember that?
Right.
And the chaplain wrote that note in the records, right?
Right.
And we can presume, just like any note taker, that when someone writes things into the electronic medical record, they do so, that's the record speaking for them, right?
Yes.
Okay. And then they notify Dr. Husel. And in that case as well, at night, 180 minutes of death support is, as we discussed, not with the family, right?
Yes.
And I'm just adding up the amounts of fentanyl that she received in her time at Mount Carmel. It looks like she was there for 4 days, and before she was palliatively extubated, she received 4,800 micrograms of fentanyl. Does that sound right to you?
Right. So that's a very low dose in comparison with what she got at the end of her life.
About 1,200 a day, if I do my math, on average.
Right. So very low in comparison to a dose, nowhere near a dose of 1,000 micrograms in one dose with midazolam and other drugs on top of that.
And Rebecca Walls was 75.
Yes.
James Timmons? We did. Paula, don't hurt me, but I don't, it's hard to keep track of the report. Let's talk about Bonnie Austin. Bonnie Austin was 65 years of age. Does that sound right?
Yes.
And this is the, Bonnie Austin was the 600, just so we can orient ourselves, right?
Okay.
Okay. We haven't talked about patient specific, but and what that means, but you would agree with me that patient specific is you determine the appropriateness of medication based on the patient's history, right? Which could include tolerance, comorbidity, prior health conditions, et cetera, right?
Correct. And their response to the medication.
And their response to medication. Conditions with respect to Bonnie Austin, acute conditions. She obviously had respiratory arrest, correct?
Yes.
She had cardiac arrest after the EMS arrived, did she not?
Right.
And then she had 5 preceding, or 5 more.
Right.
And CPR was required on her.
Yes, and she had her chest tube to fix that problem.
And did you note also that she has stage 4 chronic kidney disease as
Yes.
well? Is that right?
Yes.
She has COPD,
Mhm.
hypertension, correct?
Right.
And her pulse was 5 times by the time she was brought to the ICU. And it elevated 5 times as measured by the time she finally got to ICU unit, Mount Carmel West, right?
Right. When your lung collapses, your pulse is going to go through the roof. Yes.
It was like sky high, right?
Yeah, sure. That's a good response, an appropriate response.
And the chaplain note with respect to Bonnie Austin said, and I note the chaplain note, it said, quote, she was actively dying. Did it not?
I don't remember that note. Can you put it up there?
Sure.
Which is verified.
Oh. Bonnie Austin. While he's doing that, her blood pressure. Oh, I'm sorry. And even then, Dr. Tom Brady further says, quote, she's actively dying. Do you remember that?
Yes.
And Tom Brady was one of the doctors that had eyes on Bonnie Austin at Mount
Yes.
Carmel West. And I think this is, Bonnie Austin was the one where her blood pressure, she's extubated, fasting pressures are turned off, and the blood pressure couldn't even be recorded because they couldn't even get blood pressure. Do you remember that?
Right. That's not unexpected when you have a collapsed lung.
And so her respiratory rate was noted as a 5, and her pulse was a 39. Do you remember those notes?
Right. But in my memory, those things were fixed once her chest tube was placed. She had an acute fix of the chest tube of the collapsed lung, and then those vital signs corrected themselves.
Okay, tell me if she's extubated at 2330, the blood pressure issue that I just mentioned, your belief would be that it's before that. Is that right?
It may have occurred again, but initially her vital signs were corrected with the chest tube. I thought that's what you were referring to.
Yes.
Maybe you were referring to a different time.
Yeah.
Yep. Okay. I'm finding the Tom Brady doctor and the chaplain note.
Okay.
Just give me 1 minute. When I say I'm finding.
Yeah.
Clearly not. Showing you what's been marked as defendant's exhibit, Eli 18. And these code sheets appear to be related to Bonnie Austin. Is that true?
Yes.
Okay. And 9/13/18, CPR 19/18. Does that seem correct?
Right.
Okay. And this goes to 1959.
Yes.
And then there appears to be a heart rate sheet. And it goes on, it appears to 2028.
Okay. Yes.
Heart rate sheet. And it appears to go on to 2047.
Yes.
Heart rate sheet. Is
Yes.
that correct? And it's noted up here that she survived and she's transferred to 4H112.
Right.
Do you happen to know the floor of the ICU unit
No.
at Mount Carmel West? Showing what's been marked as Joint Exhibit 10, page 10. Does it look like that this history and physical sheet is authored by Tom Brady?
Right.
And it indicates that the reason for admission or chief complaint is what?
Oh, cardiac pulmonary arrest. But this note doesn't support, it doesn't agree with what you said earlier.
I'm sorry, what?
I thought you said earlier that his note prior to her being taken off life support was that she wasn't doing well. But this one is after she's already removed and received the fentanyl. It says she's having agonal respirations, but it's after the ET tube has already been removed as part of the care de-escalation. So that's a comment about what she would look like after she'd received the fentanyl and was taken off the life support, is the way I'm interpreting that.
Okay, so I'm looking at this note right here. Is when I examined the patient, the ET tube had already been removed as part of the de-escalation and comfort measures, right?
Right.
She was having
agonal respirations and had no heartbeat.
Right, because
Okay.
she was given 600 of fentanyl, and then those medicines stop her heart and her rebreathing
Well,
to some degree.
let me ask you this then. So we have another doctor laying eyes on a patient that knows she's been given 600.
He didn't say that he knows what she's been given.
Well, he says he examined the patient
Yeah, but
after
that
the
doesn't-
tube has been removed, right?
Yeah, but I walk in a room all the time and I don't know I don't always know what somebody just received before I walked in the room. He doesn't tell you there that he knows what she was given.
Okay, but you know what he does say though, is that she's struggling. She's having respirations, right?
She's having agonal respirations.
Right. And that's noted right there, right? And doesn't it also say the ICU team and chaplaincy are working with the family? She is actively dying, right?
It says the ICU team is chaplaincy are working. Yes, she's actively dying.
She's actively dying.
And that's exactly what somebody would look like if they were trying to breathe after having been given a medicine that would prevent them from breathing.
So this is a good point. So, because I just need to understand this. Dr. Husel ordered the 600, right? That's on the order sheet.
Right.
And then Dr. Brady is bedside while the 600 is administered.
I don't know. I don't know when he got in there.
Yes, you do.
Okay, is that a question?
We have Dr. Brady coming in. We can talk about what you said.
Where's the number? Yeah. Thank you. When I examined the patient, so we know he's in the room as part of the de-escalation and comfort measures, right?
Right.
And this is a Dr. Brady note.
Yes, this
That's
is
just my question. It's Dr. Brady that's
Dr.
writing the
Brady
note?
note. Yes.
Bonnie Austin, showing you it's been marked as Defendant's Exhibit BA2. It appears Bonnie Jean Austin. Would you agree with me on that?
Yes.
And time of death is noted as 23:53.
Yes.
And the reason that the listed reasons, causes of death, immediate and otherwise, are listed as what?
Tension, pneumothorax, and COPD.
I want to show you what's been marked as Joint Exhibit 10, page 6 through 7. Does this appear to be a record, a discharge summary with respect to Bonnie Austin?
Yes.
And does it appear to be signed by Thomas Brady?
Yes.
So we can assume that because he's doing the discharge summary, he's her attending physician.
That's right.
Correct? Is that right?
Yes.
Okay. And he writes here, does he not? There's a list of acute final diagnosis.
That's right.
And as part of the discharge summary that Dr. Brady wrote, it includes the vent withdrawal time,
Yes.
the time of death,
Yes.
and then it also includes, does it not, the medications that she is given, as well as a summary.
Yes. Can I see the list of medications?
Sure.
Where's the fentanyl?
Oops, sorry, let me scroll it up. Can you give me page 8, please? It's what? Do you see that? And let me go up here while we're getting that. COPD was brought, this is a summary right here, correct?
Right.
And history was taken from the chart. The last sentence says the family has decided to de-escalate care.
Right.
And the time from the vent withdrawal to the time of death is what?
About 30, 23, 25 minutes.
And actually, you know what I'm realizing, Dr. Eli? These are medications that she was prescribed prior to coming to Mount Carmel West.
Okay, because that's the point, is that I don't see any documentation in a single medical record of any other doctor saying that they were aware of how much fentanyl these people were getting. That's the big mystery. Nobody has said to me, I know how much they got, except for Dr. Husel. So that lone wolf clan thing kept coming to my mind, actually. Like, is he the only one who's paying attention to the fact that he's giving them these large doses and they don't know?
Okay, so, and I know we've covered what a discharge summary is, but you would agree with me that right here, Dr. Brady writes, history was taken from the chart, right?
Yes, but that does not mean that he knew how much drug she was given.
Okay. In the patient's chart, is a medication order form?
Yes.
Okay, is a MARS, a medication administration?
It's all there, but it just depends on if somebody might not review them to do the discharge summary. If the person has a straightforward cause of death and they think, oh, this is the emphysema, they're not going to go search all the MAR to see the exact doses they were given at the end of life, because nobody would ever expect for somebody to be getting this much medication. So you wouldn't even go looking for that. It would just be so out of your head as a possibility.
It's the last medication, and you would agree that you're not the attending physician on any one of these cases, correct?
That's right.
And you didn't talk to Mr. Brady nor any other attending physician.
Right. I'm looking for evidence that they knew how much they were getting, and I don't see any.
Well, the nurse knew when they administered it.
They did.
Okay. And on the orders that were verified by the pharmacist, they knew.
Objection.
Okay,
I think
it's
that
on the floor. You're going to reiterate, sustain, rephrase.
Okay? Jeremiah Hodge. Thank you. This was the 57-year-old woman that came to the ICU and she never regained consciousness, correct?
yes.
And you testified that she was unresponsive and in continuous coding. Does that
Can you
sound
put
familiar?
the sheet up there, please? Can I see the sheet?
Oh, sure. Can you print it for me, please? I've lost the report, so that's. Just Jeremiah. We get it. Yes.
His report on that.
Thank you. Appreciate it. Team effort. Jeremiah Hodge. There we go. This is a 57-year-old woman. Does that ring a bell?
Yes, definitely.
And I think that you said on direct that she had a big bad heart attack. Do you remember saying that?
Yep.
Okay. And just again, marking this. Jeremiah Hodge, 4/1/18/2108. Her code sheet. Marked as defendant's exhibit Eli 19. Code sheet 2108 went on to 2114. Does that look about right?
Yes.
Okay. And I want to make sure it's not that clear, but the
Okay.
physician signature, and if you can't make it out, I certainly would.
I'm assuming that's Dr. Husel.
Okay. And certainly, would you agree with me that 2108 is generally a night shift time?
Yes.
Just want to go through with respect to her conditions. She had lost her pulse several times, correct?
Yeah, can you put the sheet back up there, please?
Yes, the sheet needs to be there. Oh, nope. Give me 1 second. How's that?
Yeah, that's up.
She was found by the EMS to be, how do you say that? Asystolic?
That's asystolic?
Asystolic, right? And she
Yes.
was still that way when she got to the emergency room.
Right.
Most serious form of cardiac arrest, is it not?
Right.
And the EMS was doing CPR, but they couldn't get her pulse back. And again, she never regained consciousness. Is that correct?
That's right.
Okay. And with respect to just the measures to consider, that she was noted to be obese,
Yes.
And she had 5 organ system failures,
Right.
had lactic acidosis,
Right.
and low pH, her level was 6.73.
Right.
And 7.4 is normal function, correct?
That's right.
She had acute respiratory acidosis, had acute kidney injury as well, right?
Correct.
She had anemia,
Yes.
elevated white blood cell count, and a number of other issues. Is that correct?
Yes.
She also had diabetes. I just note that. Is that right? It is noted, was it not, in the file that not by Dr. Husel, that she had, quote, a poor prognosis and was in critical condition. You would agree
Right.
with me on that?
Right.
And Dr. Husel, if you recall, is the one that actually starts CPR on her when she's in the ICU. Do you recall that?
Yes.
And he increases the vasopressors from a 20 to a 50.
Right.
So when you increase the vasopressor, would you agree with me that you're trying to help someone and not trying to hurt them?
Yes.
Tell me why, and I mentioned the diabetic, because someone being a diabetic is an important factor to consider when generally determining the appropriateness of the medication. Is that correct?
Yes.
Showing you what has been marked as defendant's exhibit JH2. Does this appear to belong to patient Jeremiah Hodge,
Yes, it does.
age 57, just to
Yes.
reconcile it? And as noted on the death certificate, the causes of death are what?
Multi-organ failure, cardiopulmonary arrest, and diabetic ketoacidosis.
And what's ketoacidosis?
That's just when your diabetes goes awry and you built up a lot of acid in your blood.
And that indicates the interval time on that is indicated as day, and the other 2 is hours. Would you agree with me?
Yes.
We have 3 more. I see the finish line, and I know your flight. But it's also important. Francis Burke. Just want to get your report so you have it. Francis Burke was, and I'm getting it, doctor, 73 years of age. Does that sound familiar?
Yes.
And as I'm pulling that, before 6 months before she came to Mount Carmel West on the most immediate hospitalization, she had a pulmonary embolism, had she not?
Yes, she had.
And she is also in her medical records noted as obese.
Yes.
And the notes indicate that she had a devastating intracranial hemorrhage
That's right.
and acute respiratory failure.
Yes.
Is that right?
Yes.
To show you what's been marked as defendant's exhibit FB2. Does this appear to be the death certificate of Francis Burke?
Yes.
Okay. And kind of to just state it, fair to say she just had a brain bleed? Is that a common way to say it, doctor?
Yeah, she had brain bleed.
Okay. Because of the fancy words, I just want to, the visual, she had a large intracranial hemorrhage, meaning she has a brain bleed, right?
Right.
And don't the medical notes indicate that or rather, let me ask you, that the brain bleed was so bad that it's that it can cause one side of the brain to press on the other side of the brain, which can cause death, right?
That's right.
Her death certificate here, causes of death, if you could just read those that are listed on the certificate.
Right. Acute intracranial bleed, oral anticoagulants, and pulmonary emboli.
What are anticoagulants?
So what happened was she got a blood clot weeks, I don't know exactly the time, but sometime remote from this. She needed that treated with a blood thinner to allow the body to break down that clot. That's an oral anticoagulant. It's something that makes your blood thin. In this case, the drug, the oral anticoagulant, caused a bleeding problem. So instead of doing just good for the blood clot in her chest, it actually created bleeding in her brain. And that's a good example of why a drug is included on these sheets. In this case, it's part of her disease process. The drugs won't be included if they're later in the process necessarily.
And I mentioned the pulmonary embolism that she had 6 months prior. That's noted on the death certificate, is it not?
Yes.
Then it just says emboli.
Yes.
Okay. And there's no time associated with either of the anticoagulants or the embolism.
That shows the inaccuracy of people filling these out. There should be times there. It's just a mistake.
Well, and your report has some mistakes in it because people aren't perfect, right?
That's right.
Want to just show you what's been marked as Joint Exhibit 6, page 13, with respect to Ms. Frances Burke.
Excuse me.
No, damn it, I'm sorry there.
Just talking about her current condition. Would you agree with me that the author of this progress note associated with Frances Burke appears to be Dr. Wooten?
Yes.
And we know that she expired on 1/14/2018, correct?
Yes.
Okay. And this note appears to be the day prior.
That's right.
And I just want to go through it with you that Dr. Wooten is indicating that he had a family meeting with the husband and multiple family members, correct?
That's correct.
And he showed them the image of the CT, so of her head, did he not? And explained the findings that neurology believes there's nothing that can be done for her.
That's correct.
And the words say not salvageable.
It does.
In the very small chance that she were to survive this, the potential of complete neurological recovery is essentially nil. Right?
Right.
And doesn't it appear from his note that this is information that he's sharing with the family?
It does.
And he goes on to say in his charting, I emphasize to them that the massiveness of the stroke will ultimately lead to a brainstem herniation, which will cause her to go into cardiac arrest, leading to further neurological damage.
Right.
And neurological damage is more brain damage, right?
That's right.
And then lastly, the family does not want the patient to receive chest compressions, which you know she would not want, especially since they understand that her condition is irreversible.
Correct.
Correct? And that's on 1/13/2018.
Right.
Showing you what's been marked as Joint Exhibit 6, page 181. The next day on 1/14, when the 1,000 micrograms of fentanyl is administered, I just want to note, and again, I know your ongoing testimony with respect to 10s, but the pain score is noted by Nurse Dreyer to be a 10. Am I correct?
Yeah.
I'm sorry, what was your answer?
Yes.
Anything else on that? Sandra Castle. Just need the report. Sandra Castle, here's your report.
Okay, thank you.
80-year-old woman, correct?
Yes,
The conditions that she also had, I want to go through them because when you talk about sort of what the patient could have done or how she could have lived, she had systolic congestive heart failure, correct?
right,
Pulmonary hypertension.
yes,
She had stage 3 chronic kidney disease,
yes,
COP,
yes,
diabetes,
yes,
hypertension.
right,
The paramedics, as indicated in her medical file, had documented her ventricular fibrillation, correct?
right,
Cardiac arrest, right?
correct,
Cardiomyopathy.
right,
She also, again, in the medical records, it's noted that she's morbid obesity.
yes,
Her BMI was noted to be 45.
yes,
And then she had a shock, likely cardiogenic,
yes,
and she was found unresponsive at home.
right,
Certainly, Ms. Castle doesn't come to Mount Carmel West as a healthy patient. Would you agree with me?
I agree.
One moment. Thank you. Showing what's been marked as defendant's exhibit S as in Sam, C2. Does this appear to be the death certificate of Sandra Castle?
Yes,
And again, just to orient ourselves, age 80.
yes,
And it appears there's only one cause of death listed here. And what is that?
anoxic brain injury,
Anoxic brain injury.
right,
And it indicates duration of time, as indicated on the form, is days.
that's right,
Prior to the palliative extubation, Sandra Castle, in her time at Mount Carmel, had received 6,000 micrograms of fentanyl in 3 days. Does that sound accurate?
yes,
Okay, I've got to stop.
Okay.
If he's going to make his flight.
Okay.
Okay. Ladies and gentlemen, I'm going to excuse you for the day. I'm going to get the doctor on the road, so to speak. So we'll get started at 9 o'clock in the morning. We'll be doing it by Zoom. It's just as if you were on the stand to the best of your ability. You've had a chance to watch him here in the courtroom. We will see you in the morning. Remember the admonitions, David?
All rise.
Have a good evening, guys. I hope you guys got it set up for him. Yeah.
thank you, Judge.
Well, be available tomorrow morning. As they have you a link.
We will need to get the court to send them a link, and we'll send it to you and have.
Okay, you'll send me an email with the link?
Yes.
Okay.
Are you available right now?
Yes, I'll be available whenever you need me.
Okay.
Yes, I do.
Okay. Anything for the record?
Yes, Your Honor, but we'll wait till the witness leaves.
Ms. Sawyer, anything for the record?
Nothing for the record, Your Honor.
Ms. Menashe?
Yes, Your Honor, thank you. Your Honor, and I found myself susceptible to it. Obviously, I'm rushing at the end. And whether anyone thinks I've gone on too long or not, I think it's hard. No one could really argue that this isn't a critical witness to either and or both sides of this case. I do have to tell you that we just object to having to question him further on Zoom. And I don't think that anyone could say that I didn't try my best to complete it. I
think we would have no objection to having him come back at a different time, a different day. But, and I see your reaction, Judge, but Zoom with this many documents. Oh, but just this many documents, I just think he knew that he was going to be an expert in this case. He's getting paid $750 an hour. Find a time when he can come back.
Your Honor, we addressed this up front as whether we were bringing him in person or going to do the entire part on Zoom. We addressed the fact that he would only be here for one day. Would they be able to do that? Otherwise, we would have just left him in Tennessee and done it via Zoom. I mentioned the fact that he's an ICU doctor, has patients, which he said he has appointments for tomorrow, and that he is the caretaker of an adult brother who has Down syndrome, and so he can't be away from home for long periods of time. And the defense at that time indicated that you got the kids during the day, and if not, finishing enough on Zoom would be appropriate. The one thing they had asked was that they have the equal amount of time in person, which they did, Your Honor. In fact, I believe they had a few minutes more than I had.
Your Honor, I can just say that I did not agree to where I am today. All I can tell you is what I'm telling the court now on behalf of Dr. Husel is I think this witness needs to continue in person. I can tell you that if the state had proposed ever to initially call him by Zoom, we would have objected to Dr. Eli being called on Zoom. Dr. Swanner, prime example, we litigated that issue well in advance. He's sick. We understood that. We had lots of options, and we elected to do a Zoom with Dr. Swanner from start to finish. We know that. This is different. This is, it's hard to imagine they wouldn't say or concede this is their biggest witness. I did my best to get through it. There are 14 patients. I did not try to linger. I'm like, the whole team's trying to work with me here. So I don't know when it is or when he can come back, but he is being paid $750 an hour. And I would ask that he be brought back for the remaining cross and any redirect, which I would imagine would be of length. And it just doesn't seem unfair to me with a man's life on the line.
Okay, first things first. I've listened to both sides. We went over this last week as a solution. Now, if you're saying that you absolutely have to have him live, tell me why.
Well, Your Honor,
Because you had a chance to confront him, okay? The Zoom isn't going to change the testimony in any way.
Your Honor, I think as indicated by the mess that is created around me is this is a very document intensive witness. The Zoom becomes fragmented with a lot of documents. It's also, as evidenced by the last 30 minutes, the kind of case where he says one thing, we instantaneously pull a document. It's not like I had all these documents prepped, right? We're trying to be responsive to the best of our ability. I'm going to own, if you say we discussed this already and you say, Ms. Venasci, you didn't object like you are previously, I'm going to tell you I didn't. But I didn't really know until right this minute and this afternoon and today that Dr. Ely would present as he does. And I think he should be here in person.
Okay, was he ever deposed in the civil cases?
No.
Ms. Sawyer?
Again, Your Honor, this was specifically addressed last week. I named Dr. Ely as the witness that would be done. They agreed we could do it one day live and then finish out with Zoom. Dr. Hagris, we all both introduced a ton of exhibits with him via Zoom, and it went fairly smoothly. I don't see any difference here with Dr. Ely. And again, this was addressed up front. And we had agreed previously that any witness who wanted to testify via Zoom due to the conditions and everything else would be acceptable. We brought him in specifically because of what his role is, with the understanding it was one day, and they agreed, as long as they got equal time that the state had, we could finish up on Zoom.
Anything else?
Only because we're allowed to speak one at a time. Mr. Bias handled this issue with the court when it was first addressed, and I believe that his objection was that as long as
we were live, if they were on Zoom for redirect. We had no issue with that. I just want to say again, I clearly sped up towards the end, and I did so, and I'm putting this on record. It's not a good look optically in front of the jury with me rushing through patients. It's not, but I wanted to do as much as I could in person. I'm just telling you, Your Honor, let's just do this right and do it best practice. I don't care when he comes back. We're going to be here for 8 weeks.
Your Honor, for the record, we addressed this twice. Once with Ms. Menashe, where she said it's acceptable, and one with Mr. Baez, where he said the same.
See, he's different than Dr. Hagris.
Correct.
Okay? Dr. Hagris is a fact witness. This is an opinion witness. I want a minute to think about it.
Well, Your Honor, he's expecting a Zoom link for 9 in the morning. How do you want us, we'll need to get Darcy.
I don't know yet, okay?
Okay.
Give me a minute to think.
Okay, I'm sorry. I thought you wanted to think overnight.
No.
I apologize, Your Honor.
No, I want to think this through for a second. Plus, I want to stretch my legs. Okay, we're off the record for a minute.
Jaime?
Cassie, will you stick over here as well?
Did you get the Tracy Young that I marked?
What do we know is CD 15?
You come forward and take Mr. Zion's seat so I don't have to look across the room.
I can stand next to him, Your Honor.
Okay, that's fine. Ms. Menashe, how much more time do you have in examination?
Your Honor.
Roughly, I know you can't have a crystal ball, but give me an idea.
I'd say an hour to an hour and a half. I would try to be an hour.
And you have to ask her about the remaining 2.
Yes.
Anything else?
Yes. But I don't think I need to.
You don't have to give me a foreshadowing.
Yes.
I can only imagine if it were me that what I would be asking, but that's beside the point.
Yes, I haven't yet gone through my notes and circled back about other things that he said that were not either patient specific or in line with my intro comments about his articles and his accuracy, et cetera. So yes. And I also don't want anyone to say that I've held myself to an hour. So I just want to say that as well.
In my mix, I'm guessing it's another day on the stand between the two.
Your Honor, it'll depend on the rest of her cross, because right now I don't have much more than maybe an hour on redirect, if that.
Okay. Were there durable power of attorneys and living wills in the medical records?
In a few of them, I believe there are, Your Honor. I don't know about every single one of them. Diane, do you recall? I don't remember. Of them all.
Actually, power of attorneys in the medical records. I don't think in all, but in some.
Some, yeah.
Some were there? Because you alluded to it twice.
Oh,
Yeah, there are a few of them
there are
definitely. in
definitely
there.
a few.
Okay, but you call them power of attorneys.
I'm sorry?
They're durable power of attorneys.
Oh. Okay.
Sorry. They're a different thing under the statute.
Okay.
Okay.
Well, that just added an hour and 2 minutes to clear that up.
I hate to introduce the jury, but let's bring him back live another day in the future. You coordinate his calendar,
Okay.
okay?
And Your Honor, I know it will not be March 11th through the 18th, because I will not be here to handle him then.
Okay, well, we're kind of stuck,
Yeah.
okay? I mean, I understand the fluidity, I understand the situation, okay? He's a very important witness. I think live in the courtroom is important. So I'm going to agree with the defense on this one. You can tell them that I changed my mind. I don't care. But in all fairness, they've watched him live the whole time. I think it's also important they see him live during a redirect.
Your Honor, again, I just note our objection because this was addressed twice in advance. So I appreciate what you're saying, though. Thank you.
I understand trials are fluid. Okay, they ebb and flow. Okay, so we're going to go with that.
Okay,
So have a new witness on tomorrow morning.
absolutely. And I will give him a call and let him know what's going on.
Okay, and we'll try to adapt to him. If we can only fit him in on a Friday, we'll give up one of our Fridays to get him done.
Let me call, he probably,
But tell him it's not my preference.
sure, absolutely.
Okay,
I will call and let him know not to expect Zoom tomorrow, and I'll work with him once he gets back in his office to figure out a day.
okay. Anything else for the record?
Yes, Judge. I apologize. I realize it's late in the hour, but I feel I have to bring this to the court's attention. During the cross-examination of Dr. Ely, at the point when we were discussing the patient, Bonnie Austin, Ms. Menachie was going through an exchange with Dr. Ely in reference to Dr. Brady. At that time, the prosecutor, Mr. Zion, decided it was prudent to mention and say out loud to Ms. Menachie while she was cross-examining Dr. Ely, that Dr. Brady is going to testify. We can just simply ask him.
He did do that.
This is the second incident that we've had where prosecutors are blurting out from counsel table extrajudicial statements that are highly improper because they are clearly being heard by the jury. In essence, his comment basically is don't listen to this line of questioning because Dr. Brady's going to testify. Yesterday, or the day before, I'm sorry, or the previous incident number one, it was the defense lawyer is wrong, therefore you don't trust him. I don't think the court's admonition to the prosecution was, a deterrent enough to prevent this incident from happening. Aside from it being highly improper, this is William Husel's only jury in his day in court. He deserves a trial where prosecutors are not engaging in this type of behavior where they're making statements of their, either their opinions or what their interpretation of the evidence is. It is highly improper, and I think it warrants at this time a much clearer admonition by the court, not only to the prosecution, but to this jury, that they are not to be listening to what the prosecutors say at counsel table. I recall your I guess your curative was general in nature, but one time we have a slip up, 2 times it's a pattern, and 1 time alone is enough, in my opinion, to convict a man if there's anything that sticks with the juror's mind, and it's just simply not acceptable to the defense. I don't know where that type of conduct is acceptable, but I certainly don't think it's acceptable in this court, and I would ask that the court address the matter a little bit more stringently this time around.
Okay, well, if we're going to go down this line, what's your empirical evidence that you're prejudiced?
I'm sorry?
What's your empirical evidence? What are you basing, you saying you're prejudiced?
The prejudice is that the prosecutor is in essence saying, don't listen to this line of questioning because Dr. Brady is going to take the stand and you can simply ask him. Now, his comment, of course, I'm extrapolating on that, on what he said, but his comment was, Dr. Brady is going to testify. We can simply just ask him. And that's in essence what he is saying when he makes a statement like that. Now, if that's his personal belief, that's fine. He's more than entitled to keep that.
You're upset because he doesn't want them to listen to him because the doctor's coming on.
Correct.
Their witness.
No. Ms. Menashe's questioning to this witness.
Well, I think everybody knows that Ms. Menashe knows how to ask questions. Okay? So, okay. Suzanne?
Yeah, Judge, the mistake was your rule about the person that has the witness makes the objection. If that had been my witness, I would have stood up when she solicited hearsay about what Dr. Brady saw or knew. I would have said, objection, Your Honor. We can hear from Dr. Brady to come in. This is hearsay, like I would with any other objection. And then if we needed to approach to talk about it further, we would have. That was my mistake because it should have been Ms. Sawyer's objection. So I apologize for that. And so that was a mistake to say objection. And that's how practicing in front of you, objection, you state the reason for it. And that would have been the objection. So I don't think there was anything inappropriate other than it wasn't my turn to make objections. So I would also reiterate what the court says. I mean, it gets heated over here. I mean, they get heated over here too. If we're going to put things on the record, and you've made note of this too, Judge, in previous things, the noises and I'm not trying to impute anything on the defense, but when he was talking about, things happening in a night, I mean, I get it. It's an emotional thing and things blurt out, but it's nothing that warrants any type of sanction or any type of anything to the jury. I mean, the jury knows what's going on here. So that's just for the record from the state's point of view. Thank you.
Mr. Baez?
I just simply, again, I guess Mr. Zion's retort to my statement is that he would have exercised a speaking objection and given some commentary as to why he thought that line of questioning was improper on Ms. Menashe questioning a witness about what the medical records say. So in essence, don't pay attention to these medical records. Dr. Brady is going to come in and testify. Again, I don't see how it's completely improper. If the prosecutors have a specific incident that they want to bring up, they're free to do so. But we're not sitting 3 feet away from the jury in this case. They are. And if they're going to sit that close to the jury, they need to control themselves. And that's just simply put it. And that's no shot at these prosecutors personally, I like them all, but I don't like them enough to allow them to make extra comments to this jury while my client is standing trial for murder. So I think it needs to be addressed, and this is the second time we've had this come up. What are we going to wait for, a third or fourth, until we get to the point where perhaps Dr. Husel's not getting a fair trial? I simply don't want that to happen, and I don't want us to be in that position. I think this needs to stop, and it needs to stop immediately, and that's my 2 cents, Judge.
Okay. Suzanne, you were not on the floor. You know my rule.
And I apologize, so that's why I kind of like, but had I been, that's all I was trying to do is.
You know you don't do walking objections with me.
What's that?
You don't do the walking objections. She should have objected hearsay and that'd been it.
Yeah, and
Okay, but that's between you two. It shouldn't have come out like that because you went above and beyond. We won't have this behavior again,
I apologize, Your Honor.
okay?
It's
Because
just-
next time I'm gonna start sanctioning,
Yes, sir.
okay?
Yes, sir.
That goes to everybody. If you're not on the floor, you don't talk. It's the benefit of the jury, okay? They're the ones who have the right to hear this, and if I got a bunch of people talking, irregardless, if you guys need to speak, then let's go sidebar. But one person's on the floor, and the behavior stops, okay? 2 days in a row. Last one was last Friday. Okay? Unless you're gonna make some motion at this point in time, I don't think it's there. I think we can cure it with this. I don't know the extent with the jury. I might have to do something. Here, I'm playing Russian roulette with 5 bullets. If I mention the jury tomorrow that blurted out yesterday, am I re-informing it? I don't think you want that.
I understand the court's position, and I'm not trying to make more of this than what it is. So what we will do is we'll take the evening to discuss it amongst the team. And if I feel I need to make a formal motion, I'll do so in the morning. If not, I appreciate the court's attention to the matter.
Okay. Anything else?
Nothing further from the defense.
Sawyer?
Nothing on behalf of the state, Your Honor.
Okay, have a good evening, 9 o'clock promptly, we'll start. Don't roll in here at 5 till, I have to go to the bathroom.